Last 10 seconds. And we move to the next question. Identify the drug being given in the image to a 20-year-old patient with transfusion-dependent thalassemia and cardiac iron overload. Last 10 seconds. Question 5. Identify the test shown through animated figure below. Last 10 seconds. Mention the AML subtype with these classic morphological findings. Last 10 seconds for this question. What is the utility of marked part in the picture? Last 10 seconds. "62-year-old male with vasculitis and nephropathy. With the help of picture below, give your diagnosis." On left is the peripheral smear and right is a special test. Last 10 seconds. The revised cutoff for plasma cell leukemia with respect to percentage of plasma cells in peripheral blood is A 5%, B 10%, C 15%, or D 20%. Last 10 seconds. Five years, male with leukocytosis and increased blast in peripheral smear. Flow cytometry shows blast with positivity for CD33 bright, 64, 14, and 11C. Identify and mention the name of cytochemistry stain shown in the picture below. आप पूरा 60 सेकेंड का करें. We'll move to the next question. Identify the events shown in picture below related to carcinogenesis in acute lymphoblastic leukemia. The clue is in the picture. You have to identify carcinogenic event. If people cannot see, I am reading out. First picture says single catastrophic event in cell history, tens to thousands of chromosome fragment, aberrant repair, deletion occur, cancer. Should I repeat? As suggested by other quiz masters, we'll give 15 more seconds for this question. Identify the drug hidden in yellow box. I am derived from a five-petaled beautiful flower first found in Madagascar off coast of South Africa. My twin brother was first tried in mice with diabetes mellitus, but in fact they developed abscess with leukopenia. I don't kill, but I poison the spindle. A liposomal formulation of mine is available since 2012. Who am I? Name this form of therapy. Options are CAR T, bike, allogenic NK cell. Which of the following component has maximum weightage in CLL IPI score? A. TP53 status, B. IGHV mutation status, C. beta 2 microglobulin, D. clinical stage, or E. age? Question 16. Which of these TKI, tyrosine kinase inhibitors in CML, has the highest risk of arterial occlusive event? Options are A. Ponatinib, B. Bosutinib, C. Imatinib, and D. Nilotinib. We are halfway through. Most common cytogenetic abnormality in a lymphoma, which is CD20, CD5, and cyclin D1 positive, kappa restricted, but negative for CD23 and CD200. Options are A. Translocation 1114, B. Translocation 414, C. Translocation 1418, and D. Translocation 814. Last 10 seconds. Next question. A 50-year-old male diagnosed case of ITP, immune thrombocytopenic purpura, was initiated on steroid and dapsone therapy. After 6 hours, he collapsed. His oxygen saturation is 75%, ABG pH 7.4, PO2 114 by PCO2 35, HCO3 26. Need ventilator support. Nurse tells that his blood color is different. That's shown in the picture. What treatment would you recommend? A. Plasma exchange, B. Dialysis, C. Methylene blue, and D. Intravenous methylprednisolone. Last 10 seconds. Which mutation is associated with this morphological finding? A special stain slide is provided to you. You have to tell the mutation. ASXL1, NPM1, SF3B1 or EZH2. We move to next question. Which drug used in the treatment of AML has been added to the saline bag for infusion? Last 10 questions to go. Which of the following is newly approved TGF-beta superfamily ligand trap for beta thalassemia? Options are A. Sotatercept, Luspatercept, Voxelotor or Roxadustat. Next question. A 6-day-old term male neonate born of third-degree consanguineous marriage presented to the outpatient clinic with spontaneous occurrence of lesion on bilateral feet. Image is provided. His mother had a history of cortical vein thrombosis during the previous pregnancy. What is the likely diagnosis? A 52-year-old male film actor presented with fatigue, low-grade fever since 1 month. Lab findings are hemoglobin 7.2 gram per deciliter, TLC was increased to 18,000 per microliter, and there was thrombocytopenia. Peripheral smear revealed 42% blast, bone marrow and flow cytometric immunophenotyping suggestive of AML M4. He refuses to take 7+3 therapy offered at your center due to cosmetic concerns. He visits an oncology center in New York and sends you the picture of wine-colored drug that subsequently he receives. The picture is provided. He was told that this drug does not lead to alopecia. So you have to fill 2 answers here. Part 1 is identify the drug. Part 2 is what is its composition. I'll repeat. Part 1 is identify the drug. Part 2 is what is its composition. Question 24, a 48-year-old patient with a relapsed diffuse large B-cell lymphoma responds well, attains CR to second-line chemotherapy. Stem cell mobilization fails using GCSF. Which medicine can be added to GCSF to hasten the mobilization of stem cell? 6-month-old child with failure to thrive, peripheral smear showed leukoerythroblastic blood picture. Give diagnosis with the classic radiological findings provided. Which thrombophilia remains resistant to heparin therapy? Options are A. Protein S deficiency, B. Antithrombin 3 deficiency, C. Protein C deficiency, or D. Lupus anticoagulant. What is the most appropriate management for type 1 von Willebrand's disease before a minor surgical procedure? A. Mefenamic acid, B. Vitamin K, C. Desmopressin, D. Factor 8 concentrate. In paroxysmal nocturnal hemoglobinuria, paclitaxel acts by inhibiting C3, inhibiting C5, replacing GPI anchor, or enhancing CD55 expression. In relapsed multiple myeloma, which bispecific T cell engager targets BCMA and CD3? Options are provided: A. Teclistamab, B. Daratumumab, C. Carfilzomib, or D. Elrentamab. Last question of screening round. What is the current first line treatment for elderly AML patients unfit for intensive chemotherapy as per recent clinical trial? Options are A. Azacitidine alone, B. Venetoclax plus azacitidine, C. Low dose cytarabine, or D. Decitabine alone. So that was all. I request all of you to quickly submit your answer sheets. Just check you have written your names, your college name, phone number correctly, and quickly submit your answer sheets. So the results of this round will be declared post lunch. In that we'll be announcing the top 6 teams, but I highly suggest you listen all the presentation. You may find lot of your quiz questions coming from there. So pay attention throughout the day, be with us, and post lunch we'll be telling you the top 6 teams who will be playing the actual quiz, and out of them 2 will qualify for state round. Manoj sir, will the time permit? Will be able to tell them answers for this or no? So usually we tell them answers in the morning, but if time permits. Okay, sir. Okay, sir. Okay. Okay. So sir is saying in between some lectures, if time permits, we may show you answers of this screening round. Otherwise, let's let's be together throughout the day and listen all the sessions. All the best to all of you.
Yes, maybe now for sure. Yes. So good morning, everyone. Lot of energetic, enthusiastic faces in the audience. The quiz was pretty hard, I guess. Means at least to me, it felt like it was hard. So for now, we'll start with the basic topic: when to suspect leukemia in a child. Myself, Dr. Suyog Nagre. So why even talk about leukemia? That too in children. Means age-old teaching is that cancers happen in old age, and in children we don't usually expect leukemias or any cancers for that matter, right? So just to know about the problem statement, India's growth against infectious diseases has been like this. Like in 2020, like in 2000s, the under 5 mortality rate was 83 per thousand live births, which today or in 2021 it has come down to 31 per thousand live births. So this is quite a inspiring journey. The infectious diseases have reduced because of improved sanitation, vaccination programs, malnutrition has reduced, and that's why the other diseases like pneumonia, diarrhea, malaria, which used to claim the lives, those have reduced. But however, at the same time, the new challenge is emerging, which is childhood cancers. Like the every year, almost 52,000 new cases of cancer, childhood cancer are diagnosed in India. Just to compare with US data, USA has around 9 to 10,000 cases per year of childhood cancer, which in India, those are 52 to 55,000. So we are 5 times ahead of US in terms of cancer numbers. So, and also because of the increase in incidence, the increase in share of mortality, pediatric under 5 mortality is also increasing. So these infectious diseases are going down. However, the new problem is there, which is childhood cancer, and that's why we should be aware of it, right? So that's why we are speaking about childhood cancers. So in the childhood cancers, if you can see in this pie diagram, what we can see is 30 to 35% patients in the world are leukemia. 30 to 35 patients out of the total childhood cancers are childhood leukemias. Second one comes CNS tumors, and then the others like neuroblastoma, rhabdomyosarcoma, and others. So these two things form the major chunk of childhood cancers. So every year, what we say, almost 15 to 20,000 new cases of childhood leukemia are diagnosed. Again, to compare this with US data, USA has around 2,500 to 3,000 cases of leukemia per year. We have 15,000 cases per year. So the numbers are overwhelming. That's why we should be aware of pediatric leukemias, and that's why we have decided to talk about leukemia in child, when to suspect leukemia in a child. So what is leukemia and how does it develop? It will seem like a pretty basic question to you, or a very basic thing. We all know how leukemia develops, but just to brush up, I will go through it. Cancer of blood and bone marrow characterized by uncontrolled proliferation of immature white blood cells. This is the definition of leukemia. Okay. So components of blood, as we all know, we have RBCs, WBCs, and platelets, with each serving its own purpose, right? But what happens during the hematopoiesis, when the blood stem cell differentiates further, there is myeloid stem cell and lymphoid stem cell. Myeloid stem cell further gives rise to erythroid series, which differentiates to RBCs. Myeloid series, which differentiates to granulocytes, neutrophil, eosinophil, basophil, and megakaryocyte series gives rise to platelets. However, if there is arrest somewhere near the myeloblast stage, then something called as AML arises. Similarly, the blood stem cell will give rise to lymphoid progenitor. Lymphoid progenitor will give rise to lymphoblast, and then it will differentiate into T lymphocyte, B lymphocyte, natural killer cell. Again here, if there is abnormal clonal proliferation at lymphoblast level, then something called as acute lymphoblastic leukemia arises, right? So this you all know. Just to summarize, so what are the types? We just saw the types. First is ALL, acute lymphoblastic leukemia. Then this is the most common. 80% of the childhood leukemia is acute lymphoblastic leukemia. The other one is acute myeloid leukemia. This contributes to around 15 to 20% of the cases. This contributes around 15 to 20% of the cases. Then there is something called as chronic myeloid leukemia. This accounts to around 2 to 3% of the all pediatric leukemia cases. Then there is something called as juvenile myelomonocytic leukemia. This is further rare, less than 2 to 3%. Then there are other rare leukemias like mixed phenotypic acute leukemia, infant leukemias, right? But all these things, what we need to remember, first two, ALL and AML, these form the majority. The rest, other CML, JMML, and mixed phenotypic or infant, they contribute to less than 5% of all leukemias, right? So who is at risk? which child will go on to develop leukemia, right? So there is no proper answer to this question. There are certain conditions which make a child susceptible to leukemia. We call those as precancerous conditions, right? Or genetic conditions which may lead to increased propensity for leukemia. So we all know, or you must have read during your learning, like which are those? This image. Anybody remembers what is this image? In this child. So this child has hypoplastic thumb. This is the image from Nelson. It's not a very usual. Yes, this is a Fanconi's anemia child. Now this second image, can you see? The child looks cute. However, the facial features are a bit abnormal. So this is a Down's baby, right? This is a Down's baby. So Down's baby is also 20 times more prone for acute leukemias. Down syndrome is 20 times more prone for acute leukemias than normal children. Okay. So what is this? You can see something in the eye. Yes, there is telangiectasias. There are telangiectasias, and the child will come with a history of आमचं पोरगं सरळ चालत नाही, दारू पिल्यासारखं चालतं. So there is ataxia, right? So ataxia, telangiectasia, these are again more prone to develop cancers. So why? Because it is something called as chromosomal breakage syndromes. So when there is an inherited chromosomal breakage syndrome, those children are more prone for leukemias. Now you will say, why are you showing us these pictures? If the child has Fanconi, the child won't come to us. But many a times what happens, the child comes to you for the first time. You are the first one to see the child. The child won't say, I am a Fanconi's anemia, or I am a ataxia telangiectasia, or I am a Down syndrome. You have to suspect, and you have to diagnose even the precancerous condition yourself. That's why to see it is very important. So overall in leukemias, the peak age is 2 to 5 years. However, it can occur anytime between 0 to 14 years. As we saw, the incidence is increasing rapidly, and it is doubling every 5 to 10 years. Overall in leukemias, what we have seen is there is slight male preponderance, but even in the world there is slight male preponderance. In India, we say that is because male patients are preferentially shown to doctors, but it might not be the case elsewhere. Okay, but there is still a slight male preponderance. And these are the risk factors which we saw, right? Down syndrome, chromosomal breakage syndromes like ataxia, Bloom's, inherited bone marrow failure syndromes like Diamond-Blackfan anemia, Schwartzman-Diamond syndrome, neurofibromatosis 1. Also, if there is exposure to in utero radiation, that also makes the child susceptible to pediatric leukemias, and rare familial predisposition syndromes like Li-Fraumeni, where the TP53 is mutated. Okay, so this is the risk factors for development of pediatric leukemias. Now, how does the symptoms develop? Okay, we saw leukemia, how does it develop, and now how do the symptoms develop in leukemia? Okay, so the first pathophysiology is bone marrow failure, right? We saw what happened. There was abnormal clonal proliferation at the level of lymphoblast or myeloblast. Because of this, what is happening? The other series, the other lineages like the erythroid series, the megakaryocytic series, and the myeloid series, those will get affected, right? So when those are affected, what will happen? The further RBC, erythroid series, the RBCs won't form, and what you will get, the symptomatology will be anemia, listlessness, apathy, right? Even CCF. If the myeloid series gets affected, you won't have any neutrophils, basophils, or eosinophils to fight against infection. And so what we will have? Recurrent infections, recurrent fevers. And next will be the megakaryocyte series. So if the megakaryocyte series is affected, you will have reduced platelets, and then there will be easy bruisability, gum bleeding, melena, and all these features. So the pathophysiology will explain how the symptoms will develop. The other important thing is organ infiltration. आता क्लोनल इन्फिल्ट्रेशन झालं बोन मॅरोमध्ये, ते काही तिथे थांबत नाही का, त्यांना जागा पाहिजे कुठेतरी. मग ते काय होतात? स्पिल ओव्हर होतात. कुठे कुठे जाणार? स्पिल ओव्हर होणार, बोन मॅरोमधून बाहेर निघणार. बोन मॅरोमधून बाहेर निघाल्यावर कुठे जाणार? सगळ्यात महत्त्वाचं, सगळ्यात आवडता त्यांचा ऑर्गन आहे लिम्फ नोड्स. जाणार पहिले लिम्फ नोड्समध्ये. सो वी विल हॅव समथिंग कॉल्ड ॲज लिम्फॅडनोपॅथी. अँड इफ इट्स मोर दॅन 2 साइट्स, more than 2 centimeters, म्हणजे त्याचे डेफिनेशन्स आहे. वी हॅव डेफिनेशन फॉर सिग्निफिकंट लिम्फॅडनोपॅथी. 2 or more contiguous sites, cervical more than 1 centimeter, inguinal more than 1.5 centimeter, any axillary, any supraclavicular, any epitrochlear, this counts to significant lymphadenopathy. हे असं काही याच्यामध्ये खूप कॉमनली होतं, राईट. देन द अदर इज लिव्हर अँड स्प्लीन. लिव्हर अँड स्प्लीनमध्ये दिस gets infiltrated in liver and spleen, and something we have is hepatosplenomegaly or splenohepatomegaly. Bones and joints. So these lymphoblast or myeloblast, these go and infiltrate into the bones and joints and lead to bone pains. म्हणजे so much so that we have seen children who just presented with limbs. 1.5 वर्षाचं बाळ आहे आणि घरचे काय कंप्लेंट्स घेऊन येतात की आमचं बाळ चालत होतं, रांगत होतं थोडं 1.5 वर्षाचं, नेमकं चालायला लागलं होतं आणि आता थोडंसं 8 दिवसांपासून ते चालतच नाही आहे. कारण काय? त्याचे पाय दुखत आहेत. थोडेसे मोठे जे असतात 8-9 वर्षांपासूनचे जे मुलं असतात ते सांगू शकतात की आम्हाला काय होते, पाय दुखत आहेत बाबा, आमचे रात्री पाय दुखत आहेत, असं तसं जे काय आहे. पण हे जे छोटे आहेत त्यापेक्षा छोटे लेस दॅन 5 इयर्स, ते पाय दुखणं कसं सांगणार तुम्हाला? ते सांगत नाही. ते काय करतात? चालणंच बंद करून टाकतात. लिम्पिंग विक्स आहे ना, लिम्पिंग ऑर जॉईंट पेन्स. सो दिस इज ऑल्सो प्रेझेंटेशन. म्हणजे यातून मग ते इव्हन असं झालं की पुढे MRI केला जातो, आणखी ऑर्थोपेडिशियनला दाखवलं जातं आणि मग तरीही जेव्हा काही कळत नाही तेव्हा ते आपल्याकडे येतात, तेव्हा CBC केलं जातं आणि मग समजतं की अरे दिस हॅज समथिंग टू डू विथ द बोन मॅरो. सो दीज आर इव्हन द प्रेझेंटेशन्स विच कॅन हॅपन विथ दिस ल्युकेमियाज. देन CNS का सोडायचं? सगळीकडे घुसायचं आहे आम्हाला, नाही का? तो CNS मध्ये पण जाणार. व्हॉट विल हॅपन विथ CNS इन्फिल्ट्रेशन? वी विल हॅव समथिंग कॉल्ड एज डिप्लोपिया, रेज्ड ICT अँड क्रॅनियल नर्व पाल्सीज, अशा सगळ्या गोष्टी यामध्ये होऊ शकतात. Then testes, painless swelling of testes, unilateral or bilateral, can happen in leukemia. So always the examination should be thorough. So this is how the symptoms develop. Okay. So what are the common symptoms? आता हे असे यामध्ये होऊ शकतात. But what has been found? When a child with leukemia presents, what are the common symptoms with which they present? Right. So persistent fever, more than 2 to 4 weeks duration, mostly without clear source. Pyrexia of unknown origin, more than 2 weeks of fever without a documented source. He mostly as a presentation, 60% patients will come with pyrexia of unknown origin. Fatigue, lethargy and irritability, non-specific complaints आहे. Fatigue, lethargy, irritability, 80% patients मध्ये हे असेच complaints असणार आहेत. Easy bruising, petechiae or epistaxis, this will be in 40% of the patients. Bone and joint pain, severe, may cause limping or refusal to walk. This can happen in around 20% of the cases. अँड देन ॲबडॉमिनल डिस्टेन्शन ऑर डिस्कम्फर्ट, लिव्हर स्प्लीन वाढली, जेवण केलं की पोट मोठं वाटतं, एवढीच फक्त त्यांची कंप्लेंट बऱ्याच वेळा राहू शकते आणि आपण ती निग्लेक्टही करतो. राईट. सो ॲबडॉमिनल डिस्टेन्शन ऑर डिस्कम्फर्ट 60% पेशंट्समध्ये या गोष्टी असणार. सर्वायकल ॲक्झरी ऑर इंग्वायनल लिम्फॅडनोपॅथी, 50% पेशंट्स विल हॅव दिस लिम्फॅडनोपॅथी. ओके. अँड रिकरंट इन्फेक्शन्स वी सॉ, बिकॉज द सगळ्यात सिरीज खराब आहेत त्यांच्या, त्यामुळे हे सगळे सिम्टम्स त्यांच्यामध्ये येणारच. Note that the symptoms are non-specific, overlapping with viral or rheumatologic conditions. Persistence or progression is the key to suspicion. Right? Symptoms हे सगळे पिडियाट्रिक्समध्ये कोणतेही डिसीज म्हटलं तर सिम्टम्स मोस्टली हे असंच असणार आहेत. कफ, कोल्ड, फिवर, लिस्टलेसनेस, अपॅथी, काय तर जेवण कमी करते, हे करते, हे असेच तुमचे सिम्टम्स असणार आहेत. त्यातून यू शुड बी एबल टू डिफरन्शिएट वेअर यू हॅव टू गो फॉर द डायग्नोसिस. राईट. So then what should be your approach to the case? As with any case, first and foremost is proper history taking, right? So begins with the age. What is the child's age? What are the duration of symptoms, onset, duration and progression? If it's subacute and the progression is gradual, means if it's not improving despite medication, then it should alert you, indicator लागले पाहिजे की this is something which is not improving. सो हे तर आपण बघितलं सगळं, हे सगळं असणार त्यामध्ये. फिवर, बोन पेन, जॉईंट पेन, हे सगळं आहे का हे विचारायचं. रॅश आहे का, पटिचियल आहे, पर्पुरल आहे. persistence or recurrence of symptoms, this is the highlight, की persistence or recurrence of symptoms despite treatment has to be evaluated. Any need for transfusions, बऱ्याच वेळा असं होतं की मुलं आपल्याकडे येतात, पालक सांगत नाहीत काय झालं होतं. 2-4 महिन्यांआधी सर एक काही नाही, असंच दवाखान्यात गेलो होतो, बाळ खेळत नव्हतं, थोडं ब्लड कमी होतं, ब्लड लावलं, त्याच्यानंतर चांगलं होतं, 3 महिन्यानंतर परत आले, सर्दी खोकला ताप आलाय फक्त, बाकी काहीच नाही. आणि मग आपण CBC बघतो तर आपल्याला दिसतं त्यामध्ये काहीतरी पॅनसायटोपिनिया असं काहीतरी असतं आणि मग इव्हॅल्युएट केलं की निघतो ल्युकेमिया. तर हिस्ट्री ऑफ ट्रान्सफ्युजन्स ऑल्सो, इफ देर इज हिस्ट्री ऑफ ट्रान्सफ्युजन, देन व्हॉट यू नीड टू नो इज व्हाय इज द चाइल्ड हॅव्हिंग द नीड फॉर ट्रान्सफ्युजन. आयदर इट इज न्यूट्रिशनल अनिमिया, न्यूट्रिशनल आहे, or there is something to do with the marrow, right? So this history has always to be asked. Then family history of hematologic problems or malignancy. आता एक मजेशीर गोष्ट आहे, जर ट्विन बाळा असले ना, ट्विन बच्चू असले, एका ट्विनला जर ल्युकेमिया झाला तर दुसऱ्या ट्विनचे ल्युकेमिया व्हायचे चान्सेस ऑटोमॅटिक वाढून जातात. 6 to 7 टाइम्स जनरल पॉप्युलेशनपेक्षा त्याचे चान्सेस वाढून जातात. सो दिस इज अ फन फॅक्ट, राईट? तर त्यामुळे यू हॅव टू आस्क फॉर दिस हिस्ट्री, because cancers may run in families, because we know cancer आहे शेवटी काय, डिसीज ऑफ इम्युनॉलॉजी. when the immunity is not able to control the proliferation, it leads to cancer. Recent history of viral illness. मोस्ट ऑफ द टाइम्स व्हायरल इलनेसेस, डेंग्यू सगळ्यात कॉमन आहे आपला, ज्यामध्ये आपण आला सायटोपिनिया दिसले की काय डेंग्यू असेल असं म्हणून तो हे केला जातो, 2-4 आठवडे बघायचं हे ते. सो रिसेंट हिस्ट्री ऑफ व्हायरल इलनेस इज ऑल्सो व्हेरी इम्पॉर्टंट. देन फिजिकल एक्झामिनेशन. हे सगळं जे काही आपण बघितलं कॅन्सरच्या पॅथोफिजिओलॉजीमध्ये की बोन मॅरो फेल्युअर किंवा ऑर्गन इन्फिल्ट्रेशन, ते सगळे सायन्स आपल्याला पेशंटमध्ये दिसत आहेत का हे आपल्याला पेशंटच्या फिजिकल एक्झामिनेशनमध्ये बघायचं आहे. राईट. सो स्टार्टिंग कुठून होते आपली जनरल एक्झामिनेशनपासून. पॅलर, इक्ट्रस, सायनोसिस, क्लबिंग, लिम्फॅडेनोपॅथी, एडिमा. पॅलर मोस्टली असणार. इक्ट्रस वी नोट नो, मे ऑर मे नॉट बी देअर. क्लबिंग, सायनोसिस तर असू शकते नसू शकते. लिम्फॅडेनोपॅथी इज व्हेरी इम्पॉर्टंट. सिग्निफिकंट लिम्फॅडेनोपॅथी, हे पण काय आपण बघितलं, मोर दॅन 2 नॉन कंटिग्युअस साइट्स, साईज सर्वायकल मोर दॅन 1, ॲक्झिलरी मोर दॅन 1, इंग्वायनल मोर दॅन 1.5, एनी सुप्राक्लाविक्युलर, एनी इपिट्रॉक्लियर. देन ब्लीडिंग आहे का. मीडियास्टिनल फुलनेस, दिस इज द पार्ट वी मोस्टली डोंट पे अटेन्शन टू. चाइल्ड येतो आपण त्याला पहिले तर आपण शर्ट काढून बघायची तसदीच घेत नाही. राईट. कफ कोल्ड फीवर आहे बघितला, मेडिकेशन्स दिले, झालं काम. सो ऑलवेज एक्झामिन द चाइल्ड हेड टू टो, अनड्रेसिंग द चाइल्ड. राईट. सो मीडियास्टिनल फुलनेस, मोस्ट ऑफ द टाइम्स ल्युकेमियाजमध्ये काय होतं, लिम्फ नोड्समध्ये जातात, मीडियास्टिनल नोड्समध्ये जातात, आतमध्ये मास असतं, दॅट मास कंप्रेसेस ऑन SVC अँड अदर एअरवेज. राईट. एअरवे कंप्रेस झाला की तुम्हाला अदर सिम्टम्स मिळणार, व्हिजिंग, कफ, कोल्ड. पण दीज सिम्टम्स ओव्हरलॅप विथ अदर कॉमन व्हायरल इलनेसेस. म्हणजे साधं चाइल्डला URI वगैरे जरी व्हायचा असला तरी पण त्याला तेच सिम्टम्स आहेत, व्हिजिंग वगैरे. राईट. तर याच्यामध्ये पण तेच येतात. सो दिस हॅज टू बी सस्पेक्टेड. तर अशा वेळेस आपल्याला एक्झामिनेशन बघायचं. एक्झामिनेशनमध्ये काय दिसणार, SVC ऑब्स्ट्रक्शन झालं तर तुम्हाला वेन्स एनगॉर्स्ड दिसणार, त्याच्या छातीवरच्या वेन्स एनगॉर्स्ड दिसणार, आईज थोडे इडिमॅटस असणार, कंजंक्टायवा किमोसिस असणार, त्याचं कंजेशन असणार. तर या गोष्टी बघता आल्या पाहिजे. देन कंजेनायटल अनोमलीज ऑर स्टिग्मॅटा. हेड टू टो एक्झामिनेशन इज ऑल्सो व्हेरी इम्पॉर्टंट. हेड टू टो एक्झामिनेशन स्टार्टिंग फ्रॉम द हेड. हेड कसा आहे, मायक्रोसेफॅली आहे का. मायक्रोसेफॅली असेल तर फॅन्कोनीज अनिमिया आला पाहिजे. इफ द चाइल्ड इज देअर विथ मायक्रोसेफॅली यू शुड थिंक ऑफ फॅन्कोनीज अनिमिया. त्याच्यानंतर हेड टू टू एक्झामिनेशनमध्ये वरतून खालपर्यंत, त्याच्यानंतर मीडियास्टिनम आला, त्याच्यानंतर डिजिट्स आले, हात कसे आहेत, हातामध्ये अंगठा अब्सेंट तर नाही आहे, अब्सेंट डिजिट ऑर अब्सेंट रेडियस. दिस अगेन लीड्स टू समथिंग, मीन्स वी शुड थिंक देर इज समथिंग अंडरलाईंग, समथिंग मोर टू द चाइल्ड विच दॅन इट मीट्स द आय. राईट. आणि त्याच्यानंतर आणखी खाली काय गेलं तर मोस्टली एखाद्याला अनडिसेंडेड टेस्टीज असतात. त्यानंतर खाली गेलं तर लिम्ब ॲनोमलीज असतात. राईट. सो हेड टू टो एक्झामिनेशन शुड बी परफेक्ट. अँड देन आफ्टर दॅट वी शुड मूव टू द सिस्टमिक एक्झामिनेशन. सिस्टमिक एक्झामिनेशनमध्ये पोर ॲबडोमेन इज मोस्ट इम्पॉर्टंट बिकॉज ल्युकेमियाज मोस्टली इन्फिल्ट्रेट दिस लिव्हर अँड स्प्लीन. सो यू विल गेट दिस हेपॅटोस्प्लिनोमेगॅली. आणि अँथ्रोपोमेट्री, अगेन दिस इज व्हेरी इम्पॉर्टंट, अ रुटीन थिंग आहे, बट दिस हॅज टू बी डन. हाईट, वेट, BMI, हेड सर्कम्फरन्स. ओके. आता हा आपण बघितलं हे हा जो ल्युकेमिया आहे हा कुठेही इन्फिल्ट्रेट करतो, मीन्स इट हॅज प्रोपेन्सिटी टू इन्फिल्ट्रेट अदर थिंग्स. सो व्हॉट यू कॅन सी इन दिस चाइल्ड, ट्रंकवर एक मोठासा पॅच दिसतोय. राईट. कॅन समवन टेल मी व्हॉट इज इट. मोठा पॅच दिसतोय, एक दिसतोय ना. सो लुक्स लाईक अ काफुलेट. राईट. काफुलेट स्पॉट है ना. आणि त्याच्यासोबतच वरती एक ॲरोनी दाखवलं आहे, कसं एक काळा असा सर्कल आहे, त्याच्यामध्ये एक टेमकुड आलं आहे. राईट आहे ना. पण तो क्लॅव्हिकलच्या वरती पण नाही आहे लिम्फॅडेनोपॅथी म्हणायला, नाही का. क्लॅव्हिकलच्या वरती असतं तर म्हटलं तर सुप्राक्लॅव्हिक्युलर लिम्फ नोड आहे, नाही ते क्लॅव्हिकलच्या खाली आहे. राईट. तो ते काळा दिसते, दॅट इज अ इंड्युरेटेड स्वेलिंग. इट इज इन्फिल्ट्रेटेड बाय लिम्फोब्लास्ट्स. It is leukemia cutis. It is a presenting manifestation. This child went on to develop T-cell ALL in future. Right? This child went on to develop T-cell ALL in future. So this is a manifestation of leukemia. So any swelling in the body should not be neglected. Right? आपण आत्ताच थोड्या वेळा आधी डिस्कस केलं, काय दिसते याच्यामध्ये, चेस्ट लुक्स, मीडियास्टिनम लुक्स फुल. राईट. पण तुम्ही म्हणणार की बाकी कंडिशन्स पण आहेत, पेक्टक्स कॅरिनेटम, एक्सकॅव्हॅटम, रिकेट्स, याच्यामध्ये पण चेस्ट फुल दिसते, पण त्यामध्ये मग तुमचे कंजंक्टायवा किबोज नसणार, तुमच्या वेन्स एनगॉर्ज नसणार. सो यू हॅव टू बी व्हेरी थरो विथ युअर एक्झामिनेशन. तसेच त्याचे तर हाताचे पण वेन्स डायलेटेड आहेत, कारण त्याला मोठं मीडियास्टिनल मास असणार आहे. आता हा तोच चाइल्ड आहे ज्याचं आपण ते बघितलं ना, ट्रंकवर एवढा मोठा काफ्युलेट आहे, त्याचेच हातं बघितलं तर त्याला पॉलिडॅक्टिली पण आहे. राईट. सो देर हॅज टू बी समथिंग इनहेरिटेड इन दिस चाइल्ड विच इज लिडिंग हिम टू प्रिडिस्पोजिशन. आणि दिस वी सॉ lymphadenopathy, significant lymphadenopathy is very important. 50% of patients will have lymphadenopathy, will present with leukemia. This we discussed many times. Okay. Ata investigations, right? How will you proceed? We did with the history, we did with the clinical examination. Now we should go with the laboratory evaluation. First and foremost is CBC. CBC मध्ये what we'll see? We'll look for all the 3 cell lines, right? फक्त WBC, HB आणि प्लेटलेट्स या 3च गोष्टी नाही बघायच्या. त्यामध्ये आतमधल्या गोष्टी पण बघायच्या, लाईक डिफरन्शियल काउंट. व्हॉट इज द डिफरन्शियल काउंट अँड व्हॉट इज द MCV अँड MCH, MCHC अँड RW. ANC to look for severity of cytopenia, differential count, mostly lymphocytosis should not be ignored, and platelet count. Okay. आता आपली लाईफ थोडी इंटरेस्टिंग झाली पाहिजे ना, सगळं CBCतच कळालं असतं तर कसं. 40% ऑफ द पेशंट्स विल हॅव अ नॉर्मल CBC. सो अ नॉर्मल CBC डज नॉट रूल आउट ल्युकेमिया. म्हणजे तुम्ही म्हणाले आमचं CBC नॉर्मल होतं, आम्ही ल्युकेमिया डायग्नोसिसमधून काढून टाकलं. तसं नाही आहे. 40% पेशंट्स विल हॅव नॉर्मल CBC. बिकॉज वाय डज दिस हॅपन? ल्युकेमिया तर आहे, पण तो बोन मॅरोमध्येच आहे, तो तुमच्या ब्लडमध्ये अजून स्पिलच झाला नाही. तुमच्या CBCमध्ये फाइंडिंग्स येतील कुठून? दॅट्स वाय you need to have a high suspicion. If the symptoms are persistent and progressive despite your treatment, you should think of leukemias. And the child is not improving, you should think of leukemias. The next thing, most important thing, CBC should always be accompanied with peripheral smear. Peripheral smear is the snapshot of the patient's blood. It gives us the RBC morphology. It gives us if there are any abnormal circulating cells. If there is infection, you will have neutrophilia. If there is lymphocytosis, you will see if there are abnormal lymphocytes, activated lymphocytes, or there are circulating blasts. So peripheral smear has to be done for every patient in which you are doing a CBC. Right, then retic count. Retic is something which gives us an overall idea about the marrow health. If the marrow is good, it's proliferating. फीडबॅक असतं बॉडीमध्ये. अनिमिया झाला तर मॅरो शुड प्रॉलिफरेट, हायपर ॲक्टिव्ह झालं पाहिजे आणि तुमचं रेटिक कामाला लागलं पाहिजे. करेक्टेड रेटिक काउंट जो आपण म्हणतो तो तसा आला पाहिजे. सो इफ द रेटिक इज अनिमिया आहे आणि रेटिक एक लो आहे, सो दॅट वुड मीन की मॅरो इज नॉट फंक्शनिंग प्रॉपरली. सो यू हॅव टू लुक फॉर मॅरो पॅथॉलॉजी. देन LDH इज टर्नओव्हर, सेल टर्नओव्हरचा मार्कर आहे. वेन देर इज इन्क्रीज सेल टर्नओव्हर, इफ देर इज ल्युकेमिया व्हॉट विल हॅपन, देर इज ॲबनॉर्मल प्रॉलिफरेशन म्हणजे इन्क्रीज टर्नओव्हर आहे. सो यू एक्सपेक्ट अन LDH टू इन्क्रीज. And then other things like uric acid, serum calcium, phosphorus, these are tumor lysis markers. म्हणजे when the cells break, त्याचे components बाहेर येणार. So these markers will be raised again. And then chest X-ray. Chest X-ray is also very important because you can see a mediastinal mass. Mediastinal masses won't be diagnosed that way. So a chest X-ray, if you suspect there is mediastinal fullness, there are lymph nodes, so always, and there is cough cold, you just don't ignore it. If the child is presenting 2 weeks झाले, बरं होत नाही, सर्दी खोकला आहे, you proceed with chest X-ray. फक्त clinical करूनही कधी जमणार नाही. But that's why you have to go for investigations also. And the next thing will be bone marrow evaluation. एवढं सगळं करायचं. तेव्हा सस्पिक्शन वाटलं की नेक्स्ट स्टेप इज बोन मॅरो इव्हॅल्युएशन, बोन मॅरो ॲस्पिरेशन अँड बायोप्सी. ॲस्पिरेशनवर आपल्याला दिसणार सेल्युलॅरिटी काय आहे, हाऊ आर द सेल लिनियर्स, प्रिकर्सर्स कसे आहेत. इफ देर इज अरेस्ट इन मॅच्युरेशन, ल्युकेमियामध्ये काय होतं, अरेस्ट इन मॅच्युरेशन आहेत, लिम्फोब्लास्ट और मायलोब्लास्ट, ते पण आपल्याला त्यामध्ये दिसून येईल. और देर इज इन्फिल्ट्रेशन, राईट. अँड देन biopsy is also mandatory, and on this aspirate we send further investigations like flow cytometry and cytogenetics, which will give us the diagnosis, right. So this is how should we proceed with the case of childhood leukemias: history, clinical examination and lab investigations. Okay, so there are this is आपण discuss केलं की the symptoms are non-specific, vague, and they overlap with other common illnesses. So we should be able to differentiate from other common illnesses. So what are the most common mimics of leukemia? तर आपण ल्युकेमिया बघितलं आहे. आता दुसरं सगळ्यात महत्त्वाचं काय होतं क्लिनिकल प्रॅक्टिसमध्ये लेबल होऊन जातो पेशंट, तो म्हणजे आयरन डिफिशियन्सी अनिमिया और न्यूट्रिशनल अनिमिया. सो व्हॉट वी नीड टू सी इज ब्लिडिंग. हे तुमच्या याच्यामध्ये आयरन डिफिशियन्सी अनिमियामध्ये देर वोंट बी एनी ब्लिडिंग, राईट. ऑर्गॅनोमेगॅली नसणार, लिम्फ नोड्स नसणार, बोन और जॉईंट पेन नसणार. त्याच्यामध्ये काय असणार, फक्त अनिमिया. आणि CBC जर बघितलं तर देर शुड बी मायक्रोसायटोसिस, द RW शुड बी इन्क्रीज्ड. जर डायमॉर्फिक असेल तर तुमचा MCV नाही बदलणार, बट युअर RW शुड बी हाय. RW जर नॉर्मल आहे तर तुम्ही त्याला न्यूट्रिशनल अनिमिया लेबल करू शकतच नाही. सो ऑलवेज लुक फॉर RW, ठीक आहे. सो दिस इज वन. अदर डिसीज विच कॉमनली मिमिक्स इज ITP, इडिओपॅथिक इम्युन थ्रोम्बोसायटोपेनिक पर्प्युरा. याच्यातही ऑनसेट सडन आहे, याच्यात पॅलर असू शकतं नसू शकतं. ब्लिडिंग याच्यामध्ये असणार बिकॉज प्लेटलेट्स आर लो. ऑर्गॅनोमेगॅली नसणार, द चाइल्ड शुड बी वेल. lymph node should be absent, bone and joint pain will be absent, and CBC मध्ये you will have only thrombocytopenia. Anemia can be there because of bleeding, but most of the times it's only isolated thrombocytopenia. The other is JIA, juvenile idiopathic arthritis. याच्यामध्ये ही कोर्स ऑन ऑफ असतो, 1-2 मंथ्सची हिस्ट्री असते, आणि याच्यामध्ये पॅलर असू शकतो नसतो, बिकॉज इट्स अ क्रोनिक डिसीज, अनिमिया ऑफ क्रोनिक इन्फ्लेमेशन यामध्येही होऊ शकतो. बट ब्लिडिंग इज व्हेरी रेअर, ऑर्गॅनोमेगॅली इज व्हेरी रेअर. लिम्फ नोड्स असले तरी दे वुड बी सॉफ्ट, मोस्ट ऑफ द टाइम्स देर इज नो लिम्फॅडिनोपॅथी. बोन अँड जॉईंट पेन यामध्ये पण असेल, बट दिस इज ट्रू आर्थरायटिस. द अदर मार्कर्स विल बी रेज लाईक CRP, ESR, देर विल बी स्टिफनेस, राईट. आणि द CBC मोस्टली विल बी नॉर्मल. बट JIA असा आहे की इट इज द क्लोजेस्ट मिमिकर. इफ द चाइल्ड प्रेजेंट्स विथ एनी बोन पेन, जॉइंट पेन, तो टू रूल आउट दिस यू नीड टू गो फॉर अ बोन मॅरो, अदरवाइज यू मे मिस दिस कंडिशन. सो हे आपण बघितले IDA, मायक्रोसायटोसिस, HRW, ITP, आयसोलेटेड थ्रोम्बोसायटोपिनिया, JIA, जॉइंट स्वेलिंग्स, बट सिस्टमिक सायन्स आर मिनिमल अँड CBC इज ऑफन प्रिझर्व्ड. आणि व्हायरल इलनेसेस, डेंग्यू जर आहे तर इट शुड रिकवर 2 to 3 weeks त्याचं स्पॅन आहे, राईट. 2 to 3 weeksमध्ये डेंग्यू रिकवर झाला पाहिजे. युअर काउंट शुड नॉर्मलाइज. इफ युअर काउंट्स आर नॉट नॉर्मलाइजिंग, यू शुड स्टॉप लेबलिंग द चाइल्ड एज डेंग्यू, राईट. यू शुड थिंक देर इज समथिंग मोर अँड द मॅरो शुड बी इव्हॅल्युएटेड, राईट. सो एनी व्हायरल, इव्हन EBV वगैरे पण लिम्फ नोड्स घेऊन येतात आपल्याकडे, इन्फेक्शियस मोनोन्यूक्लिओसिस, त्यामध्ये पण सिग्निफिकंट लिम्फॅडिनोपॅथी मिळते. बट द थिंग इज द सिम्टम्स, इट्स सेल्फ लिमिटिंग डिसीज. लाईक 2 to 4 weeksमध्ये ते सिम्टम्स सगळे जाणार अँड द चाइल्ड विल रिस्टोर टू नॉर्मल्सी. इफ इट्स नॉट रिस्टोरिंग टू नॉर्मल्सी, देन यू शुड थिंक ऑफ pediatric leukemias. Okay. So we will go with some cases now. Okay. Case number 1, 5-year-old female, 15 days of fever on and off, generalized weakness, limb pains. On examination, no dysmorphism, pallor is present, cervical lymph nodes 2 into 3 centimeter significant आहे, liver 3 centimeters आणि spleen palpable, firm 4 centimeters. Okay. CBC केलं तर काय आहे, TLC is 3400, differential what you can see, polymorph 50, lymphocyte 78. So what you can see, polymorph 15, एज तिचं 5 years आहे. सो lymphocyte count is too high for the age, right. HB is 4.4, RBC count is low, 1.4 million, MCV, MCH, MCHC is normal, RW is 15.1, again normal, platelets are 56,000, retic is 0.2, LDH is 2,000. Summarizing this CBC, there is pancytopenia with low retic, high LDH, high suspicion of pediatric leukemia. Because there is also significant cervical lymph node, there is hepatosplenomegaly. Symptoms are fever since 15 days on and off, generalized weakness, limb pain, non-specific complaints. You should think of leukemia. Should go with next step काय, CBC तर झालं, पेरिफेरल स्मेअर सगळ्यात महत्त्वाचं. पेरिफेरल स्मेअर सगळ्यात महत्त्वाचं, राईट. पेरिफेरल स्मेअरवर दिसत आहेत मोठे मोठे सेल्स दिसत आहेत, राईट. दिस इज अ क्लिअर कट केस की देर इज अ ल्युकेमिया, राईट. बोन मॅरो केलं तर दिसेल आपल्याला काय आहे, तर B आहे का T आहे. सो इट्स अ B सेल ल्युकेमिया. ओके. दिस वॉज अ मोस्ट कॉमन प्रेझेंटेशन, म्हणजे पॅनसायटोपिनिया किंवा ल्युकोसायटोसिस विथ बायोसायटोपिनिया. दिस इज अ क्लासिक प्रेझेंटेशन, राईट. Case 2, we have a 6-year-old female child, complain of fatigue since 1 month, pallor noticed by parents, occasional mild fever. फक्त फटीग आहे 1 month पासून, काहीच नाही बाकी. सो पॅलर इज सिग्निफिकंट. ऑन एक्झामिनेशन नो डिस्मॉर्फिझम, लिव्हर इज 3 centimeter, स्प्लीन 2 centimeter, नो सिग्निफिकंट लिम्फॅडिनोपॅथी. इन्व्हेस्टिगेशन्स केले त्यांनी, तर TLC इज 4600, अगेन डिफरन्शियलमध्ये लिम्फोसायटोसिस दिसतंय काहीतरी. HB इज 5.2, RBC काउंट इज लो, MCV इज नॉर्मल, RW इज नॉर्मल, प्लेटलेट्स आर 72,000. राईट. पुढे काय केलं, ॲट लोकल क्लिनिक रिसिव्ड अ PRBC ट्रान्सफ्युजन, स्टार्टेड ऑन आयरन अँड B12, सस्पेक्टिंग न्यूट्रिशनल अनिमिया. तो आर देर एनी पॉइंटर्स विच विल गिव अस दॅट दिस इज नॉट न्यूट्रिशनल अनिमिया? HB is 5.2, right. RBC count is low, yes, but the RW is normal. Why should the RW be normal if it's nutritional? If your MCV तुमचं नॉर्मल असू शकेल जर दोन्ही कंपोनंट्स आहे, राईट. बट व्हाय शुड द RW बी नॉर्मल? द RW शुड बी वाईड, राईट. आणि थ्रोम्बोसायटोपिनिया, मेगालोब्लास्टिकमध्ये थ्रोम्बोसायटोपिनिया पण असेल, बट द RW इज द पॉइंटर हिअर अँड ऑल्सो द न्यूट्रोफिल काउंट विच इज व्हेरी लो. आता चाइल्डने ट्रान्सफ्युजन घेतलं, स्टार्टेड ऑन ओरल आयरन, पण काय झालं, सिम्टम्स परसिस्टेड अँड 1 month later the child again presented to us, and this time the CBC is total count of 2600, HB 4.8, despite transfusion, MCV 80, RW 14 and platelets are 26,000. So the cytopenia progressed, right, because the cause was not sought properly, right. So the retic count was low, LDH was high, and then peripheral smear suggested blast. So this was again a case of B cell ALL. However, the thing to note is there was a diagnostic delay by around 4 weeks because the CBC was pointing at the first instant only that there is a lymphocytosis and it's not fitting into the nutritional anemia. So further evaluation should have been done before bone marrow before PRBC transfusion. Next case, 5-year-old male child presented with complaints of easy bruising since 3 weeks, petechial rash over the legs, no fever. On examination, pallor आहे, no dysmorphism, multiple petechiae ecchymosis on lower limbs, liver just palpable, spleen just palpable. Investigations, TLC 4800, again lymphocytosis, HB 8.9, MCV 80, RW 15.6, platelets are 45,000. Okay, so here also we have lymphocytosis, however the TLC count is preserved, HB is 8.9 and platelets are 45,000. So very easily we can miss this child as platelets, means 45,000 platelets without fever, easy bruising, petechial rash, 5 years of age. It's very classic presentation of ITP. It can be a very classic presentation of ITP with no fever, well child, and with such CBC it's very easy to miss. Okay. So initial impression at local hospital was ITP, and the child was started on prednisolone for 14 days, followed by tapering of prednisolone for next 14 days. Right. What happened next? Investigations after 1 month. TLC 22,000, again with lymphocytosis, HB 6.3, MCV 80, RW 15.6 and platelets 16,000. Retic is low, LDH is high. Right. तर आता इथे परत तसं झालं. फक्त आयसोलेटेड थ्रोम्बोसायटोपेनिया होता 45,000, HB 8 एवढं ब्लिडिंग होतं त्याला 3 आठवड्यांपासून, तर मग ॲनिमिया झाला असेल असा त्यांनी विचार केला आणि मग ITP लेबल करून स्टिरॉइड चालू करून पाठवलं घरी. पण 1 महिना झाला पण ते काही CBC रिकवर झालं नाही. ठीक आहे, मग आता काय करावं लागेल, परत फर्दर इव्हॅल्युएट करावं लागेल. रेटिक काउंट करा, रेटिक काउंट लो आला आहे, LDH वाढून आलं आहे, करा पेरिफेरल स्मिअर कुठं आहे. येस, पेरिफेरल स्मिअर दिसतंय, पेरिफेरल स्मिअरमध्ये फ्रँकली ब्लास्ट आहेत. राईट. So this was ITP, means what we thought was ITP turned out to be a leukemia, but there was pointer, there was lymphocytosis, right? There was lymphocytosis, and what explained the anemia? Your HB was 8.9, MCV was normal, RW was normal. So peripheral smear should have been done at least a peripheral smear should have been done, and even before that, even in ITP, when for any indication, if you are giving steroid, you should do a bone marrow. If the cause is uncertain, if you are certain of the cause, then you can go ahead, but if you are not certain about the cause, you should do a bone marrow and then only start the child on steroid. Otherwise, steroids will push the child into remission and the diagnosis will get delayed. Right, so PS suggested blast, and this again turned out to be case of BLL. Now what happened? आता तुम्ही म्हणाल की ठीक आहे ना यार, ITP होता, आधी ITP लेबल झालाच नाही इव्हेंच्युअली डायग्नोज, महिन्याभरानंतर झाला पण झाला. सो व्हॉट हॅपन्स, देर वॉज स्टिरॉइड एक्सपोजर बिफोर द डायग्नोसिस. सो व्हॉट हॅपन्स, आपण जर ल्युकेमियाचे ट्रीटमेंट प्रोटोकॉल्स बघितले तर त्यामध्ये स्टिरॉइड इज अन इंटिग्रल पार्ट ऑफ द ट्रीटमेंट, अँड त्याचं जे रिस्क ग्रुपिंग आहे त्यामध्ये जर डायग्नोसिसच्या आधीच पेशंटला स्टिरॉइड मिळालं तर इट लीड्स टू अप स्टेजिंग ऑफ द रिस्क स्ट्रॅटिफिकेशन, म्हणजे तो हाय रिस्कमध्ये जातो आणि मग त्याला आपला हाय रिस्कचा प्रोटोकॉल द्यावा लागतो. हाय रिस्कचा प्रोटोकॉल दिला तर इंटेन्सिटी जास्त, ट्रीटमेंट रिलेटेड मॉर्टॅलिटी जास्त आणि ओव्हरऑल इव्हेंट फ्री सर्वायवल कमी. तर असं ती सायकल आहे. सो दॅट्स वाय अर्ली डायग्नोसिस इज इम्पॉर्टंट. म्हणजे स्टिरॉइड हे मिळालं नसतं तर बरं झालं असतं. राईट. आता पुढच्या केसेस आपण थोड्या फास्ट घेऊ. राईट. केस 6, आता हा न्यूनेट आला आहे आपल्याकडे, नॉर्मल फुल टर्म न्यूनेट, चांगलं वेट पण चांगलं आहे, जस्ट प्रेझेंटेड विथ कंप्लेन्स ऑफ अशी थोडेसे डाग पडलेत त्याच्या शरीरावर, मल्टिपल ब्लूइश कलर्ड स्पॉट्स ऑन स्किन ऑल ओव्हर द बॉडी, नो ऑर्गॅनोमेगॅली. म्हणजे डिलिव्हरी झाली की आईकडे असतं बाळ, त्यानंतर ते फक्त दाखवायला आणतात है ना, म्हणजे पिडियाट्रिशियन वगैरे राऊंड घेतात आणि मग दाखवायला आणतात फक्त की बाळ कसं आहे बघा, दूध पिते नाही पिते. तसं जस्ट साध्या फॉलोअपसाठी आलं होतं आणि त्याच्या अंगावर हे असे डॉट्स दिसले. राईट. व्हॉट इज दिस रॅश? देर वॉज नो ऑर्गॅनोमेगॅली ऑल्सो. ठीक आहे. तर आपण बघितलं नाही, आपण ल्युकेमिया डिस्कस केला आहे, त्यामध्ये काय होतं की स्किनमध्ये पण ल्युकेमिया जाऊ शकतो, पण न्यूनेटमध्ये, हे तर न्यूनेट आहे, जस्ट जन्मलं आहे, काही तासांचं बाळ आहे. राईट. CBC करा त्याचं. सगळ्यात पहिले काय केलं? CBC केलं. CBC केलं तर काय झालं? TLC काउंट इज 1,03,000, 19% न्यूट्रोफिल, 71% लिम्फोसाईट. यांच्यामध्ये लिम्फोसाईट काउंट हा नॉर्मल आहे, न्यूनेटमध्ये असंच राहणार लिम्फोसाईट काउंट. प्लेटलेट इज 30,000. प्लेटलेट 30,000 व्हायचं काय कारण? मदर वॉज फाईन, मदरला काही अँटीनेटल पिरियडमध्ये फीवर असता, काही व्हायरल इन्फेक्शन्स असते, तर आपण टॉर्च सस्पेक्ट करू शकतो. टॉर्चमध्ये पण असे डार्क म्हणजे असे जे स्पॉट्स आहेत ब्लूबेरी मफिन रॅश वगैरे टॉर्च इन्फेक्शनमध्ये पण येते. बट दॅट विल नॉट बी इंड्युरेटेड. हिअर द रॅश वॉज इंड्युरेटेड, palpable, right? And this was pursued further. So this case was pursued further. A peripheral smear was done, and the smear clearly showed abnormal atypical cells, and that's why a flow cytometry was sent. So, yes, so flow cytometry suggested pro B cell ALL, CD10 positive with MLL rearrangement. So this was a case of congenital leukemia. This is rare. 1 in 10 lakh cases will have congenital leukemia, but this is also a thing which can happen, which we should not ignore. बऱ्याच वेळा पेशंट येतात आपल्याकडे घेऊन, देर आर सिम्टम्स, थोडीशी रॅश आहे, आपण इग्नोर करतो, बट दॅट्स नॉट द केस. एव्हरीथिंग शुड बी परस्यूड अंटिल द डायग्नोसिस इज डन. So why early suspicion matters in pediatric leukemia? If the child is diagnosed late, what will happen? There will be higher WBC count. तो जो lymphoproliferation जे चालू आहे, ब्लास्टचं जे proliferation चालू आहे, it will not stop. They will relentlessly go on to infiltrate other organs, and that will increase the tumor burden. म्हणजे कचरा जास्त जमा झाला तर तो साफ करायला वेळ जास्त लागतो ना, तसा तो प्रकार आहे. सो देर विल बी हायर WBC काउंट, मोर कॉम्प्लिकेशन्स, जास्त वेळ तो न्यूट्रोपेनिक असणार, जास्त त्याला इन्फेक्शन्स होणार, परत ट्रीट करायला जड जाणार, अपग्रेडेशन इन रिस्क ग्रुपिंग, त्याला देण्यात येणारी ट्रीटमेंटची इंटेन्सिटी जास्त असणार, आणि त्यामुळे ओव्हरऑल ट्रीटमेंट इंटेन्सिटी वाढली की ट्रीटमेंटचा कॉस्ट पण वाढणार, आणि आपलं प्रॉग्नोसिस तेवढं कमी होणार, लिडिंग टू इन्फेरियर इव्हेंट फ्री सर्वायवल. दॅट्स वाय we should always try for early suspicion. We should have suspicion of leukemia so that we can diagnose it early. India versus West, if we compare the data, survival is 65 to 75% in India versus more than 90% in high income countries, and this gap is mostly due to late referral. हे सगळं जे आहे, it's because of late referral. We have caught up with the supportive care. जी ह्या leukemia patientला लागणारी supportive care आहे, we are at par with the Western countries. Just this thing ki delayed referral is leading to our low survival rates. Missing leukemia costs a life. Suspecting it costs only a CBC or bone marrow. फार तर काय होईल, तुमचं CBC PS जाईल, फार तर bone marrow होऊन जाईल, तो नॉर्मल येईल, पण you won't miss a child with leukemia, and that's why we should always think of leukemias. So take home messages: leukemia is most common childhood cancer, 35 to 40%. Red flags: persistent fever, pallor, bruising or bleeding, organomegaly, bone or joint pain. Mimics are there like IDA, like iron deficiency or nutritional anemias, ITP, JIA, and viral infections. However, persistence and progression, multisystem involvement, and despite treatment, if the child is not improving, you should think of leukemias. Diagnosis is very simple. All you have to do is CBC plus peripheral smear, and if you are strongly suspecting, then you should go ahead with the bone marrow. Early detection will save lives. When in doubt, order a CBC PS, and we are just one call away. Anytime you can call us. Thank you so much.
Excellent work. Dr. Suyog Nagre has done DNB in pediatric hematology from prestigious Wadia Hospital, and he is associate professor in Government Cancer Hospital and associated with Jeevan Amrut Hospital as well. The way he has taught all of us was like teachers standing in front of us. I am very glad that all the students were sitting here and they got a beautiful insight in how to diagnose or suspect even leukemia at the earliest possible time. I feel like rest of the conference, if no one is attends, still it is worth Jeevan Amrut Haematology Summit, because such a beautiful lecture at the start of hematology session we all had. I would like to request all of you to clap for Dr. Suyog Nagre. Thank you, sir. I would request Dr. Chaitanya Khillare to please felicitate Suyog Nagre, sir. And if some questions are there, maybe we can ask. We have time, no problem, sir. Yes.
Okay, just one comment. Excellent insight into how to suspect leukemia by the clinician. Now, what are some of the red flags for the pathologist? Because I'm a pathologist, I will just say a few things about pathological aspect of leukemia. One, we have to understand the limitation and strength of the cell counter. Whatever lymphocytosis that is being shown, it is actually the mistake of the cell counter. Those are L1 type of blast in the previous FAB classification, which are mistaken as lymphocytes. Similarly, this blast can release minor fragments of cytoplasm, and which can be counted as platelets. So you won't get thrombocytopenia, but rather a normal count in sometimes. But those are fragments of cytoplasm which are being counted as platelets, because cell counter is blind. It is a particle counter. It is not a cell counter. Any particle is counted based on the size as a cell. If it is 3 to 30 femtoliters, it is platelet. Above 30 to 300, it is RBC. So in the same RBC chamber, platelets and RBCs are measured. So there can be a mistake in that. Secondly, then morphology. I'm coming to morphology. You said about CBC, very important. Lot of times we are not sure whether it is a blast or not. So we call it atypical cell. And clinicians are confused. What does he mean by atypical? There are two types of atypical cell. Atypical cells favoring reactive, atypical cell favoring neoplastic. So we have to differentiate between that. So learn to identify virocyte or reactive lymphocyte or atypical cell favoring reactive morphology, which is having very dark cytoplasm. Learn to make your own smears. Learn to stain your own smears. So that is very important. Get familiar with all the Romanowski stains, including the Fields, Gimsa, and then Leishman. All these stains one should be very familiar with and should know how to troubleshoot if the staining is not proper. And I think that should be some way in which the communication between the clinician and pathologist will help in solving some of the issues. Last but not the least, I would just like to remember one great pathologist of 1940s, without which pediatric leukemia would have been the dreaded disease that it was in the 1940s. The name of that pathologist is Dr. Sidney Farber. Dr. Sidney Farber was the pathologist who is the founding member of the Dana-Farber Cancer Institute, one of the premium institute in the world for leukemia treatment. He was a pathologist, and his work in the 1940s led to, he is said to be a father of modern chemotherapy. His work led to one of the earliest chemotherapy regimen, that is antifolate. So all pathologists can play a very important role in diagnosis and management of leukemia. Thank you very much.
Thank you so much for the comment, sir. Two teachers in the auditorium is like boon for all the students. Dr. Sachin Kale sir is astute pathologist from the MGM hospital, and he is very good in morphology that I have seen myself. Thank you so much, sir. Yes.
Thank you. First of all, thanks to Dr. Toshniwal sir for giving me the opportunity. So, as Nagare sir has excellently pointed out, so when to suspect a leukemia in a child, and he has exceptionally told that pathophysiology will lead to something presentation of clinical side. So as a pathologist also, we are always looking for something what is abnormal in peripheral smear or a CBC. As you told, always look for a TLC first, and whenever I see increased TLC or even normal TLC, I always next look for absolute counts. So I would also like to say always look for absolute counts. So sometimes 5,000 lymphocyte count can be normal in a 2-year-old, 3-year-old, 5-year-old. But in an adult, it is definitely a lymphocytosis. So always look for a absolute count. And sir also said persistent of symptoms. So I also take sometimes history, whether the symptoms are persistent or temporary. So temporary symptoms can go like in dengue or all. So, and again in another finding, small finding like a teardrop cell, if a pathologist sees a teardrop cell, it always indicates there is bone marrow is packed. That's why the round RBC has become a teardrop. So whenever I see such abnormal findings, I look for another abnormal finding, whether there is a blast or not. So that's how a pathologist's point of view, how to suspect leukemia. Thank you, sir, for the excellent talk. Thank you.
Thank you, Shridan, sir, for your excellent comment. So I would like to Chaitanya Khilare to ask on stage and felicitate Dr. Suyog Nagre, sir. My senior Dr. Umesh Raitha sir is in the auditorium. He will felicitate all the chairpersons. Umesh sir, please. Dr. Sachin Kale sir is the professor in pathology, MGM Hospital. Dr. Shridan Patil sir, pathologist from Dr. Hedgewar Rugnale. You are very healthy, that is why. Dr. Praful Pandey sir, श्रीधन सर तुमच्या बच्चूसाठी एक छोटं गिफ्ट आहे. विचारेल ना पप्पा कुठे गेले, त्यासाठी आहे. थँक्यू फॉर कमिंग सर. यस. डॉक्टर प्रफुल पांडे सर, ही इज इंटेन्सिव्हिस्ट फ्रॉम पेंटागॉन हॉस्पिटल. Thank you, Praful sir, for chairing the session. This small token of gratitude for your kids. They must be missing you on this Sunday. Dr. Sakha Patil sir. Sir, busy asunhi वेळ काढून आला. Thank you so much sir for coming and chairing the session of Dr. Suyog Nagre. For next talk, we have Dr. Nilesh Vasekar in the auditorium. Thank you, Mr. Yes, sir. So, Dr. Nilesh Vasekar is my dear friend. He has done his MD medicine from JJ Hospital, followed by DM in clinical hematology from KEM, followed by fellowship in bone marrow transplant from Singapore. He is half European, and that is why he has started his NHS, that is Nashik Hematology Services at Nashik, and is also associated at Medicover Hospital. He'll be talking to us on real immunotherapy and antibody drug conjugates in the treatment of cancers. For this session, I would like to ask chairperson to come, Dr. Sagar Gupta. He is physician from and HOD from Hedgewar Hospital. Dr. Amol Kulkarni, Dr. Shubhangi Ghule madam, so thank you so much. Let's start with the session.
Thank you, Manoj.
Hello. Thank you, Manoj, for giving me this opportunity. And Manoj is a good friend, and he is also a teacher, because I learned a lot of things from him. Hematology, I have learned from him only, most of the hematology. Also, nowadays I am learning management from him, how to build the hospital and how to create a state-of-the-art hematology facility in a place like Aurangabad or two-tier cities like Aurangabad. So, without wasting much time, I'll be talking on this interesting topic of immunotherapy and antibody drug conjugates in the treatment of hematological cancers. So, what is real immunotherapy? When Manoj told me to give talk on this topic, so I thought let's do some research. What is real immunotherapy, and why we should talk about immunotherapy nowadays? Why we should think about these newer approaches while treating the diseases or deadly hematological malignancies. So immunotherapy is basically taking the help of our own immune system to fight the cancer or to fight the hematological malignancies. And in that, various steps are there where your immunity will give help while treating the cases. When he told me real immunotherapy, so I thought, what is real and what is fake? So this is fake. So these guys have tried from a long time. They have tried using immunotherapy by promoting their products. That they're saying ki, this is immunotherapy, but it is not. This immunotherapy, and because of the good results, nowadays we are getting good results with immunotherapy. These guys are also promoting our immunotherapy is working, and traditional immunotherapy is working, and they're trying to justify that Nimbu Mirchi is better than original nivolumab. So we should not do that. And not only in India, outside also, in US also, there is a cult which says that you should not take treatment, allopathic treatment should not be taken, and the industry, allopathic treatment industry is booming, and they have a lot of misconceptions. So lot of patients do suffer because of these misconceptions. We should not promote these. Burden of hematological cancers, we know there are almost 63 cases per 1 lakh hematological cancers in our community in India. And the commonest ones are ALL, AML, myeloma, lymphomas, and CML. So while treating these diseases, we know chemotherapy was a backbone of treatment in most of the cases. But as we are seeing, we are learning from our experiences that the chemotherapies, we are trying to reduce the toxicity of chemotherapy, and we are trying to merge chemotherapy with the newer therapies so that side effects will be less and we'll get more survival. So if we see in immunotherapy, we have bone marrow transplant, then monoclonal antibodies, bispecific T-cell engager therapy, then you have antibody conjugates, and tumor vaccine and immune checkpoint inhibitors. So these are the main modalities of immune therapy, whatever it is available today. Most of the therapies we are using, bone marrow transplant, most of the centers are doing. Manoj has recently completed 100 bone marrow transplants. So it is a common thing to do. But these options are having curative intent, and these options are available, can be given to the patients of hematological malignancies. And this is the timeline where we have seen these drugs coming into the market. We have from 1980s, I would say, these drugs and these modalities are coming in the market. In 2002, we have seen rituximab coming in. Then we have seen gemtuzumab ozogamycin, which was approved for treatment of AML. Then in 2010, its approval was withdrawn because of the side effects. Again in 2017, gemtuzumab ozogamycin is there in the management of acute myeloid leukemia. These drugs are phenomenal drugs, and these drugs can really change the management of hematological malignancies. What is the difference between chemotherapy and immunotherapy? Chemotherapy, we all know chemotherapy can cause side effects in the form of cytotoxicity, cytopenia is more common. Then chemotherapy can lead to untoward side effects because of the death of or destruction of the normal cells also. While in immunotherapy, that is less likely. In immunotherapy, the side effects can be in the form of immune-related side effects, and there are cons in the form of we don't know why immunotherapy does not work in some of the other some malignancies and does work in some malignancies. So tumor microenvironment plays role over there. What about antibody-drug conjugates and traditional chemotherapy? If we see antibody-drug conjugates, they have high binding affinity, and the antibody-drug conjugate have specificity for the tumor cells. While long half-life will be there with antibody-drug conjugates, while in traditional chemotherapy, half-life is very less. Can we differentiate between immunotherapy and ADC, antibody-drug conjugates? Yes. So if you see antibody-drug conjugate, the killing agent is cytotoxic drug payload, which is combined with the antibody. And in immunotherapy, only your immune system is being activated with the help of antibody. Okay. So mechanism is immune activation. While in ADC, you have targeted the drug delivery. So side effect profile will be different, right? So immune-related in immunotherapy, while chemo-like neuropathy, brentuximab vedotin can cause neuropathy. So which is not seen in cases of inotuzumab treatment. So in ADC you have chemotherapy like side effects. So these are slight differences. So coming to the first thing, monoclonal antibody. So we used to use chemotherapy for the management of malignancies, but we tried to do some precision in management of leukemias or lymphomas. And in precision, if we see, if we can target only those cells which are cancer cells, like CD20 positive lymphoma cells, if we can target those, if we can target the terrorist only, then we'll try to avoid damage to the normal people. Okay, so monoclonal antibodies comes into picture like that. CD20 positive B-cell lymphomas can be treated with rituximab. We all know rituximab is the mother of all these monoclonal antibodies, right? So it was developed in 90s, and pivotal trial was done in 1998. We know GALA trial was there, and rituximab, with the help of it targets CD20 of the lymphoma cells as well as leukemia cells, and it can help in destroying those lymphoma cells with the help of immune activation. So indications are non-Hodgkin's lymphoma, CLL. Also in rheumatological disorders like SLE, rheumatoid arthritis, B-cell derived disorders like immune thrombocytopenia, we can achieve some good amount of remission with the help of rituximab. And rituximab is a day-to-day drug we use in our regular practice. This was a GALA trial which has shown significant improvement in survival by using R-CHOP versus CHOP, which was done in 1998, and till today there is no much change in management of DLBCL. R-CHOP is the standard of care for DLBCL. What are the side effects? Immune reactions can be there, myelosuppression, infection, skin reaction, HPV reactivation. But all these things are manageable. These are not unmanageable things. We use it on regular basis, and we hardly find any major reaction. If you are taking good care of infusion reactions, then rituximab is a manageable drug. Coming to daratumumab, this drug has changed the management of multiple myeloma. It is CD38 monoclonal antibody which helps in managing patients of daratumumab, and it has been approved in the management of multiple myeloma. It is been used as a single agent in refractory cases and combined agent in upfront management of multiple myeloma. Whether it is standard risk multiple myeloma or high risk multiple myeloma, it has changed the management of multiple myeloma. It is like a rituximab of lymphoma. So daratumumab is a monoclonal antibody to go ahead in the management of multiple myeloma. Infusion reactions can be there because of DARA, neutropenia, thrombocytopenia, and we need to do cross matching before using daratumumab. So try to do it before you prescribe daratumumab in a patient of multiple myeloma. Coming to the immune checkpoints. So immune checkpoints, tumor cells, they escape the chemotherapy with the help of these immune checkpoints. Immune checkpoints, what they do is they avoid cancer cell killing because of the T cells, and this PD1 and PDL1, they inhibit the destruction of that cancer cell. So how to avoid that? So we can use immune checkpoint inhibitors. Okay. So what are those? We have PD1 and PDL1 inhibitor. So PD1 inhibitor is nivolumab, pembrolizumab. We are going to talk about that. And atezolizumab, the medical oncologists do use this drug. And durvalumab, we don't use that. So these are PDL1 inhibitors. So these drugs have definitely changed the management of some of our lymphomas. 100% survival, have you seen it? In any of the disease, in any of the medicine disease, you have seen it? No. Even if you see tuberculosis, 90% survival you can say, right? So 100% survival. This is pembrolizumab in classical Hodgkin's lymphoma, that in relapsed refractory setting. So it's a magic drug. 100% survival you have never seen in the history of medicine. So pembrolizumab can achieve that. How does it work? It inhibits the PD1 checkpoint. and it inhibits that checkpoint, and it causes activation of those T cells which try to kill that tumor cells. Classical Hodgkin lymphoma, relapse refractory setting, you can use pembrolizumab. Also in primary mediastinal B-cell lymphoma, we can use pembrolizumab. Drug reactions, like immune reactions can be there, pneumonitis, colitis, hepatitis, infusion reactions can be there. Pembrolizumab, after studying pembrolizumab, you can get progression on CT scan, but that can be immune reaction, and after follow-up, you can have normal PET scan. Next drug is nivolumab, brother of pembrolizumab. It also blocks that PD-1, and it activates the T cells by blocking that PD-1, and it helps in destruction of the tumor cells. It is also useful in classic Hodgkin's lymphoma, can be used post-autologous transplant in Hodgkin's lymphoma. Nowadays, if I say stage 3, stage 4 classical Hodgkin's lymphoma, what is the treatment of choice? Students, in 2025, ABVD? No, it is Nivo-AVD. IBVD is out. Okay, so 2025, if you are treating stage 3, stage 4 Hodgkin's lymphoma without nivolumab, it's a crime, provided patient does have money for nivolumab. Okay, you can still use ABVD. So these are the side effects which nivolumab can cause: skin rash. I'm using it in most of my patients, but hardly seen any of those. But you should tell the patient before using it. But survival rates are phenomenal, and after 2 cycles of Nivo-AVD, in last 3 to 4 of my patients, I have seen complete remission in stage 4 Hodgkin's lymphoma, and that is the phenomenon. Coming to antibody drug conjugates, how does it work? And third type is antibody drug conjugate. In antibody drug conjugate, your monoclonal antibody will carry the drug or a cytotoxic drug along with it, which will attach to that cancer cell, and that cytotoxic drug will enter that cell and destroy, or it will cause DNA damage and destroy that tumor cell. It's like using Trojan horse, and with the help of that, you can kill the tumor cell. So what are the different examples of ADCs? One is brentuximab vedotin, polatuzumab vedotin. Brentuximab we use it in classical Hodgkin's, and polatuzumab we use it in DLB cell, gemtuzumab ozogamycin in AML, inotuzumab in ANL, and belantamab in multiple myeloma. Coming to this drug, inotuzumab ozogamycin, it's a wonderful drug which has been used in relapsed refractory acute lymphoblastic leukemia. It does carry calicimine along with CD22. You need to have CD22 positive tumor to give inotuzumab ozogamycin. The inotuzumab will bind to CD22, and that calicimine will destroy the DNA, and it helps in apoptosis. So relapsed refractory B-cell ALL, you can use inotuzumab, and it's a phenomenal drug. If patient is having relapsed refractory B-cell ALL, you want to take it for a transplant, inotuzumab can be given, and achieving remission, we can take that patient for transplant. These are the survival curves of ozogamycin, inotuzumab, and these are pretty good as compared to the standard of care. Hepatotoxicity is a worrisome with inotuzumab. You need to be very careful. You need to monitor liver enzymes. Coming to this second drug, brentuximab vedotin, it was a star drug till last year in classical Hodgkin's lymphoma, but nivolumab has replaced it. But this is also a good drug which acts by this mechanism of ADC, that is antibody drug conjugate. It binds to CD30, and it carries that MMME along with it, which destroys the DNA of tumor cell and helps in achieving remission in the patients of classical Hodgkin's lymphoma in relapsed refractory setting, as well as upfront you can use it. Adverse drug reactions are peripheral neuropathy. You need to be very careful while using this drug. You can get bad peripheral neuropathy. Otherwise, the rest of the side effects are manageable. This is a survival curve of brentuximab vedotin with ABVD, and it is superior to ABVD. Polatuzumab, it is CD79 antibody directed drug conjugate which carries MMMA along with it in a B-cell lymphoma, and polatuzumab can be used in high-risk DLBCL upfront cases. So side effects are infusion reaction, diarrhea, and hematological toxicities. But these are the results which were compared along with R-CHOP, and polatuzumab has increased the survival by a range of 5 to 7%. Coming to the BiTE, that is bispecific T-cell engager. How does it work? Bispecific T-cell engager will bind your CD3, and another antibody will bind with the tumor cell, and it will kill that tumor cell with the help of cytotoxicity. So blinatumomab is a prototype of that, where you have a CD19 antibody as well as you have CD3 antibody, which will bind with the CD3 positive T cells and CD90 positive tumor cells. Those T cells will destroy those CD19 positive tumor cells. So blinatumomab is a good drug, and CD19 positive B cell ALL we can use blinatumomab. Blinatumomab can be used in upfront cases also. Recently got approval in consolidation phase of B cell ALL management. So if your patient can afford blinatumomab, you should always give the option of blinatumomab in consolidation phase. Adverse drug reaction, the patient can develop neurological toxicity, and the patient can develop cytokine release syndrome. So managing these drugs in a hematology center is mandatory. You should not give it in normal ICU or in normal hospital, multi-specialty hospital. This drug should be given in a setup where bone marrow transplant unit is functional. These are the survival curves, blinatumomab in the range of 70 to 80%. So are we looking at the cure? By using these drugs, are we thinking we can cure the patients of hematological malignancies? Yes, we can. Monoclonal antibodies have achieved a survival rates of 60% in NHL. Checkpoint inhibitors 20 to 30%. The time is not ahead that will achieve almost 90 to 80% in cases of classical Hodgkin's lymphoma. Also, BiTE therapies can achieve 40 to 45% relapse-free survival, and ADCs can achieve more than 10% of the normal NHL, like 70% survival can be achieved with the help of ADCs. There are challenges to manage these newer drugs. We have those are efficacious, the access is there, but we need to develop our indigenous drugs to reduce the cost. Cost is phenomenal. If patient is having some sort of insurance which can cover these immunotherapy drugs, should be there, or should be advisable. Indian innovations like rituximab, we have Indian rituximab. So that's why the cost of rituximab has reduced significantly, which used to cost around 50,000 in past. Now we can get it in 5,000, 6,000 rupees. So if we can develop Indian monoclonal antibodies, Indian version of ADCs, then definitely we can go ahead. We have Indian CAR-T also. Dr. Sumit is going to talk about that. But these other drugs, immunotherapy drugs, if we can create biosimilars in India, we can reduce the cost. Nivolumab cost is around 2,30,000 rupees single cycle. So if you can create 20,000-30,000 option, then patients can easily use it. So to conclude, so immunotherapy is reshaping the treatment management of hematological malignancies, and monoclonal antibodies and checkpoint inhibitors do provide long-term survivals in the patients of hematological malignancies like lymphoma and leukemia. Antibody drug conjugates like brentuximab and polatuzumab does enhance the management and does enhance the survival in patients of lymphomas, and collectively immunotherapy and ADC this present the backbone of management of recent treatment in cases of hematological malignancies. Thank you. Any questions?
Thank you, Dr. Nilesh, for wonderful presentation on various modalities of this real immunotherapy, and it's all the aspect you have covered. I just want to ask about what is your experience about after using this, if there is a hyperstimulation of immune system, what are the adverse consequences, like patient developing some sort of infection or septicemia, fungal infection? What is your experience?
Okay, so the septicemia or fungal infections are not that common with our rituximab or inotuzumab, but it is common with brentuximab vedotin. So in those patients, what we do is we try to give antifungal and antiviral prophylaxis to avoid those side effects, and we give them preventive medications like to prevent the infusion reaction or immune reactions or cytokine storm. The drugs like inotuzumab, blinatumab can cause cytokine storm, very bad cytokine storm causing high ferritins, high LDH, patient having pancytopenia. But for those patients, we are giving pre-medication in the form of methylprednisolone, antihistamines and paracetamol, and we keep those patients on low dose steroids for few days, where we find those patients are going to get that macrophage activation or cytokine storm. There we are using those drugs to suppress the immunity. Yeah.
Very nicely elaborated and covered all the aspects of the immunotherapy. Congratulations for that. I just want to ask, what is your experience? Say 10 years back, these therapies were not there probably. So how is the change in the quality of life of a patient? You can explain.
Okay. So 10 years ago, we used to admit 80% of hematological cases. Okay, and now we are on admitting only 20% of hematological cases. That's how these drugs have changed the management. Like nivolumab, if patient is not going to get any reaction in first dose, then you need not admit him. The patient will come to daycare, he'll take the medicine and he'll go away. So that's the beauty of these drugs. Rituximab also, if patient is not developing any reaction in first cycle, you need not give second rituximab in ICU. You can give it in daycare only. So with this availability of these drugs, side effects are going down. Patients are getting more patients are getting cured, and more patients are getting benefit because of those drugs. But the cost is an issue. But with Indian innovations, we can help all the patients.
So another question is generalized. Say, what is the possibility, or how can you elaborate? There is a bridging of treatment before bone marrow transplant in this immunotherapy.
Okay, yeah. So if you want to safely take the patient for bone marrow transplant, there are two options. One is using salvage chemotherapy or using immunotherapy. Okay, like in the case of B-cell ALL, if he has relapsed on chemotherapy, you can give salvage chemotherapy, which has a toxicity of a mortality risk of almost 25 to 30%. While if you are using inotuzumab, the risk of mortality is 5 to 10%. So you are saving on that 20% mortality, you are saving that. So the patient can safely go to transplant.
Right. So it is giving much time to the patient to adequately get the transplant also, because there is a heavy load of the patients also.
Yes,
so
yes.
thank you, doctor. So nicely elaborated.
Thank you so much. Nice discussion. We may think that Google is something still we all are used to Google, but we must try to learn now DeepSeek and ChatGPT and everything. This is the way the bispecific antibodies are coming. We may feel that this may be expensive, this may not be available in near future, but mark my word, by 2030, all of us will be using this drug, and today all the young generation, young students are here in the auditorium, and they will be using for betterment of the patients. Dr. Nilesh had one slide in that he mentioned, are these curable? Yes, we are looking for the cure in the cancer, and soon that dream will be true for sure. Like HIV, for every patient now life is like normal. For cancer also, we hope and we are working together on that. Cancer will be a curable disease in near future for sure. Thank you so much. I would like all the chairperson to please come and felicitate Dr. Nilesh Vasekar, please. I request Dr. Sudhakar Hase to please come forward and felicitate the chairperson for chairing these sessions. Today, this time we thought that all the young colleagues of us should get the opportunity to chair the session, and for them, we have got some gifts for their kids, because on Sunday you spend time with us and kids are there waiting for you all at the home. But thank you so much for taking your time out. Dr. Amol Kulkarni sir. Dr. Shubhangi madam. Yeah. Shubhangi madam चं काय जाऊ जा समोर देऊन टाका. She has 2 boys. They are waiting for her at home, and we really thankful that she is here with us. Dr. Amol Kulkarni sir. Thank you so much for taking your time out and coming for the today's event. हे सर तुमच्या मुलीसाठी. And Dr. Sagar Gupta sir. Thank you so much, dear Sagar sir, for coming for the today's event. ठीक है. So now we have our third session. Dr. Shweta Biani, she is MD Pathology and working as hematopathologist. She is backbone of Jeevan Amrut. She'll be delivering on benign hematology, what's new in 2025. For this, I would like to invite for chair Dr. Oher sir, who is in the auditorium. Dr. Govinda Nagatkar sir. Dr. Sandeep Ghule, if he is around. Dr. Mahesh Kesale, who is my batchmate, can you please come forward to chair this session? And Dr. Shilpa Vaishnav, madam, can you please come to chair this session? Thank you so much. And we have benign hematology. We learned a little bit about malignant. Now we will listen from her about benign hematology and what's happening new in 2025. Over to you.
A very good morning to all of you. So, in the first 2 sessions, we have learned about cancers and the immunotherapies, anticlonal antibodies, which are really bringing to a cure to the cancers. And now I am here to focus and draw your attention a bit to what is happening in benign hematology. So, I will bring some important cases and recent updates what is happening in benign hematology. So, I am just standing here as I am a MMC speaker, and you all will be getting 2 MMC credit points, and I would like to connect with you all and convey my regards and thank you from this podium for all the support and guidance. So, benign hematology. So, medical science is ever evolving, and in this age of artificial intelligence, hematology is at the driving seat, but it is more for the malignant diseases, as we have seen in the first 2 sessions. So now the non-malignant hematology. It comprises mainly of anemias, various thrombocytopenias, inherited bone marrow failure syndromes, acquired marrow failure syndromes, thrombophilia, bleeding disorders, and thalassemia hemophilias, along with sickle cell disease and many more. So, in the first week of July itself, we have heard the news that Japanese have mentioned and invented new blood, a blood which can be given to all blood groups, and it can be stored in shelf for 2 years. So, it is a major evolutionary change. In India, like in monsoon, many people are suffering from malaria and dengue, and we everywhere in newspaper or in our communities, we see blood bank people are asking for blood donations, and we all go for it. But this is a very revolutionary change. These people are preparing a product which can be given to all blood group and no need of cross match or no need of refrigeration, anything. It can be stored in shelf. So this, they are working on it, and maybe in coming time, we will be having it in India as well. So case number 1. This is a young girl preparing for police bharti. She is tired on physical exertion and she was severely pale, hemoglobin only 3.4. MCV was low and poor diet. No focus of excessive blood loss was there. So on evaluation, she was a case of iron deficiency anemia. In a traditional way, we treat the patients with iron deficiency anemia with iron supplements, and when there is severe deficiency, we give blood transfusions as well. But the recent and update in this anemia is these are treated with IV iron, intravenous iron supplement. So we have good molecules which can, we say that near perfect IV iron. So they are safe, effective and convenient. Just one shot of IV iron and the hemoglobin is up by 3 gram per dl in a period of 2 to 3 months. So it is a big relief from taking supplements which cause many side effects like constipation, fatigue and anorexia, nausea. The iron, oral iron intake that was causing. So IV iron is a good in for the benign hematology. So ferric carboxymaltose and iron isomaltoside, these are the available molecules, and previously they were patent, but now they are available in very low cost as well. Earlier it were available in 5,000 for 500 milligram dose, but now it comes around 1,000 to 1,200 milligram, 1,200 rupees for 500 milligram dose. So it is a very good treatment option available. Next, thrombocytopenia. So 43-year female presented with petechial lesions. Platelet count was less than 10,000 and immature platelet fraction was high. So it indicated towards immune thrombocytopenia. Treatment with new molecules with excellent early response. So till now and at many areas, this ITP is treated with steroids, or when diagnosis is not clear, the patients keep on receiving platelets. But now these two drugs, eltrombopag and romiplastim, are giving excellent response. So the next is hemophilia. We know it is due to factor 8 deficiency, factor 9 deficiency. So a patient Swaraj, who is a 3-year-old boy, diagnosed with a case of severe hemophilia, means factor 8 deficiency, history of recurrent right ankle bleed, which became the target joint. Family is worried because he is small child, he wants to play, but whenever he plays, he comes back with pain in the joint. So this patient was planned with prophylaxis with new drug. This new drug specialty is, it is given only once a month subcutaneous and with least side effects. So this drug is Hemlibra. It is emicizumab. What is action is, it is a bispecific drug and it binds factor 9 and factor 10, and along with them it carries on the intrinsic pathway which lead to coagulation, and this way it is not factor 8 but it is a drug which brings together factor 9 and factor 10 which causes coagulation. So this is a boon for this patient because just a once a month and subcutaneous dose, and patient is relieved with any other side effects. So how we have come to progress in bone marrow failure syndrome. A young male with pancytopenia, he required transfusions at local level. He was planned for treatment, and but how to treat? Because it was pancytopenia and it was difficult to diagnose the cause. But the new technique, next generation sequencing, helped to narrow down the exact mutation causing marrow failure. So next generation sequencing help us to see whether the bone marrow failure is due to congenital or acquired reason, which are the genetic causes, and then we can accordingly directly target the disease and treat accordingly. So this is the boon with next generation sequencing. Next, the bleeding disorders. A young girl with menarche at 13 years. She is associated with very heavy bleeding and requiring transfusion. She was otherwise well. No past or family history. The finger prick smear shows no evidence of platelet aggregation, and hence we went for next generation sequencing, and we got the specific diagnosis of Glanzmann thrombasthenia, and accordingly she was treated with platelet transfusions. And now the thalassemia, it is very prevalent in India as well. So thalassemia patient, we know that they require frequent blood transfusions, and then the consequences with iron chelation, and they have to suffer a lot. Although it is not life-threatening, but the quality of life of these people are compromised. So in these evolution, we are having answer for this as well. So regular transfusion remain the treatment of choice along with chelation of iron for thalassemia patient. But now with progress in science, we have come to the with a drug which can be given to the thalassemia patient, minor and intermediate, which can reduce their dependency for transfusion. And along with that, this new drug is luspatercept. So this reduces the frequency of transfusion in thalassemia minor and intermediate, and we are hopeful that the scientists who are working tirelessly on this, we can find the cure for thalassemia major as well. One more breakthrough in this field is treatment for sickle cell disease. Sickle cell disease is a genetic abnormality, and this is Kendrick Cromer. This is a boy who was treated with gene editing therapy. He was having sickle cell disease, but he was treated with gene editing therapy and he is cured. So we can celebrate this big breakthrough in the field of medicine. So he is the first patient of newly approved sickle cell gene therapy. In this CRISPR-9 and Cas gene, here we can see as we edit our messages, we are editing genes also here. So it is a major breakthrough in the field of medicine, gene editing. We have discussed these major inventions in our field of medicine. Along with that, I would also like to bring your attention to the importance of automated cell counters. The parameters that they show, they have major significance in deciding the prognosis, diagnosis, and therefore treatment of the these hematological disorders. So first is immature reticulocyte fraction. It measures the percentage of immature reticulocytes in a sample. An increased IRF indicate enhanced erythropoietic activity in the bone marrow, and it potentially indicating early response to therapy. So if IRF is increased after treatment, then we can see that our treatment is getting response. Along with that, bone marrow function also we can evaluate. So it can differentiate between myelodysplastic syndrome and megaloblastic anemia as well. So next is the reticulocyte hemoglobin content. So this parameter provides a reliable measure of a functional iron available for erythropoiesis in the previous 3-4 days. Like we see hemoglobin HbA1c, which gives us the indication for glucose level in previous 120 days. Like that, this is reticulocyte hemoglobin content. It gives us the indication of iron content in our body in past few days. So in early iron deficiency, so this is decreased, and it is a sensitive indicator of early iron deficiency. Even before changes in mature red blood cell get evident, and again then monitoring the treatment. It helps in assessment the response of iron supplementation and manage patient receiving erythropoietin therapy. Like the red blood cell parameters, we have platelet parameters as well. Immature platelet fraction. So it indicates the proportion of newly released and more immature platelets in circulation. So in the diagnosing of thrombocytopenia, we have seen ITP. So if the immature platelet fraction is high, then it is a case of ITP, because we know at least marrow is functioning. But if the immature platelet fraction is low, then there is some other problem with the bone marrow. It may be marrow failure as well. Again, for monitoring platelet recovery, immature platelet fraction can predict platelet engraftment after hematopoietic stem cell plantation. So generally, if we have to see the platelet count, mature platelet count, it will take longer time. But IPF gives us the result in few days. So we can be relaxed whether the newer platelets are engrafted after bone marrow stem cell transplant. So mean platelet volume. Again, this is the average size of platelet. So it helps in differential diagnosis for essential thrombocythemia, in which it is increased, mean platelet volume is increased, and in reactive thrombocytosis, it is normal. Then we will come to white blood cell parameters. The newer one is the immature granulocyte. The many blood cell counters which are coming nowadays, three-part blood cell counters are common in periphery as well, but in major cities and big hospitals, the blood cell counters up to 9-part, they are also coming, and these are having these important parameters like immature granulocyte. It detects and quantifies immature neutrophils. So we get the clue for infections and sepsis. Elevated immature granulocytes is an early indicator of bacterial infection, and it can be useful in identifying sepsis. Then nucleated red blood cell. It indicates the presence of immature red blood cell, those still containing nuclei in peripheral blood, and they are wrongly calculated as lymphocyte, and therefore we get increased WBC count. But these are also getting now in blood cell counter. So in hematological disorders which are having NRBC, they suggest conditions such as severe hemolysis, bone marrow stress, and certain anemias and malignancies as well. Next is monocyte distribution width. It is a measure of the variability in the size of monocytes. In sepsis detection, the US FDA has approved monocyte distribution width as a parameter to improve early detection of sepsis. So what is the significance of these parameters? It helps in earlier and more accurate diagnosis, better monitoring of disease progression and treatment response, reduced need for manual microscopy and specialized tests, and therefore improved screening and prediction of infection and other conditions. I will go through in brief regarding this Human Genome Project and next generation sequencing. So this Human Genome Project was started in 1990s, and it took around 32 years for completely mapping the human genome. So it got completed in 2022. This human genome, entire human genome mapping has been done, and we are having the reference genome on which the next generation sequencing technique is based. It takes reference from the Human Genome Project. So, while the Human Genome Project initially relied on Sanger sequencing, it is a method limited to sequencing one DNA fragment at a time. But the development of next generation sequencing techniques marked a paradigm shift in genomics. We have seen the use of NGS in my previous slides, thrombocythemia, diagnosing bone marrow failure syndrome due to congenital or acquired condition. This next generation sequencing provides us a clue in minimum time. So what is next generation sequencing? It is a massively parallel or deep sequencing, represent a group of modern sequencing technologies that have drastically increased the speed, throughput, and affordability of DNA and RNA sequencing compared to traditional Sanger sequencing method. So its key characteristics are, it can massively sequence at a given time. It can manage many DNA strands, and therefore high throughput, and therefore cost effective, and increases speed of detection. It is having higher sensitivity and discovery power. So NGS offers greater sensitivity to detect rare or low frequency variant and novel genetic mutation. Because of these innovations, next generation sequencing plays a central role in identifying the molecular characteristic of cancer. In this review, we discuss the role of NGS in the diagnosis, treatment, and monitoring of hematological malignancies. So, what are the applications of NGS in hematology? It helps in diagnosis and classification of malignancies. WHO and European Leukemia Net committees has also given a major significance on genetic abnormalities, therefore classifying acute myeloid leukemia based on genetic aberrations. This NGS provide a major help to us. Then prognostication and risk stratification. NGS provide a valuable prognostic information by identifying mutation and gene expression profile at the correlate with disease progression and treatment response. Like mutation like RUNX1, TP53, FLT3 are associated with unfavorable prognosis in AML. Then targeted therapy selection. So NGS can identify mutation that may be targeted by specific drug. This allows for the selection of personalized therapy and can improve patient outcome, like we see targeted drug therapy. So this NGS provide us the culprit, who is the culprit, and therefore we can directly target it. Then measuring minimal residual disease. So very traces, even if leukemic cells are present in traces, this NGS is very capable of detecting those culprit, and therefore we can plan our further strategy. So it is available in various forms like whole genome sequencing. It determines the complete DNA sequence of an individual, and it is required when we want to know whether any genetic abnormality or genetic mutation is present in the individual. Next, exome sequencing, in which we sequence only the protein coding region of the genome. Transcriptome sequencing, in which we analyze the RNA sequencing. And epigenomics, in which studying modification to DNA that affect gene expression. So we still have challenges in using this NGS, like it is yet to be standardized worldwide. So there are variation in lab to lab and machine to machine. So we are still waiting for the standardization of this technique. Then bioinformatic expertise, like technician skill has to be developed for using this high skill machine, as well as it provide a huge data. So interpreting that huge data, it also takes time. And when interpreting this huge data, therefore still we can't use it in acute leukemia cases, because they progress fast and we can't wait for this long for giving the results. So in conclusion, this next generation sequencing is transforming the field of hematology by providing in-depth understanding and genetic landscape for blood cancers. Its growing role in diagnosis, risk stratification, therapy targeted selection, and MRD monitoring is revolutionizing the clinical management of hematologic malignancies and paving the way for more personalized and effective treatment approaches, because if we know the target culprit, we can definitely more effectively treat the patients. So a bit about Jeevan Amrut Haematology Center. So it is the largest hematology. I am happy to share with you all that it is the largest hematology center in Maharashtra, if not in India at least. It is with 80 functional beds and ability to cater all the classes in society. We are having Pradhan Mantri Jan Arogya Yojana in our panel as well. We have 4 bedded state-of-the-art bone marrow transplant unit with more than 90 successful bone marrow transplant done till date, and we are reaching the century now. We have team of dedicated compassionate caregivers with us, and the number is growing to 100. And still 10 research studies are also going on in the Jeevan Amrut Haematology Center. So we are helping to formalize new drugs as well, which can help the treatment, and with lesser side effect we can maybe cure the patient with blood cancers. So this is our team Jeevan Amrut. This is our initial setup. We were at N4 SIDCO, and now we are at N1 SIDCO Jeevan Amrut, and we shifted here in April this year only. So the journey of Jeevan Amrut began on the auspicious day of Gita Jayanti on 30th November 2017 with our team of 5 members only, and now we have grown to the team of 100. Since then, till yesterday we are counting, we have provided our services of hematology to 14,633 new patients from all across Maharashtra and nearby states, and some patients from out of India as well. We have follow-up patient OPD of 39,351, and bone marrow aspiration and biopsy procedures, we have done 6,951 till date. For bone marrow transplant, we are approaching a century, and till now 92 successful bone marrow transplants, including both autologous, allogenic, with related as well as unrelated donors, and few rare diseases like enzymopathy, mucopolysaccharidosis patient have also been treated at Jeevan Amrut with bone marrow transplant. Successful it is. So it's all about the team, and I thank you all very much for being here and supporting us in this journey of hematology. We are always happy and always try to reach the hematology with all our colleagues, students and community for bringing awareness and what's going on new in hematology for better patient care, and therefore making India progress with world. Thank you.
So thank you so much, Dr. Shweta, for your presentation. Any comment or questions from the chairperson auditorium? Yes, Vaishnav.
Hello. Excellent presentation by you, Dr. Shweta. I congratulate Team Jeevan Amrut for such commendable work. You explained very well about the clinical cases, newer parameters in the hematology section we are using in day-to-day life, along with the newer applications in the field. Thank you so much.
Whole Marathwada will be thanking you for setting such a good hematology setup which was not available in this area.
Simple case, simple case of iron deficiency anemia to like platelet disorders to bleeding disorders, factor deficiencies to modern advances. I think I always tell my student like diagnosis of anemia. Anemia is not a diagnosis, it's a symptom of something, right? It's not an end in itself. It is because of something that anemia is happening. So we have to find out the something because of which anemia is happening. It is not enough to diagnose microcytic hypochromic anemia. You do the investigation, you diagnose iron deficiency anemia, that is also not enough. You have to find out why iron deficiency is happening, whether the girl is having menorrhagia, woman is having menorrhagia, multiple pregnancies, or that's an old man. Old man with iron deficiency anemia is definitely a red flag. Definitely a stool for occult blood should be done to rule out any colonic malignancy. And colonic malignancies, if they are diagnosed early because of anemia, they will go a long way in having a very good prognosis. So these are the simple things about which all of us can keep in mind. So very good coverage of all benign hematology. Thank you.
Hello. I request all the chairperson to please be on dais and felicitate Dr. Shweta Toshniwal. I request Dr. Namita Soni madam, please be on dais to felicitate our chairperson for the date, for this session. Thank you. Dr. Over sir. Thank you so much. Thank you so much. Yeah. Dr. Over sir, Dr. Govinda Nagatkar sir, Dr. Mahesh Kesale sir, and Dr. Vaishnav madam. Thank you for chairing the session. Weekend in the middle of monsoon, many of your colleagues may be roaming all around the Maharashtra and you are in the auditorium. I really thank all of you for being here. And next two talks we will be hearing from the doctors who are from the Tata Memorial Hospital, and they are all the way from Mumbai here to make us learn something new about the hematology at the cutting edge technology. Thank you, Dr. Mahesh Kesale, for being with us today. And thank you, Dr. Govinda Nagatkar, for taking your time out. I know Sunday is usually busy with the family. Your kids are really missing you, but you are here and we are really happy for your time. Thank you, Namita Sunil. एक group photo घेऊया त्यासोबत. Madam, एक photo घेऊया सोबत. Thank you so much. I always thought that now conferences are not meant to be arranged, because in the generation where reels and shorts are there, usually attention span is not that much. But when today in the auditorium I see that auditorium is full and many students are also taking notes from the speakers, I really feel that something good is happening in the town today. Next session is for Dr. Sumit Mirk will come to us for CAR T-cell therapy, a revolutionized cancer therapy, how our own cells will fight with the cancer. He will enlighten us about that overall, the methodology and how Indian CAR T-cells are being developed. For this session, I would like to ask or request Dr. Sandeep Sanap sir to chair the session. Dr. Sandeep Sanap sir is a physician. He is associated with MGM Hospital and he is associated at the Vaidyanath Hospital. Dr. Shyam Hirvekar sir, Dr. Gaurav Baheti and Dr. Aniket Sate, all four of them are in the auditorium. Please come forward to chair this session with Dr. Sumit Mirk. Sumit Mirk is MD Medicine and DM in Hematology, and he is right now working as Associate Professor at ACTREC Tata Memorial Hospital. And because of him now, Tata Memorial initially, yes, one of the premier institute where medical oncology seats were there. Now because of him, Tata ACTREC is having DNB Hematology also available, 2 seats from this year. And we are really fortunate that Dr. Sumit Mirk, as to teacher, is amongst us to teach us about CAR T-cell therapy. Thank you so much, Dr. Sumit. Over to you.
Thank you very much, Manoj sir and Shweta. So today we will learn about CAR T-cell therapy. We must have heard about this in newspapers, in news, from colleagues, from seniors. So let us understand what is this. It's a revolutionary treatment for sure, and it is something which innovates and utilizes your own T cells and your own immunity to fight the cancer. So I request the audiovisual team to hide my video. I don't want to see myself. So let us go through a story. We have a young girl diagnosed with BALL in 2010, had multiple relapses, chemo refractory, had so many infections, necrotizing fasciitis, almost had to undergo an amputation but just avoided it, had an early relapse during treatment, was advised transplant, but the physicians thought that she was too unfit for the transplant. Given a lot of salvage chemotherapy did not work, and her cancer was increasing. And subsequently, she was enrolled into a trial which is called a CD19 CAR-T trial at a hospital in US. And after receiving her CAR-T cell therapy, few days later she was very unwell, high-grade fever, respiratory failure, respiratory distress, shock requiring 3 inotropic support. So you can imagine a patient in the ICU who is having a bad cancer, not in remission, is on 3 inotropes for blood pressure support, is on ventilatory support, what will you prognosticate such a patient? Near death, right? Inevitably in all of these cases. She was induced into a coma because her vital organs had to be preserved, and for nearly 2 weeks she was on the ventilator. And at that time, when one of her primary doctors was in a conference in some other parts in the US, he realized that this is a form of cytokine release syndrome, which we have recently seen in the COVID era. And after that, they measured a lot of cytokines in the blood. And they saw that one cytokine was standing out apart from the others, and that was interleukin 6. To block that, tocilizumab and monoclonal antibody was given, and subsequently she came out of it. Imagine a patient coming out after 2 weeks of ventilatory support, 3 anatropes, and a bad cancer. And not just that, she not only came out of it, the most important thing was her cancer went into remission. So this was she when she was very unwell, when she was very sick. This is she 2 years later. And because her cancer went into remission after a lot of ups and downs, her treatment was named as immunotherapy or breakthrough of the year in 2013. And this is she 12 years down the line, wherein she is potentially labeled as cured. And the word cure is very difficult to use in cancer because unless patients are alive without disease for at least 10 years, the word cure is not used. And you can see her photo last year and the current photo on the right this year, wherein she's alive, cancer-free. And in her name, her parents have started Emily Whitehead Foundation, which helps patients for CAR-T all across the globe. This is Carl June, the person who pioneered CAR-T cell therapy, and he received a Breakthrough Science of the Year award in 2024. And a small documentary is made on this called as Fire with Fire. And if anybody of you have time later in the day, see it on YouTube, and I'm sure you will not be able to sleep in the night because it is so inspiring. So let us understand what is CAR-T. For that, we need to understand what is basic immunity, what is the concept of immunotherapy, what is CAR-T as such, it is efficacious, if it is yes, then what are its side effects, and where do we use it. So going back to the basics. So if you have to see on the left-hand side, you have innate immunity. On the right-hand side, we have adaptive immunity. Innate immunity is these phagocytes, dendritic cells, NK cells. What are they? They can fight anything which comes their way. They are the first to mount a fight against any infection. And in the long run, the adaptive immunity takes up, which is full of T cells, B cells. And the T cells become effector and memory T cells, and then they preserve that immune response with them. The earliest response is by the innate immunity, which is irrespective of whatever pathogen it gets, whereas the second response, which is more controlled and sustained, is called as adaptive immunity. So innate immunity is NK cells, macrophages, dendritic cells, monocytes. They destroy virally infected cells. Importantly, it is independent of what you call as MHC, major histocompatibility complex, or in other words, HLA, that is human leukocyte antigen. So it is independent of MHC, and it kills whatever comes their way. It is faster in action, but unfortunately it is not potent, and it is not well sustained, which means it is only for a short duration. On the other hand, adaptive immunity is B cells, T cells. Importantly, they are specific, which means they will target a specific thing. They need MHC, or major histocompatibility complex, to target that specific antigen. It is slow in onset, but the biggest advantage is they are more potent, they are sustained, and they have a memory, which means in future response to the same antigen, they'll mount a reaction faster than it was supposed to in the first response. So it has memory. So if you go back to the basics of immunology, in the adaptive immunity you have CD4 T cells, you have CD8 T cells. And both CD4 and CD8 require a certain amount of what you call as T cell receptor on their end. And then they also require MHC on the other host cell end in order to kill that specific antigen on the host cell. So in essentiality, whatever CD4, CD8, T cells, whatever we know, it has a response which is mediated via MHC. So as a student, many of us, even I used to think that why does cancer happen? Why does normal immunity doesn't control cancer? Why does normal immunity doesn't kill cancer? And many, many years ago, Paul Ehrlich told that humans are brought up in a way by their own immunity that they have to avoid autoimmunity. which means that our immune system doesn't destroy our own tissues, and that is why they are averse to our own tissues. Now, majority of these cancer cells antigens or tumor antigens, unfortunately, are self-antigens, which means they are also expressed on host tissues. Now, because they are also expressed on host tissues, the own immunity doesn't kill them. Even if it does kill, it is often transient and not well sustained. So what can be done? So if you see this on the figure on the right hand side, we can see that the top panel shows the normal immunity, a T cell with a T cell receptor killing a host cell with the help of an MHC antigen, and it also requires some fast ligand which triggers apoptosis. Now unfortunately what happens, cancer cells are smart. It knows that the immunity is utilizing its own MHC to kill it. So it downregulates its own MHC, it downregulates its own HLA so that it is shielded from that immune kill. So cancers are smart. Can we become more smarter than them? So let us see that. So the concept of immunity, immunotherapy has been a long journey with a lot of ups and downs and a lot of failures. So this is what you call as the normal lymphogenesis. When you start from a bone marrow stem cell to a lymphoid progenitor cell, it then gives rise to the T cells and the B cells. Now, if something which is deficient at the lymphoid stem cells itself, like adenosine deaminase, which is a very important enzyme for the whole lymphoid community, the entire lymphoid arm will get spoiled. So, in deficiencies like adenosine deaminase, which is one form of severe combined immunodeficiency, when you don't have any T cells, no B cells, the patient hardly has any immunity, they are prone to infections, and majority of them die within the first few years of life. But the important thing is that majority of these disorders have a monogenic disorder, which means that one gene is defective, and if you can replenish that, then probably you can recover what is lost. So this was the first time in the late 80s and early 90s that they thought that you can reintroduce the deficient genetic material in the human body by virtue of few vectors called as lentiviral retroviral vectors, and you take these cells from mice and you do these experiments in mice, and they show that a virus was able to insert these specific deficient genes into the cell and replenish what was deficient. So this is a story of David Vetter. He was also called as Bubble Boy. A famous movie was made on this. His parents diagnosed that their child have severe combined immunodeficiency. He is prone to multiple infections. So his entire life he had to stay in a bubble so that he was not exposed to the environment and he was not exposed to infections. If you can see his life, if he had to play with his peers and colleagues, he used to be masked like an astronaut, or what we used to don in the COVID era, all these astronaut-like suits, and used to play so that he could be alive. And subsequently, a few years later, because of the pioneering work in 1984, which showed us that a virus could integrate an extra gene into the cells, few recipients underwent called as gene therapy for severe combined immunodeficiency. And the first lady, who was a Sri Lankan national called Ashanti De Silva, subsequently underwent a gene therapy, and one of her subsequent patients, they are alive 25 years down the line. Which means that this brought us to the concept that if something is deficient, you can replenish that by virtue of inserting the gene with the help of a viral vector. So what is CAR-T? Can we extrapolate the same immunological concepts what we had previously to cancers today? So if you go back again to the normal immunology, you have a normal T cell receptor on the T cells, and then you have the host cell or the target cell or the cancer cell, which again expresses some HLA or MHC, and by virtue of this combination, it targets a tumor antigen. However, as we noted in the previous slides, the most important drawback of normal adaptive immunity is that it requires HLA. The most important thing which cancers have overtaken us is that they can downregulate their HLA, because of which even post-transplant patients have a relapse of their cancer. So if this is a component of cellular immunity, can we borrow something from humoral or antibody-mediated like immunity? So this is an antibody. We must have seen these antibodies in drugs like rituximab, daratumumab, so on and so forth. So this is an antibody. It has on the inner side, the longer end has the heavy chain, the outer side, the smaller one has light chains. And the most important is a variable domain, which means that that variable domain is specific for that antigen. It will go and kill that respective antigen or mount a response against that respective antigen, and it doesn't need an HLA for doing that. So this is the advantage of humoral immunity. It has specificity but does not rely on HLA. On the first hand, the cellular immunity is also specific but requires HLA. So can we combine both of them into one picture and use that potential to a fullest extent? So as you can see in the subsequent third diagram, the internal part of the T cell is the same. Only the external part of the T cell, which is the T cell receptor, which was using HLA to bind the respective cancer cell antigen, is being replaced by the variable domain of the antibody, which means you take one fragment of the antibody, insert it into the subcellular part of the T cell receptor, and because of that you make a modified T cell receptor. And this modified T cell receptor can then bind to that specific antigen irrespective or overcoming the need of HLA, which means that when cancer cells are downregulating their HLA, but they are having their antigens on their surface, they can still be targeted, which they were not previously able to be getting targeted for. So this is what is called as chimera. Chimera means a mixture of two or more individuals in one person or in one individual. So chimera is the head of a lion, the body of a goat, and the tail of a snake. And as per the famous Greek mythology, it is called as a fire-breathing female monster. Now, why they have labeled it as a female, husbands can understand in the audience. So this is what is called as chimera, wherein you combine few things together and then you use that for disease biology. So this is a chimeric antigen receptor. What was normally a T cell receptor is now a mixture. It is a chimera. It is called as a chimeric receptor. So these are engineered T cells. These T cells are not born with it, but they are engineered or modified. Because of this engineering, you graft a specificity onto the effector cells, which are T cells, and because of this modification, it augments the T cell function. So how do we make it, or how does one make it? You take out the patient's own T cells, you insert a modified receptor into the T cells with the help of a viral vector. It can be a retroviral vector, lentiviral vector, and then you make what is called as a chimeric antigen receptor bearing T cell. And then you expand these T cells outside the body, which means in the lab. And then you infuse these own modified CAR T cells or T cells with a chimeric receptor into the body, which can then go and kill the cancer. Which means these are autologous, the patient's own T cells which are modified, primed in a way to kill the patient's own cancer without any external help from outside. So what happens when you give them, just like normal biology, its innate potency is to expand, its potency is to multiply, so it will go and multiply, and then it will give long numbers of memory T cells which have this modified receptor into their body. So it will be like a living drug into the body for a long time. So what did we gain with CAR T in a way? In the first, you saw that the T cells was able to kill the target cell with the help of an MHC. The cancer cells became smart, but then we overcame that by using a modified chimeric antigen receptor. So if you have to summate the components of innate and adaptive immunity, which is getting used in CAR T cell formation, the most important thing is it is MHC independent and it is antigen specific, and importantly it has memory for sustained action, which means that you have bridged the innate and adaptive immunity together into a current novel form of immunotherapy, which is called as CAR T cell therapy. So it is the perfect intersection of immune therapy, cellular therapy, gene therapy, and if you combine this mix, this is called as CAR T cell therapy. So there are multiple generations of CAR T. In the first generation, you have the simple structure as we explained. So this is like your captain of the Indian cricket team, Rohit Sharma. He is good, but probably you can make him better. And then if you add an additional co-stimulatory domain, which means the response of the T cell will be more and more sustained. So it will be more and more better. So if you add Jasprit Bumrah, yes, you have a good batsman, you have a good bowler, so you have a good combination. If you add more co-stimulated domains and if you have the aggression of Virat Kohli, yes, you can win multiple games. And lastly, your T cells, which have multiple co-stimulated domains, can release a lot of cytokines and factors which go and kill the cancer cell in addition to what you're additionally doing. So if you have such a formulation of team, then you can probably win any World Cup. So the typical concept is that before giving CAR T cells, you give some medicines called as lymphodepletion, so that the patient's own T cells which are there in the body, they don't compete with coming T cells which have a modified receptor, and then it prepares the space and surface for the incoming modified T cells. So you give some drugs called as fludarabine or cyclophosphamide, which is called as lymphodepletion, to just before the CAR T cell infusion. So most important is, where is this novel form of therapy used and where it is useful. So there is something which is called as CD cell markers on the surfaces of cells, and they're also present on the surface of the cancer cells. So one of them is CD19. So it is restricted to the B cell compartment. It is not there on the stem cells. So if you target that, the stem cells will not be damaged, but only the B lymphoid cells will be hampered. And the most important thing is, even if it targets the normal B cells, you will get less antibody production. But then you can replenish those IVIG or immunoglobulins from outside by giving antibodies. So while it will have a side effect which will be decrease in the immunoglobulins, but you can always supplement that from externally, and that is one way wherein you can overcome the cancer. There is some targets on the surface of myeloma cells called as B cell maturation antigen, and this is also restricted to the plasma cell lineage compartment. So the indications typically for disorders which have a lot of CD19 expression, for example, B acute lymphoblastic leukemia, high-grade lymphomas like typically the diffuse large B-cell lymphomas, and in today's era we also have it for multiple myeloma and to a certain extent for chronic lymphocytic leukemia. So all well done, we've understood the mechanism. How does it actually pave out in the real world? How many patients' lives are getting saved because of this novel therapy? So if you have to look at lymphomas, the large B-cell lymphomas before the era of CAR T-cell therapy, which means only in the era of chemotherapy and immunotherapy which have rituximab with it, the long-term outcomes are not more than 20%, which means a person who has a relapsed DLBCL, the long-term chances of him doing well in the long run is not more than 20 out of 100. Now, in the era of CAR T-cell therapy, you can see that the curve, which is the orange curve, which is standing out, it is doing well with respect to 40 to 50% long-term outcomes in the long run for the same patients with relapsed DLBCL whose outcomes was 20% or lesser. Now, if you look at other studies which have again compared it with the previous conventional chemotherapy, again it is better to the tunes of at least from 20% to 40 to 50%. When you see it for mantle cell lymphoma, again it is close to 50 to 60%. And when you look at for acute lymphoblastic leukemia or BALL, 25 to 30% do well in the long run, which in otherwise contemporary chemotherapy era was hardly less than 10%, which means you're able to salvage at least double the number or more number of patients as compared to your conventional treatment with this novel form of immunotherapy. Coming to myeloma, multiple myeloma is a relapsing disease, it's a remitting disease. Unlike acute leukemias, you cannot cure it, you can keep it under control. So you have to give some form of treatment lifelong. If the patient is receiving transplant, they receive induction, transplant, consolidation, maintenance, and as far as they don't relapse, they will receive the maintenance. And once they relapse, they'll again receive some form of therapy and again maintenance. So it's a disease wherein you have treatments and treatments and treatments, and you still cannot cure it. Now coming to the latest data which was published 2 months back is CAR T-cell therapy for relapsed myeloma. You can see that 1/3 of the patients are progression-free, which means alive without any evidence of relapse, 1 out of 3. And this is importantly, it's a single treatment, which means there is no follow-up treatment, no maintenance for these 1/3 proportion of patients. And half the patients are surviving, at times with relapse, at times without a relapse. So this is much better than the conventional era, wherein this outcome was again less than 20%. So if it is so good, so effective, does it have any side effects? Yes, it does have. So it's a T cell, it's a modified T cell, It's a modified T cell which is known to expand. It's a modified T cell which is known to proliferate. So when it proliferates, it expands, it releases a lot of cytokines, and this is what is called as cytokine release syndrome. So in the COVID era, we must have seen ARDS, cytokine release syndrome, given tocilizumab. Something similar happens in the first 2 weeks of CAR T-cell therapy. High-grade fevers, at times with a drop in blood pressure, at times requiring oxygen support. You will do infective workup, it is negative, and this is typical of cytokine release syndrome, where there is a lot of inflammatory markers, and this is inflammatory fever or immune fever. It can manifest with fever initially, but if we don't control it well, it can progress to organ dysfunction and multi-organ dysfunction also. It can cause neurotoxicity also, which is called as ICANS or immune cell neurotoxicity syndrome, wherein patients with the previous cytokine release syndrome get some form of headache, somnolence, vague dizziness symptoms or vague neurological symptoms, and for this you require specific drugs like anakinra or dexamethasone, which will penetrate the brain. Does it have long-term toxicities? Yes, the CD19 CAR T, which I told, which targets the B cells, it not only targets CD19 on the cancer cells, but also targets CD19 on the normal B cells. So because it targets the antigen of the normal B cells, it decreases the amount of immunoglobulin production which normally happens, and that can lead to hypogammaglobulinemia in the long run. That is why these patients require regular IV immunoglobulin supplementation from outside to prevent viral infections which happen in these patients. And this is the pictorial diagram for students, wherein you have the first month, which is full of cytokine release syndrome, neurotoxicities, and subsequently they can still be exposed to some viral infections because of hypogammaglobulinemia. So coming to what is the data from India? Everything has been published in US, in Europe. What is our setting? What is our reports? So the first one and the second one are both our data from Tata Memorial Center. The first one is for pediatric and the second one is for adults. And you can see that close to 70% patients responded in the first one. Half of the patients surviving 1 year down the line, which was previously again less than 20%. And on the right hand side, you can see that amongst this cohort of 13 patients, 7 were doing well at 1 year down the line and in remission. What is the data from other centers from India? The first is the data from CMC Vellore, and the second is a collaboration of a company which is called as Immunil. So in the first one is a very novel and innovative one, wherein they have made such a product wherein after taking out the T cells, normally it used to take at least 4 weeks for producing these CAR T cells in the lab. But in this CMC Vellore data, after taking out the T cells, they used to manufacture it in 9 to 10 days, which means that in a week's time, you can take the patient for CAR T cell infusion. So you can see that after collecting the T cells on day -10, after 72 hours, they just start the lymphodepletion, and in 10 days' time, they infuse the T cells. So the waiting time of manufacturing has come down from 4 to 5 weeks to less than 2 weeks as per the CMC Vellore data. And this is again data from Immunil subset, which shows us that it is very tolerable in the Indian setting with CRS rates or ICANS rates which are very less as compared to what is reported from the Western data. And it is very encouraging to share that our government has approved 2 CAR T cell therapies as of now, which is only 10% of the cost as compared to what it is available in the West. So what lies in the future? Cancer cells are smart. If you target them with the CD19, they will downregulate the CD19. So you can target 2 antigens together with the CAR T cells so that it doesn't escape. You can use T cells from normal humans called as allogenic T cells, make CAR T cells in them and use them as and when required for any patient. It is called as off-the-shelf CAR T, which means it's like a drug in your pharmacy. And it can challenge the role of autologous transplant in newly diagnosed myeloma in first-line setting. So these are some success stories, and the 2 people on the top right, Dr. Rahul Purwar from IIT Bombay and Dr. Gaurav Narula sir from Tata Memorial Center have pioneered for the first CAR T cell therapy for India. On the left-hand side, you can see that this is a pediatric patient who is doing well in the long run. On the right-hand side, an adult patient who is doing well in the long run for lymphoma. So some important success stories. So it's something to leave on the note that the future is bright even for relapsed refractory cancer patients with CAR T cell therapy. Thank you.
Excellent talk, Dr. Sumit. Thank you so much for making such a difficult topic, the complicated CAR T cell therapy, in a very lucid, simple language to understand all of us. I request chairperson, if any question, comment is there, or auditorium, if any question, comment is there, please feel free to ask. Dr. Sumit is here. Anything? Yes, Sachin sir.
I think I heard him second time. Basically, these cells are collected. C for collected, A for armed. They are armed with that CAR, chimeric antigenic receptor, and they are reinfused CAR, and then they target the tumor cells. That's how it works, I guess.
Thank you so much for making it simpler version to understand. So I request chairperson to please felicitate Dr. Sumit Mirg. Please come on dais. I request Bhattu madam to please felicitate our chairpersons. Madam is here in the auditorium. Can you please come on dais, madam? Thank you. All four are enthusiastic young physicians who are leading the front in Sambhajinagar. And I am very glad that today's theme, young people should come forward, and all the speaker and all the chairpersons are young. Thank you so much, Bhattu madam, for being here. हे कोणाचं आता तू ये डॉक्टर श्याम हिरवेकर क्या हे कोण आहे डॉक्टर Thank you, Dr. Shyam, for taking your time out. Dr. Gaurav Bahiti. Thank you, Gaurav, for being here. Your daughter must be missing you on this Sunday, but we are really glad that you are here with us. And Dr. Aniket is here with us. Thank you, Aniket. Thank you, Dr. Aniket, for taking your time out on this busy Sunday, for being with us on Hematology Summit 2025. We are really glad to have you. Sumit, आ जाओ प्लीज एक फोटो लेते प्लीज एक फोटो घेऊयात मॅडम थांबा प्लीज प्लीज Thank you everyone for being here, and thank you for excellent talk, Dr. Sumit. Now, next talk is by Dr. Bhausaheb Bagal. He is consultant in Tata Memorial Hospital. He is professor in medical oncology, teacher to me, elder brother to me, and person for whom I have very high regards, someone I really like. the most as a consultant, as a physician, as a person. I am really glad that Dr. Bhausaheb Bagal is with us today for his talk on multiple myeloma. For this session, I would like to request Dr. Nilofer Patel to chair this session. Dr. Umesh Malu is here. Dr. Shweta Sikchi, she is in the auditorium. She can chair the session. Please come front. And Dr. Sanjay Devare sir is here. I request him to please come forward to chair this session for Dr. Bhausaheb Bagal. And over to you, Dr. Bhausaheb Bagal. Everyone is eager to listen to you. Thank you so much, sir.
Thank you, Manoj and Shweta. I think it is good to be back to Sambhaji Nagar. For those of you who don't know, I'm from Jalna, and Manoj, I didn't miss much. I was with my family, friends, and my farmhouse, so I didn't miss much. My slight quality may not be very good, so forgive me for that, but let's see. Manoj asked me to speak to the audience, which is a mix of physicians, students, and maybe our oncology and hematology colleague. And I think it's a bit of difficult task, but let's see what I can do to this. So I will talk briefly about introductions, what are monoclonal gammopathies and these plasma cell disorders. We'll see an interesting study, and I am sure student in the audience will definitely like this study. We'll see the clinical features of these plasma cell disorders, how do you diagnose these people, and briefly about how do we risk stratify and treat these people with plasma cell dyscrasia. So I will start with the case which I treated in right in the raging pandemic. So she was an elderly lawyer who still was practicing, who on routine screening for routine testing during her COVID found to have anemia, just hemoglobin of 11.9 and raised globulin. So the physician ordered for electrophoresis. That showed an M band of 1.9 gram and raised free light chain assay. And her bone marrow was done. It showed plasma cell, a fish panel, which is a genomic test to see what kind of myeloma this person has, what is the aggressiveness, which was done, which was normal. And she was, she came to TMH for further treatment because she was labeled as having multiple myeloma. And let's see in the due course what happens to this elderly lady. So let's start what are plasma cell dyscrasia. So as name indicate, these are the disorders which arise from the plasma cell, and as you can see, plasma cell arise from the B cells. They develop from the B cells in the lymph node, and as lymph node has two parts, as you know, the dark zone and light zone of the germinal center. In the germinal center, when these B cells sort of develop or mature, they undergo something called as somatic hypermutation. That is their natural tendency to undergo mutation, so that they develop an antibody which is a perfect fit to the antibody. So this is somatic hypermutations, and these cells become something called as memory B cells. After this, these cells, when they are exposed to a complementary antigen, they survive, and this exposure is mainly by the antigen presentation by dendritic and T cells here. If they don't expose to this antigen, these cells die. And after this, these B cells called as plasma blasts now, they leave the lymph node for bone marrow, so they come and home in the bone marrow. And once in the bone marrow, they reside there, they produce normal plasma cell produce immunoglobulin, which help us to fight infections and they keep us fit. But what happens in very early in the stage, during this somatic hypermutation stage, or the class switch reaction, this cell develops some genomic abnormalities. The start of this plasma cell dyscrasia is very early, that is in the lymph nodes, and after many years or sometime decades, they develop into something called as a frank plasma cell dyscrasia. So subsequently, we'll see what are these plasma cell dyscrasias. So as I said, these genomic lesions are very early event, and these are called as initiating or founder event. So these genomic lesions would be there throughout the disease of this patient course, and when you do genomic testing, you will always find these genomic changes. But when you when the disease evolves, these people acquire something called as secondary abnormalities. So these are abnormalities which probably are responsible for progression of the disease and changing the tempo of the disease. So for some time, this disease will keep quiet, and after some time, this disease will become fulminant, and which will manifest in terms of a frank plasma cell disorder or myeloma. So what is happening in this disease is you have a normal cell, you have a clonal plasma cell, which is very early and initiating event. We have a progression to slightly higher or aggressive form of disease called as smoldering multiple myeloma. then a frank multiple myeloma, which is typically a plasma cell related cancer, you can say as of now, and end or terminal stage something called as plasma cell leukemia, which is a very aggressive and a very fulminant form of disease. And along the way, you can see this plasma cell burden in the bone marrow is increasing, so number of plasma cells are increasing. The M component, which is the secretory component or tumor marker for disease, is also increasing. And this is how you can pick the patient at different part of the journey of developing multiple myeloma or plasma cell disorder. So you saw this sort of slide in Sumit's presentation, and what you can see is in the initial part, the MGUS, or smoldering multiple myeloma, you can say precancerous parts of this disease, the M band is very low. As you become multiple myeloma, you have a high burden of multiple myeloma, reflecting in terms of the M band, which is going up there in the middle part of the slide. And in the left hand side, when this disease becomes relapse or refractory, the M band tend to become not only more in terms of quantity, but it doesn't respond to treatment. So this is the terminal or last relapse refractory multiple myeloma stage, as you can see. So this is the clinical model for plasma cell dyscrasias, and your patient may fall at different time point, like when you do the testings. So someone may be asymptomatic and have a MGUS or a smoldering condition, or someone may be symptomatic, has a frank plasma cell disorder. So what this leads to is, if you do the M band testing in the community hospital and if you find a M band, that doesn't mean that the person has multiple myeloma. That can be the early stage like MGS, and if you do this in community, more than 50% of the time this person doesn't have a malignancy. This is just a finding which is called as monoclonal gammopathy of undetermined significance. Roughly 15 to 20% of people of this will turn out to be multiple myeloma. There are other disorders like amyloidosis, lymphomas, macroglobulinemia, etc., where you can have M band. But the point here which I want to drive is, M band is not multiple myeloma. If you find M band, you have to figure it out, what is the relation of this M band to the clonal nature of plasma cell, and then figure out what is the current situation of this person in the journey of plasma cell dyscrasia manifestation. So we call this precursor condition MGUS and smoldering multiple myeloma, and these are very important because they are 10 to 20 times more prevalent than actual multiple myeloma in the community hospital. So the chance that you would see this kind of patient is much more than an actual multiple myeloma patient, and then you should be kind of well versed with this. So we describe MGUS and smoldering multiple myeloma in a person who just has a M band but doesn't have any multiple myeloma related manifestation. And depending upon the quantity of M band present, the urinary Bence-Jones protein excretion amount or quantity, and the proportion of plasma cell in the bone marrow, it is divided into smoldering multiple myeloma versus a MGUS, which is a slightly earlier stage of the disease. Moving on, when you develop CRAF feature, the traditional teaching of calcium, renal, anemia and bone, if you develop CRAF features, we call something called as multiple myeloma. But now we have added to this something called as SLIM. SLIM stands for S for 60% plasma cell, L for light chain ratio more than 100, and M is MRI showing a lesion in the bone marrow, which is still not affecting the bone. So this SLIM, this is a biomarker. So your person may be normal, but has this biomarker which is going to tell us that this person is going to develop a frank multiple myeloma within few months to few years time, and it is best to treat. So now we use something called as SLIM CRAF to label something as a having active multiple myeloma, meaning this person will require a treatment for multiple myeloma so as to avoid the end organ damage or having damage because of the high plasma cell burden. Now let's look at the rate which this disorder progresses to multiple myeloma. So if someone is diagnosed with MGUS, the chances that this person is progressing to multiple myeloma is 15% at 15 years. That is 1% per year. So very low chance. That means we need to counsel this patient, tell them that this person, the chances of you developing multiple myeloma is very low. There are ways and means to risk stratify and predict a person's prognosis in, but definitely something to work up and counsel and plan a follow-up accordingly. If you look at the smoldering multiple myeloma, the other precursor condition, the rate is very high. It's exactly opposite. Like most of the people, like more than less than 20% of the people would be myeloma free at the 20 years timeline. That means these people would have a different plan of follow-up. They would be monitored more closely, and they would probably require treatment in their due course of time. So this is how a precursor multiple myeloma condition, a normal person with M band would be follow up in a community-based practice or with in consultation with a hematologist. So what is boiled down to is these are precursor conditions. The M protein is your calling card or a trump card, and you have to take an exact decision when you want to treat these people and when you want to have a restraint and not to jump the gun and treat these people immediately. I think that's very vital because you are going to label these people as multiple myeloma, or for a lay person it becomes very difficult to accept the diagnosis of cancers, and I think this is a very thin line which we have to respect or keep in mind when we counsel and work up these patients. So final algorithm for us and undergraduates, it is very important when you get a person with a monoclonal M-band, you look whether person has clinical signs and symptoms. If yes, are they because of myeloma? Those are called as myeloma defining events. If no, then you do certain investigations and rule out these slim crabs and you label this patient MGUS or a smoldering myeloma. There are uncommon disorders which can be associated with monoclonal M protein, and that's why it is important to evaluate these people for other disorders, like they can have MGRS, so monoclonal gammopathy of renal significance. The M band is very low, but it is damaging the kidneys, so that's called as MGRS. And we group these disorders according to the manifestations. They can be neurological manifestations. There would be inflammatory disorders associated with other syndromes like Poem syndromes and some neuropathies, etc. So these would be things to work up in a person with M-band but no multiple myeloma. Moving on, so I said we'll see about a very interesting study which was done in a country called as Iceland. And the Iceland's population is exactly half of Sambhajinagar's population today. So what they did was they screened all their people who were above 40 years of age for having an M-band. And half of the people above age of 40 agreed to participate in the population. So they have very huge sample size of roughly 1.5 lakhs people giving their sample to look for M-band. And their goal was to what is the prevalence of M-band? So how many people would have M-band? What are the associations? What happens to this? Because this seems to be a big problem because as you would say from the result. So what did they is they screen these people and they label these people MGUS if they didn't have multiple myeloma. Obviously patient with multiple myeloma and other defined entities will go on to treatment. And after this they randomized 3 people into no further workup. So as if you have done no testing, you will be going back to your community physician or doctor. In the second arm, they followed the guideline. What I told earlier, how do you follow MGUS and a smoldering multiple myeloma. And in arm 3, they did an intensive workup. So let's see what happens to these kind of things. And this is a very good study which is going to give us many answers. What are we going to do this kind of iatrogenic diagnosis or problems which we create by screening. So important findings are this is a very common disorder. So 5% of the people above 50 and 7% of people above 70. That means at least a dozen or half a dozen people in this hall are going to have this disorder today. And not to get scared, but it has implications beyond cancer. So most of these people would not develop multiple myeloma, but they may have other associated disorders like cardiovascular disorder. They may develop kidney related problem. They may have neuropathy, etc., which are kind of very treatable if diagnosed and treated early. And definitely there is a small but a finite and predictable risk of developing into cancers, and there are studies ongoing to see if we can prevent or treat these people early so as to improve their outcome. Moving on, I think the final conclusion of this is that M protein, when they are found on a screening, they are not innocuous and they need to be worked up diligently. Then we need to rethink our clinical management in a person with M-band because not everything is as straightforward as it looks, and more studies or research is needed in this field because this is a very significant and common prevalent problem. Now we move on to the multiple myeloma and let's look at some of the features. So we saw anemia is one of the common problem in the community practice as well as in community hematology practice, and this important and common problem of CRAB. But it is important to keep in mind that anemia in multiple myeloma, if it occurs in isolation, then first thing is it because of something else? Why don't I have all other manifestations? There are various causes by which you develop anemia in patient with multiple myeloma. It's just the physical replacement of bone marrow, the cytokines secreted by these abnormal plasma cells, kidney dysfunctions, and various other factors. As well as many of our patients would have concomitant nutritional deficiency. So definitely when you have myeloma, you figure out why your patient has multiple, doesn't have other manifestations of myeloma like our lady had. The next feature is the bone. So bone typical teaching is you should have a lytic lesion. But as we understand, lytic lesion takes time to develop. That's why we have other ways of looking at this. But lytic lesions, I think important thing to look in community practice is if a lesion which is painful, which is aggravated by a movement, which hampers with your with your sleep, or which is nocturnal and which is restricted to central skeleton, ribs, spinal cord, proximal girdle bones, etc. This is something very. I think one of the student asked me some time back, why do you get nocturnal pain? And in fact, one of my very intelligent patient, his job was working. So he said, I was working for 6 hours, 8 hours a day. My job is standing, but I never had pain in the day, but I get it in the night. So I think this is a typically described thing. And the answer to that is, when you sleep, your muscle which are active in the day, they go into the spasm mode and they protect your bone from getting pain. But when you sleep, this spasm goes away and you get pain, that kind of pain. So definitely these are called as red flag sign. This lighting lesion could be because of some other things also. But these are the things which should not be ignored in a person with back pain, because back pain, that is a very common complaint in the community practice. Moving on the imaging, I think this is a day and age where imaging is very easily accessible. In olden days, we used to rely on the skeletal surveys, etc. So we look at three imagings, the whole body low dose CT. The CT here is low dose. We don't want to expose this patient to a conventional dose of radiation in the CT scan. So low dose radiation CT, which is very sensitive for detecting lighting lesion. The next is whole body MRI. So what MRI looks at is, it is better at looking at soft tissue and also at looking at bone marrow. So we'll be able to figure out what is the health of the soft tissue. For example, does this person have soft tissue plasmacytoma? It is useful modality if someone has a cord compression, etc. And also the bone marrow, which is inside the bone, and early changes can be detected in this. So one of the slim feature is caught here. And the next interesting modality is FDG PET. So FDG is fluorodeoxy. It is glucose being metabolized by the cancer cells at a higher rate than the normal counterpart. So these lesions lit up, we call as FDG avid or FDG metabolizing lesions. But there is also good modality, and another use of that modality is to assess the response. But problem is, roughly 15 to 20% of the multiple myeloma would be non-FDG avid, so you may have a false negative scan in such kind of patient. If you do PET and CT together, you may have a CT component showing a lytic lesion, but PET doesn't show avid lesion, but still multiple myeloma cannot be ruled out. So these are small things. So based on this, usually we decide what would be the best modality in the individual patient. If I am looking for a person who has a chance of extramedullary disease, I will pick PET scan. I want to follow this person with PET scans, I will be doing PET scan. If someone has cord compressions, then I will probably look at MRI, etc. So this is a way of choosing the lesion. So, so this is an image of low dose CT, which seems very unreal if you are not used to looking at this. This is MRI. Again, the point here is look at the soft tissue and the bone marrow inside the bone. We are not looking at bone by doing MRI. And this is a florid disease seen in these scans. And PET scan shows this FDG avid lesions, which in fact has disappeared in this patient after treatment. So this is the utility of three modalities. Moving on, renal impairment. That is a common problem if you have renal failure. Most of the times people would be looking for a treatable cause. So when I was doing my nephrology posting, my SR used to sell, for nephrology, urine is the gold. And if you have a patient with multiple myeloma, it's a jackpot, because you are going to avert a very long treatment, so dialysis, transplant, etc., etc. So I think it is important to diagnose renal impairment with multiple myeloma early, so that these people don't end up having renal failures. So the way it damages cast nephropathy, these renal tubules are choked by the light chains which are produced by the plasma cells. Other causes are hypercalcemia, direct plasma cell disorders. Many times people use NSAIDs, etc. Then you can have renal amyloidosis, and that's a slightly different manifestation than a typical multiple myeloma. And the last term, which is MGRS, where we have monoclonal protein, and you find out by doing a kidney biopsy that this is damaging the kidneys, something called as MGRS, which is most of the times diagnosed by a nephropathologist. But I think the important clues to diagnosing multiple myeloma in a person with renal failure is a normal size kidney or sometimes enlarged size of kidneys, hypercalcemia, and third thing is increased globulin. So keep in mind that you don't want to miss this kind of renal failure. And we don't do kidney biopsies for all patients with multiple myeloma if it is attributable to multiple myeloma. So the catch is, if you should have a serum free light chain more than 500 and a significant light chain urea, then you assume that these light chains are damaging the kidneys, and that's called as cast nephropathy, and you don't have to do a kidney biopsy. But for our other patient, you need to prove that this M band is damaging, because as I told you, in the community, the chances of person having a monoclonal gammopathy and renal failure of, say, because of diabetes or hypertension is much common than the person having multiple myeloma. Moving on, there would be other symptoms of multiple myeloma, like neurological symptoms. We can have frank cord compression, you can have neuropathy, you can have radiculopathy and other things, and rarely hyperviscosity. It can be seen in much more common in other plasma cell disorders than multiple myeloma. Infections is one thing which is often kind of very difficult to catch if someone is not having frank manifestations. So these people will develop typical infection in the lung like pneumonia, pyelonephritis by capsulated organisms, and there will be caught when you investigate these people. So that's one thing to keep in mind. And when we treat these people, when a person with multiple myeloma comes to you in the community after he is being treated, it is important that this person would be immunocompromised because of the treatment as well. He will be receiving monoclonal antibodies, steroids, maybe neutropenic, and these infections should be treated very promptly. I think it is important to have at least 1 minute on amyloidosis, because this is a diagnosis which is often taught to us that it is delayed, and it is because it has varied presentations in general practice. So multiple myeloma, to think to look at is frothy urine. So the person has proteinuria, this is leading to frothy urine. Macroglossia, so tongue enlargement because of the amyloid deposit. Similarly, deposit can be in the musculoskeletal system, and you can have appropriate enlargement or restriction on the moment. Cardiac amyloidosis, I think this is a very important diagnosis to be done early, because person with early stage cardiac amyloid have excellent outcome, while the patient with advanced stage usually have a very dismal outcome with the survival measuring in few months only. Many times peripheral neuropathies and GI symptoms are difficult to pinpoint in a one go or first consultation, but I think if something is not fitting, some patient is coming to you repeatedly, and this is an important diagnosis or differential diagnosis to keep in mind. So this lady I saw some years back had a florid skin amyloid deposit. So you may not have that kind of deposit in when you see patient in community early. She had a shoulder fat pad sign, the deposit there also. I will run through the investigation quickly. So what we do is we do look at anemia by doing a complete blood count. Also look at the circulating plasma cell, kidney function test to see what is the status of the kidney. And important is LDH and beta 2 microglobulin, which are sort of tumor markers for multiple myeloma. I think it is important to understand what are M band, how it is done by tests like serum protein electrophoresis, which shows you M band, immunofixation, which gives you exact type of the M band, and nephelometry, which gives you the estimate or what is the concentration of M band. And the next thing is serum free light chain assay. So if you do SPEP immunofixation and SFLC in a person, you have a very good screening test to rule out multiple myeloma in patient. And just to put a point here, serum free light chains are different from the complete light chain. So what happens is, this is a normal immunoglobulin. So this is a hidden portion of light chain, which is two light chain adjacent combined by the disulfide bond. But when they become free, they are not attached to each other. So this is how they are tested, by having a specific antibody against the hidden part. So hidden light chains are different from the combined light chain. Many times we miss this kind of information when we are not used to looking at this kind of report. And if you use these two tests, electrophoresis, immunofixation with serum free light chain, and if this is normal, you can be very sure that your patient doesn't have multiple myeloma. And these are kind of algorithms you have to follow when you are just SFLC. The very important message from the Nordic study, that the light chain can vary from as per the age and as per the GFR. The next is bone marrow test. So when you plan bone marrow in the community, many times there is no idea that what we want to look. But besides morphology, we need certain tests like flow cytometry, so as to demonstrate the clonality. The biopsy, we need to look at exact percentage of plasma cell, because as I said, the type of plasma cell dyscrasia will depend on what is the percentage. We want to see the exact characteristics, so we need to do cytogenetics. And sometimes it can be patchy. So if bone marrow doesn't have adequate clonal plasma cell, you cannot rule out multiple myeloma. That's why I think it is important to consult and plan this in consultation with a proper person when you plan a bone marrow in the community setting. Other investigations, sometimes fat pad biopsy to demonstrate amyloid. Renal biopsy, as I said, you will require in certain cases. For POEM syndrome, so the nerve conduction studies and serum VEGF levels, etc. And as we discussed, other causes of anemia like nutritional deficiencies and bleeding, etc. need to be finally, I will move on to risk stratifications and treatment. The point here I want to make is not everyone with multiple myeloma has the same outcome. For example, if someone has a high risk multiple myeloma, the person's lifespan is probably 4 to 5 years. But if someone has a low risk multiple myeloma, he is going to live more than a decade. Probably what estimate of survival which we give him today may not be valid by the time he lives for 10 years. Those are kind of advances we are seeing in this. So we use cytogenetic information in the bone marrow to risk stratify besides the tumor marker which I said earlier. And this will give us an idea how aggressive we should be and what kind of counseling we should plan for this kind of patients. Another important test is to do a residual disease assessment after treatment. So we have very sophisticated tests like flow cytometry, which are able to count abnormal plasma cell at a level of 1 in maybe a million or 10 million cells, and they tell you, so this is the level of response which we have. And if you have excellent response, you do well. If you don't have that kind of response, you don't do well. So these are kind of tests or refinements which can be done once you start these people on treatment, and can help you to tailor the treatment also. And these treatments are very prognostic. For example, in this study, if you achieve MRD negativity, so you have a very good response, your outcomes are better irrespective of what you treat that patient with, whether you transplanted or not. So these are kind of newer prognostic tools which we use in our clinical practice. Managing multiple myeloma, so we saw this kind of picture. So it's a continuous treatment, as Sumit said. We start with the inductions. The aim is to debulk or get control of the disease. This treatment is going to be initial treatment where we want to get a person out of the risk because of multiple myeloma related complication. The next part is when disease is controlled, you want to consolidate. You want to have as low level of a disease or M-band as possible. So that's second part of the treatment, which can be transplant or sometime non-transplant based approach. And last is maintenance, so that the disease doesn't come back and it doesn't evolve into a difficult to treat disease. So this is how the treatment will work for this disease. And typically you will classify these people into two groups. One is transplant eligible patient, these are younger, fitter patient where you want to treat them with high dose chemotherapy. And the other is not eligible, so person who are elderly or have comorbidities, especially renal dysfunction, you put them into non-eligible group and you treat these people with the systemic therapy, and you go to the outcome. I think one important and very useful treatment for our patient is transplant, and fortunately Manoj and colleagues are doing it, and it's a very cheap treatment in my opinion if you look at the cost of certain other drugs. And there are many times hesitations from the patients, and it is important for us to counsel them very duly. And you can see the smiling face of this lady when her stem cells are collected. So we collect the stem cell from the peripheral blood. It's not bone marrow or not a painful procedure at all. And after doing high dose chemotherapy, you get good response, but you have a period of roughly 10 days to 2 weeks where you may have infections and you may have complications. But once you recover from this, your job is done. This is one time treatment, and this will give the best control, the best depth of response. So definitely something which should be used appropriately. And briefly on the non-transplant eligible side, so we have very good drugs. So we call as novel agents or newer drugs, which are not chemotherapy. People would not have hair loss. People would not have typical chemotherapy related side effects. And we also have a recent approvals or recent new drugs like monoclonal antibody daratumab and bispecific therapies. And we heard about CAR T therapy from Sumit, and definitely the outcome of this disease are improving very rapidly. Finally, I think it is important to translate all these outcome into our setting, and this is outcome from our cohort and which are comparable to international standards. So if you do an intensive treatment, do a transplant very safely, you can achieve the outcome which are kind of available or possible globally. So so let's come to the story. So this elderly lady, when I saw her on the first consultation, she had a splenomegaly, which is kind of not a thing which you expected in patient with multiple myeloma. When we did her bone marrow repeated in our institute, the lady had hairy cells in her bone marrow. So her diagnosis was hairy cell leukemia smoldering multiple myeloma. And again, hairy cell leukemia is a low grade lymphoma where you treat them with a single agent clatarab in one course of therapy and they achieve a good remission. And this lady continues to be in remission as of now for both hairy cell leukemia as well as her plasma cell dyscrasia. So I think it is important to kind of being aware of this kind of overlapping cases where people might put your skill into a test for optimal outcome. So with this I will stop and thank you for hearing to me.
Thank you so much, dear sir, for such a nice presentation. We heard about various newer treatment options in hematological malignancies. From sir, we can understand that now we can predict early and even we can treat them at the earliest possible time so that we can translate it to the long-term remission. If any question is there or any comment is there from the chairperson, we have time. There should not be a problem.
Hello.
Yes, sir.
Hello. It is really good to see that future for all the treatment and malignancies is good. It was a very good comment that half of the person in the hall will be showing it. What are the precautions to be taken for that?
I think it was, the comment was meant in the sense, we can have a spectrum of disorders where we could have a pre-malignant condition, etc. So, specifically in this context from progression of smoldering myeloma or MGUS to multiple myeloma, there are no preventive measures. These cells will acquire additional genomic lesions at random and it is difficult to predict. So most of the times these people would not be treated or would not be in fact screened also. For example, low risk smoldering myeloma, this person is not advised to have a following with the oncologist, etc. He can be managed in the community as well. But at other spectrum, you can have something called as high risk smoldering myeloma. So this person is going to require treatment. So the point here is you are going to risk stratify these people with precursor conditions and plan an appropriate follow up for these people, as most of these people would have normal lifespan and most of these people would have good outcome. But definitely there are no preventive measures as of now. There are ongoing studies to treat these people early and see if we can improve the outcome, but we'll have to wait for that.
Thank you so much, sir. Thank you all the chairperson for chairing the session. I would like all of you to come on the dais and felicitate Dr. Bhausaheb Bagal sir, who is here for today's Jeevan Amrut Haematology Summit. एक color kit पण दे. Yes, please, Devre sir. Thank you so much, Bhaus sir, for coming to Jeevan Amrut. क्या? ये directly क्या था? Thank you so much. I request Dr. Prahlad Dharukar to please be on dais and come to felicitate our chairperson. Dr. Prahlad is neurosurgeon, dear friend of us from Jalna. He is all the way from Jalna to attend today's CME. Yes. Dr. Nilofar Patel. Thank you, madam, for coming today and gracing the today's occasion. Dr. Umesh Malu. Dr. Shweta Sikchi, madam. Thank you, Umesh, for coming. Thank you, Dr. Shweta, for being here. Yes. And Dr. Sanjay Devre, sir. Bhaus sir, एक group photo साठी समोर याल, please. Thank you, Devre sir. Sundayच्या दिवशी वेळ काढून. Thank you so much for being here and gracing today's Hematology Summit. After this, we will have inauguration of our CME formal inauguration, followed by 3 more lectures and then lunch. Please. Thank you everyone for sparing your time. Thank you, sir. So we will have a formal inauguration of our CME. President, Madam of Physician Association of Chhatrapati Sambhajinagar, Dr. Ranjana Madam is here in the auditorium. Sanjay, समय क्यों है समापन? I would have the privilege to ask her to please come on the dais. Dr. Kulkarni sir from Kulkarni Cancer Hospital. Kulkarni sir, तुम्ही याल inauguration साठी. Please, yeah. Dr. Naik madam, she is the professor in medicine in MGM Hospital. She is here. Bhaus sir and Sumit Mirk, both of you can come please for the inauguration of the today's CME. Thank you so much. Thank you. तुमच्या कार्यकाळात एकदम चांगलं हे सुरू झालं.
Thanks, Manoj. Good.
Congratulate you. On behalf of Physicians Association Chhatrapati Sambhajinagar, I congratulate Dr. Toshniwal, Shweta Toshniwal for arranging such a wonderful hematology conference and all the senior oncologists who have come along from Mumbai and delivered a very nice lecture. So thank you from our Aurangabad team to all of you. And once again, I congratulate Toshniwal sir and madam for arranging such a hematology good conference, which is always a yearly procedure now. So we are waiting for your conference always. So thank you very much.
I would like to felicitate Naik madam, Ranjana madam and Kulkarni sir. I would request Dr. Kuldeep Singh Rahul sir, please be on dais to felicitate our guest. Please sir. Sir is like mentor to me, sir is like fatherly figure for me. When I joined first time in Aurangabad, sir was the one who guided me for everything. And I am very happy that he is in the auditorium today. Thank you so much sir for being here. Naik madam. Shantanu sir, please. Thank you so much. Or the esteemed guest, you all are like guide to all of us, and thank you so much for being here. Yes, sir. Thank you, madam. Yes. So with this, we will move on to the next part of our hematology summit. 3 more lectures are still pending. In between, we have tea and some snacks going on. If you are hungry, please feel free to have tea, and we will have next session going on. I will hand over mic to the Dr. Shweta for further proceedings.
Hello everyone. So the next talk was by Dr. Ria madam, but she is not here due to her ill health, and she conveyed her sorry for this event, so she could not attend this. So next session will be by Dr. Manoj Toshniwal sir. He will be talking about hitting the bullseye, how targeted therapy fights leukemia. So one more approach we will get to see ki how we are coming close for curing the cancer. I invite Dr. Sucheta Ghadge madam, Dr. Sushen Ghadge sir, Dr. Saurav Baheti sir, Dr. Avinash Tribhuvan sir, and Dr. Vilas Rathod sir for chairing this session. I hand over the mic to Dr. Manoj sir.
So I am really fortunate that today we have this event here, Jeevan Amrut Haematology Summit, with such a good audience available in the auditorium. Up till now, sessions are going good, where we are having good discussion about various new therapies for the malignancy. And I am here to talk about targeted drug therapies which will kill the cancers. After this, we will have answer session of our initial screening round. So the students who are in the auditorium, who are waiting for their question answer, whether they have done good or not, what marks they will get, they will know after this talk for sure. After that, we have 2 more deliberation, followed by the final quiz, which will have 6 winner teams which will come in front. And like Antakshari, we will have 6 rounds of question answers for various hematological disorders. And with that, we will get 2 winners who will go for the zonal level, where Maharashtra, Rajasthan, Gujarat teams will come to fight in the Gujarat, one of which will go to the national level. So this is how it is, ISBST Qs. So we are here to discuss about hitting the bullseye, how targeted therapy fights the cancer. So I would like to thank, Sampla never talk, Survat Zali. So I would like to thank all of you for being here in the auditorium to listen, to have this Sunday morning being spent for something which is academic. We all know this man, he is Mr. Narendra Modi. You may like him, may not like him, but for sure you may not ignore him. Whole world is discussing about this man. Some say he's good, some say he's bad, but someone, like everyone is saying something about this man, and that is because of his overall attitude towards the thing. Operation Sindoor, yes, we know Operation Sindoor, and I am here to discuss actually the Operation Sindoor in medicine or in hematology. In Operation Sindoor, this was the press briefing where targeted areas were shown in the Pakistan which were hit by the Indian Army, and how we demolished them just because we wanted to take revenge of that Pahalgam attack. Enough of politics. I am not here to praise Modi. I just wanted to get your attention so that we can discuss something about hematology, precision medicine and everything. CAR T cell therapy already Dr. Sumit has covered. I am here to discuss about how we can target the cancer, that too with the 10 routine cases which we are seeing in the OPD, which we are treating with the targeted things, and that will emphasize the importance of these therapies and also help us to learn this easily. This is where the target therapy actually started. That is 20th May, which is the World Leukemia Day 2021. And on that day, this was the article in the Time magazine. The cancer, these are the cancer bullets, new ammunition in the war against the cancer. That is what they mention. Few of us are Gen Z, few of us are millennial, and few of us in the auditorium maybe in the downstream. But yes, for Gen Z, targeted therapy is at their disposal to treat cancer with for better. Blood cancer fight is not that easy for sure, because blood cancer is the disease which is disease of poor, but still it causes so much of emotional, financial and physical turmoil for the patient, for the family, for everything. I know many students who initially thought, yes, hematology is the career for them, but maybe 6 months, 1 year, 2 years in the down the line, and then they thought, I should not be doing hematology because I can't cope up with this emotional trauma of treating these patients when they go through the chemotherapy. They have n number of side effects and finally could not make it. But yes, we have to see those who can make it, those who can be saved by the therapy, and this all can be ended by the bull's eye. If we target that bull's eye of that cancer, yes, we can treat them with best results with least side effect for sure. I don't know from where this word came, bull's eye. काही असेल का त्याच्या डोळ्यात? But ठीक आहे, कदाचित that mark looks like bull's eye, that is why they call it as bull's eye. पण असं काही नाही, जसं रावणाच्या बेंबीमध्ये जीव होता तसा त्या जनावराचा जीव त्याच्या डोळ्यात असतो, असं काही नाहीये. बुल्स आय मीन्स इट जस्ट लुक्स लाईक बुल्स आय, दॅट इज वाय दे कॉल इट ॲज बुल्स आय. सो यस, जस्ट टू मेक इट अंडरस्टँड हाऊ द ट्रॅडिशनल chemotherapy works, we give chemotherapy, it kills cancer cell, it kills normal healthy cells also, and that is why many side effects. But when we target the cancer cells, targeted therapy will have few or no side effects, and it will kill only cancer cells, and with that we can avoid all these side effects associated with the chemotherapy for these patients. And yes, why do we want to avoid? Because it is really frustrating, it is frightening to the patients, and many of our patients do leave chemotherapy in between just because of the fear or the toxicity associated with the chemotherapy. And it is going to happen with all the chemotherapeutic drugs, though minimum nowadays, but it is cell cycle which is hampered by the chemotherapeutic drugs, and that is the why they have so many side effects. But when we have new cancer specific cell targets, we can target the specific molecule in the cancer cell so that least side effect, these molecules will not be available on the normal healthy cells, and that is why patient have least side effect and the best result. Simply to understand, if standard chemotherapy we give, it is like Hiroshima, Nagasaki. You put the bomb and everything will be destroyed for generations. And this is like someone who is sniper. He hits directly to the president who is giving the narration on the podium. So yes, someone who can be targeted is like sniper. Okay, so we may think that this is the thing which is in the future, but no, this is reality now. We have these molecules at our disposal. In daily OPD we are using for various patients, and we are having the best results. Just let's go to the few cases where we can understand. She is Shweta, 23-year-old female. On the first anniversary of her marriage, she was admitted in one of the ICUs in multi-speciality hospital in Chhatrapati Sambhajinagar. I did marrow in almost 10 in the evening. Diagnosed to have acute myeloid leukemia. Family came to Jeevan Amrut, and next day her father-in-law messaged me, sir, looks like she is going to die. We know that blood cancer means death, but we want her to die in comfort. We don't want her to die with so much of pain. Yes, that was very frightening, but I counseled them. We started treatment with least side effect like azacitidine and venetoclax. She is out of the woods. She was having her marrow normal, followed by unrelated bone marrow transplant, post bone marrow transplant now 3 years, and she is pregnant with 5 months of pregnancy now. So yes, we can target AML also with targeted therapies. He is 79-year-old surgeon from Nanded, lymphadenopathy, being surgeon. Whole life he was reviewing lymph nodes of various patients for tuberculosis or even malignancy, and he did his CBC, WBC count was 80,000. He was already thinking that now I am done with my life. My 3 kids are doctor. I don't want to take any therapy. I counseled him, looks like sir it is just CLL. Let's start with some tablet. You will be better. And now more than 4 years he is taking these pills acalabrutinib, and he is doing good for sure. 66-year-old professor, retired from University of Aurangabad, that is Bamu University. He had anemia. While routine morning walk, he used to feel tired. Anemia was there. Workup showed multiple myeloma. He was also frightened, being so educated, being guide to various PhD student, and he thought he will not make it now because cancer is something which is hitting him. But we started him a bortezomib, lenalidomide, dexa. He is doing good. He is in remission, and mark my word, he will remain good for almost more than 10 years because these are the targeted drugs which have least side effect, still best result for multiple myeloma cases. He fares well. He will remain good for sure. 41-year-old female, mother of 2, happy family. They made new home with so much of like small things they gathered. They have vastu, whole family is here, and during that function she is feeling tired. Routine blood work done after that, TLC more than 2 lakh. Workup suggestive of chronic myeloid leukemia, and whole family was there to sit around and cry that now what's the use of this new home, she is going to die. Yes, she has blood cancer, and initially it used to be like she will die because of blood cancer, but now for a chronic myeloid leukemia we have tyrosine kinase inhibitors. She started on imatinib, she is stable, and she has life expectancy being normal. In Western world, yes, life expectancy is normal for the chronic myeloid leukemia. Not yet in India because of the various taboos associated with it. Some family member will come to her with some Ayurvedic tel or Ayurvedic noni like dawai for her cancer to be cured. But hopefully she will continue on TKI and she will remain good for her, both the kids. She is 55-year-old female, daily wage worker. On lymph node biopsy at Hedgar Hospital, she got diagnosed with diffuse large B-cell lymphoma. She was very frustrated. She understood that cancer तो हो गया अब. And she was like, sir, आता मला काहीही treatment करण्याची आवश्यकताच नाही. पैसे जातील मी वाचणारे नाही. But we counseled her, let's go for rituximab based therapy, R-CHOP, that was given in Yojana, and now she is completely cured and still working with full potential in the field, and she is happy. Even if I tell her that now no more need of follow-up, still religiously she comes every 6 months just to see that everything is good. That faith she has now in medicine. She is 82-year-old female. Her name is Mote. Mote, though she is lean thin, but her name is Mote. Mote Aji असं म्हणतो आम्ही तिला. She had splenomegaly with pancytopenia, and on evaluation she was marginal zone lymphoma. Everyone thinks that now lymphoma at the age of 82 years, why to treat her? She can die, but she still wants no one even to hold her hand while she is going to bathroom. She thinks that independent she should be before dying. And we started her on only rituximab. Only rituximab, it is targeted therapy, and her disease in remission. She is doing good, she is free, and no side effects were there with rituximab. Case number 7, one electrician was tired, fatigue, weight loss was there. He is 51-year-old. He was thinking that new project in hand may be causing this problem, but on evaluation he was found to have huge splenomegaly. That peripheral smear was typical. Various teardrop cells are here, and marrow was suggestive of primary myelofibrosis. On evaluation he was found to have JAK2 positive. So JAK2 positive primary myelofibrosis. I told him that we have targeted therapy, you need to be on that, but cost of that therapy is almost 30,000 per month. He was like, I can't get it. But thanks to Modi ji, we have now this Ayushman Bharat Yojana, where he gets that medicine every month free of cost for primary myelofibrosis. Jakavi is available in Yojana, and he is doing good. He is absolutely normal, takes one pill morning, evening, and he is doing fairly well. One more patient, relapsed refractory myeloma. He was initially doing good on bortezomib, lenalidomide, but unfortunately he relapsed. He being an industrialist from the Jalna, he thought now this is the end of story because he has relapsed disease, he will not make it. He was again having anemia and bone pain. Money was not the issue. He was given option of something like monoclonal antibody which is available bispecific, and he is excellent. Teclistamab showed excellent response with PET scan being normal, M-band being normal at the end of 1 year, and he is continued to be on that medicine doing a normal life. We all know that targeted therapy is newer thing from that Gen Z. No, it is not like that. We have targeted therapy since past also. This APML, acute promyelocytic leukemia, usually they present in young patients with pancytopenia. Marrow was suggestive of acute promyelocytic leukemia and FISH for PML RARA was positive. No conventional chemotherapy is needed for them. We catch them early. We give high dose vitamin A, that is all trans-retinoic acid or arsenic trioxide. It particularly targets this PML RARA fusion, and yes, cure rates are more than 90% for this deadly malignancy because of the targeted therapy, because we can target whatever the problem is there in the body. Last case, relapsed refractory lymphoma. She was Hodgkin's lymphoma, 22-year-old lady, initially 3-4 hospital, finally landed in government cancer hospital. She was frustrated, she failed 4 chemotherapies followed by autologous transplant which was done by us, and she thought she will not make it for sure. Family was also frustrated. We have clinical trials going on in our institute, and one new trial came for MALT inhibitor, that is AUR113. That is just phase 1 clinical trial. Tablet is there. We started her on tablet. On day 15 PET scan, the relapse refractory disease has also vanished. Her PET scan is completely normal. This is the beauty of newer drugs which can target without side effect. The patient who is failed almost more than 4 line of therapy, who was on the verge of dying, just few tablets and looks like she is cured, or maybe she is having very good response to the drug. So this is how these target therapies are doing. So in future, when we understand cancer, how it behaves, how genetic alterations are there, by thinking various things about the cancer, we can have personalized medicine. Maybe a day or an era will come where we will have just one pill. You just take one pill, and whatever cancer, whatever disease you have, you will be cured out of it. That is what I would wish that should happen, and that is how the research is going on. Now AI is coming in everything. AI in hematology is also very rapidly coming. You just take blood sample, not the blood sample like 10-15 ml, just a drop of blood. Put that drop in the AI machine. It will have the algorithm where it analyzes what is the problem, what test needs to be done, what are the genetic markers, what genetic markers are important considering the patient's features, what are the medications available, what are the side effects of the medicines, what are the comorbidities patient and what medicine should be omitted, what should be given, at what dose it should be given. He will prompt the patient, he will send message to the patient that now you need to do the LFT, now you need to do the RFT. That is how the system will run, and you will have to be there just seeing what machine is doing to your patient. This good medicine is developing at present. So we have a bright future for hematology for sure. We have a bright future for cancers for sure, and targeted therapies are available which are making this disease highly treatable. With this talk, I would like to emphasize, yes, malignancies are very common nowadays. We all know that initially malignancy used to be 1 or 2 cases in a town, but now every home has patient who has one or the other malignancy. Yes, they are very common, and every clinician must be aware of it for the best outcome. We have all the therapies available at our disposal, but problem is that referral bias. Patient usually comes to the consultation late. Second thing, because doctor is skeptical, patient is also skeptical. They feel that I may not be out of the woods, and that is why they delay the therapy, even they skip the therapy, and that is why results are not good. Even Steve Jobs, on routine scan, the Apple man, Steve Jobs, on routine scan, he had pancreatic cancer. Small dot was there. Someone told him, like, yes, it is more likely a pancreatic cancer. Better you go for oncology consultation and get treated. He thought, all of my friends say that I have some superpower. Whatever I think, that is how things happen. That was his misconception. And he started thinking, I will take some Ayurvedic pills, I will take some yoga, pranayam, everything, and daily I will start thinking for 1 hour that my pancreatic malignancy will vanish. And literally he used to practice that daily. Steve Jobs, he wanted to say that if I think something is not there, it will vanish. If I think something is there, it will come. That is what his prediction was there. And unfortunately, in 9 months' time, it became metastatic pancreatic malignancy. And such an intelligent person, unfortunately, because of his thinking bias, we lost. अगर स्टीव जॉब्स ऐसा सोच सकते हैं तो अपने गांव के पास के मामा तो यही सोचते हैं कि मला कॅन्सरच नाही, मी दिवसभर गुटखा खातो, मला कॅन्सर कसा होऊ शकतो, मी दिवसभर बिड्या ओढतो, मला कशाला लंग कॅन्सर होईल. आणि त्यामुळे ॲज अ फिजिशियन इट्स आवर ड्युटी टू गाईड देम दॅट यस, कॅन्सर इज रियल फॉर एव्हरीवन, दिस कॅन कम. वी ऑल हॅव टू अंडरस्टँड दॅट early signs and symptoms, guide them rightly and treat them rightly. Early diagnosis gives everyone the advantage. As a doctor also you get advantage, as a patient also he gets the advantage, and family also gets the beloved person sitting beside them. Enormous amount of research is going on, and soon it's going to be a most curable disease for sure. Target therapies are available for almost every malignancy, making treatment more comfortable and with better results for sure. So this is all from me. Thank you so much for your patient listening. Thank you.
Thank you, Dr. Manoj sir. With your presentation, it seems like cancer is getting like diabetes or thyroid. So many treatment options, targeted therapy and antibody, monoclonal antibodies, and with greater cure rate. So thank you for beautifully explaining all these prototype diseases. If there are any questions from chairpersons, audience, or any comment, please.
Thank you, Dr. Manoj, for a lucid talk and presentation.
Thank you, sir. I would like to invite our chairpersons for felicitating our speaker. I request Dr. Rohini Pawar Madam to please felicitate our chairpersons. Dr. Saurabh Baheti sir. Dr. Sushen Ghadge sir. Dr. Vilas Rathod sir. Please stay for one photograph, please. Saurav sir. Sir, session photo. I request Dr. Richa Madam to please come on the stage and please break the ice for our elimination round for state level quiz.
Very good afternoon, everyone. So we had wonderful screening round in the morning. Thank you, Manoj sir, Dr. Shweta ma'am, for all the wonderful arrangements for all the participants. On your behalf and on the behalf of Quiz Masters, I thank them for wonderful organization. What I am going to tell you now is very quickly we'll see answers of these 30 questions. The result, like who are the 6 teams who are qualifying, will be disclosed after the lunch as we discussed in the morning. I'm just going to quickly show you the answers. So before we see answers from all the participants, how was the quiz? Difficult, raise your hand. Mixed, raise your hand. Or easy. So difficult? Okay, only 2 people failed. 3-4 people felt difficult. Was it very easy? No, I'm taking a genuine feedback so that next year we incorporate all 5 of us quiz masters will incorporate your inputs. Okay, let's go quickly through all the answers. First question, identify this instrument used in hematology. Hickman catheter. I think those of you who have worked in hemat wards got it right. What is the storage temperature and shelf life of platelet? I request all the students not to record. It is a humble request. Last year also we made this request because this is a question pool of state quiz. We request all of you not to click. Thank you. So 22 to 24 degrees Celsius for 5 days was the answer. Then this raccoon eyes, beautifully shown here in a case of AL amyloidosis. So that was answer, amyloid purpura. Identify the drug being given in a 20-year-old thalassemia major patient with iron overload, and it was actually desferrioxamine infusion pump. The test was asked from the clue provided as animated figure. It is thromboelastography, a little different from ROTEM. However, we gave marks to any of the answer. So this, I was surprised, very few of you got it right. So what we were trying to show you was Herculean cells, EO-baso precursor along with blast. So it was actually AML with inversion 16. Monocytic is a broad term, it will not be taken as answer. So here you were supposed to identify the part highlighted with arrow, and it was actually leukoreduction in inline filter. This 62 years old male with vasculitis nephropathy, most of you got it correct. Yes, we were trying to show you the cryoprecipitate in the background of peripheral smear, and the second picture is showing you very typical picture of cryoglobulin. The revised cutoff of plasma cell leukemia with respect to percentage of plasma cells in peripheral blood is now revised, and now we use cutoff of 5% unlike initial cutoff of 20%. This cytochemistry stain was asked. The clue provided was flow cytometric immunophenotyping, which is 33 bright 64 14 11. See, all of them are monocytic marker on flow cytometry, and that's why the answer was non-specific esterase. Now this was little difficult, but I think hardly some of you got it correct. So we were asking you the carcinogenic event leading to acute lymphoblastic leukemia, and the answer is chromothripsis. The team who qualify for next round should read which type of ALL it leads to. Now the next question, identify the drug in yellow box. The clue provided was mutation, right? So simple imatinib, of course, is not the answer. The answer is asciminib. This most of you got it correct. Yes, we were talking about Vinca alkaloids, and any of the Vinca alkaloids written as answer was taken as correct. Next question, name this form of therapy. I believe now all of you are wiser after beautiful lectures we heard, and it was indeed BITE and not CAR-T. Which of the following component has maximum weightage in CLL IPI score? The answer was TP53 mutation status. Some of you got confused with IGHV mutation, but the single most important prognostic marker is TP53 mutation status. Which of these TKI in CML has the highest risk of arterial occlusive event? Answer was ponatinib. Most of you got it right. Here the clue provided was CLPD with 25 cyclin D1 positivity. So yes, we are talking about mantle cell lymphoma and they are negative for 23 and 200, and hence the answer was translocation 1114. Next question, 50-year-old male diagnosed as case of ITP, and then what we were trying to tell you with these lab findings was that saturation gap typically noticed in methemoglobinemia and the dark brown colored blood, and the answer for the or the therapeutic option for this condition was methylene blue. Which mutation is associated with this condition? The morphological finding being shown here is a ring sideroblast, which is typically detected on pulse stain, and the mutation associated with this is SF3B1. Which drug used in the treatment of AML has been added to the saline bag for infusion? Many of you got it correct, it was mitoxantrone. Which of the following is a newly approved TGF-beta superfamily ligand trap for beta thalassemia? The answer is luspatercept. Also read the indications, other indications for this drug. A 6-day-old term male neonate born of third degree consanguineous marriage. Her mother is having a history of cortical vein thrombosis, suggesting you the hereditary condition, and the answer to this picture was neonatal purpura fulminans or hereditary deficiency of protein C or protein S. This was little difficult. So we gave you a case of AML and the patient denied routine cytotoxic chemotherapy, went to New York, and we tried to show you the drug. The clue was it doesn't lead to alopecia. It is usually used in elderly patient, and actually the drug was CPX351 or also known as Vyxeos. It is indeed a combination of liposomal daunorubicin with cytarabine. So anybody who has written even liposomal dono, we have given some marks to them because it was a difficult question. So 48-year-old patient with a relapsed DLBCL. The question here was, if the stem cells don't mobilize after GCSF, what is added? So the answer to this was CXCR4 antagonist or plerixafor. This was correct by very few teams. What we were trying to show is 6-month-old child with leukoerythroblastic blood picture and failure to thrive. The intention behind keeping this question was this disease is only diagnosed if you suspect it. It can be diagnosed very easily with simple X-ray, infantogram, and what you are seeing here is marble bone disease, osteopetrosis. But the problem is we don't suspect it only. Which thrombophilia remains resistant to heparin therapy? Most of you got it correct. It is antithrombin 3 deficiency. Simply knowing the mechanism of drug will help you answer this question. What is the most appropriate management for type 1 von Willebrand disease before a minor surgical procedure? So the answer was desmopressin. In PNH, we asked you the mechanism of action of this drug, and it was inhibiting C3, that is A option. In this, we have given marks to both A and D. So in relapsed multiple myeloma, which bispecific T-cell engager targets BCMA and CD3 both A and D answers were taken as correct, and all the students who wrote either A or D were given marks. What is the current first-line treatment for elderly AML patient unfit for intensive chemotherapy? Manoj sir just showed us a case for this example, and it is indeed venetoclax plus azacitidine. So thank you. Those were the answers of 30 questions. We look forward to having all the students post-lunch for results of screening round and the final quiz. Thank you.
So after listening to the answers, now I am feeling that it was easy. That is what the feeling is. But I hope it was not easy. I hope we have tough competition. Just 2 more lectures, then we will have lunch and we will have our state level hematology quiz with the 6 winner teams, and all those who have been here rather than going out in the rain, better you stay here, see how these 6 teams perform, see how these guys will do in the quiz. And this year 2nd year students are here. Next year you again have the chance to come back and win the quiz. So this is a good opportunity for you to learn. With this, I would like to move for the next lecture, which will be by Dr. Chaitanya Khillare, a very dear friend of mine, who is a pathologist and owner of Udyati Pathology Lab, Parbhani. He is using AI platform there to diagnose leukemias and various blood malignancies at the root level. He is writer, enthusiast in hematology. I would like him to come on the dais. For his lecture, I would like to have chairperson Dr. Kaustup Sodani sir, Dr. Dhananjay Khatavkar sir, Dr. Rahul Chaudhary sir, Dr. Abhay Pohekar sir, and Dr. Sharad Biradar sir. Maybe we'll have 5 chairperson, enthusiastic physicians who are like really doing remarkable work in the field of medicine in Aurangabad. And with this, I hand over mic to Dr. Chaitanya Khillare sir for further proceeding. तू दिल नाही का presentation? तुला हे देऊ का? He will be talking on AI in hematology, artificial intelligence in hematology, which is available at his clinic, and he is routinely performing all the tests on that. So over to you, Dr. Chaitanya.
First of all, thank you for all. Actually, I did my UG from MGM Aurangabad 2003 batch, and this hotel is also previously called as the Windsor Castle. So my first year fresher party was given in this hotel only. So it's nostalgic, and thank you for calling me from Parbani. So before I start, I would like to thank Dr. Rajendra sir. He is in USA now. He is the first person who introduced me this term. My guide, my wife, and of course my partner. I'm lucky that I'm having a lab partner, an owner who is ready to invest in my all adventures. Because doing this AI and doing this adventure is not easy in terms of money. We have to invest almost 50 lakh plus rupees. So this is not an easy decision. Whenever it comes to economy, each and every partner will think that how much we can earn. And thanks to my wife, she's over here in the hall. First time she's listening me. So reason is, whenever I will think about out of box, she's the only person who think yes, we can do it. So thank you. And thank you of course to the team Jeevan Amrut, and thank you to the audience for listening me. I am doing this all thanks before my completing lecture, because I don't know how is my presentation. So till last moment, before that I should thank you. So coming to that, as I'm from Parbani, we don't have a tertiary care unit like this, Jeevan Amrut or something, and we don't have leukemia daily. So most of the time we will do on the benign diseases. And after listening stalwarts from the Tata and Nashik and Medicover, all these things, we are now in a small lab at Parbani, who is running hardly 10 PS daily. So this was the case. This is not case basically. Usually what happens is patient come to our lab, we do a CBC, Coulter, and if such reports are coming like platelet are 22,000, RBC is down, and hemoglobin is 8.8. So we don't have a CBC with PS. We have a CBC first at remote places. And now next is definitely, after seeing the report, physician will tell, now you do the PS. So patient will come back or he will call us. Now in these cases, we need a trained, skilled technician who can alert us. Second is thing that I need physically present in the lab. So that's the one problem we already have and we face daily. Because if such patient came at night, 10 p.m. while you are going to shut down the lab, my lab is running 24 hours, but still, even though lab is running 24 hours, I am not available for 24 hours. So that's very difficult in such cases. So I'm going to talk on this problem. So who I am is, I'm Dr. Chaitanya. I wrote already 2 books and having 11 publications. My journey started in 2018 when I was in Navle Medical College as an assistant professor, and I was handling 2 digital histopathology digital scanners. One was the Apiro CS 2000. That time it was around 75 lakh rupees. When I was taking training of that machine, my trainer used to tell me, sir, please एक बात करो कि अगर मैंने नहीं कहा है तो कुछ भी बटन मुझे पीछे पूछे बिना मत दबाओ, बिकॉज अगर कुछ हो गया तो दोनों की किडनी बेचनी पड़ेगी. So that was how I learned. First time I got. In 2018, I come to know this term, and then I wrote first article, artificial intelligence review article, which was rejected by almost more than 20 magazines, 20 journals. So finally, I released it without indexing journal in my college only. Then I first brought, when I shifted to the Parbani, I first brought the urine examination, AI urine examination machine. Then I brought this AI 1000, and then we are having now the semen analysis also in the AI. So I would like to say proudly that this is the only standalone lab, except from the corporate, in whole India, which is using the all three at one place. And this is workflow that how I am going to present. What is AI? I will take you in a very basic manner. Then I will share my cases, and then I will share you the new problems. So first of all, AI, we know that this is actually a second brain. But whenever we called it as AI, we know ChatGPT, Gemini, chatbots. We basically think chatbots, but it's not like that. Actually, AI can be divided into two parts technically. One is the research end, one is the user end. When in 2018, nobody knows what is the user end. We know only the research end. And I'm not going to talk about the research end, because in research end, there are the terminologies which are not in our limits. Python, DL, ML, so many terms are there. At the user end, we know machines are there. We know the terms, ChatGPT, Gemini, Cloud A, Lima, all these things. So we are at the user end, and my talk is about the user end. These are the two beautiful articles. If anybody want to know what's in hematology, how AI is doing, so these are the two basic articles I did for references for this my talk. And still we have this problem, the leukocytosis versus leukemia. So these are the tedious jobs, these are the tedious problems. I told those these are the two problems we have. And AI is now going to explode like this. In 2021 itself, on the global trend, you can see the conferences were conducted, and you can see that more than 40% of papers were on the AI in hematology itself. So this is how global trend is going, and AI is getting expanded. I'm not going in a deep, but I will not also give you the jargon terms. These are the very basic terms. AI is an umbrella, and below that umbrella there are the two terms which we and everybody should know. That is the one ML, we always say ML, machine learning, and second is the DL. So DL is the core thing, that is the deep learning. ML means machine learning, means we are teaching machine to go to the senior KG, junior KG, first class, second class. So we are basically training the machine with basic things. For example, if I want to teach a second year MBBS student, I will tell him this is the cell, this is the nucleus, this is the nuclei. So these are the machine learning. But when it comes to the deep learning is very like upper level, but it is core, that someone is a SR, assistant professor, or professor is learning himself. After working for 10 years in a cancer, after working in 10 years in hematology or any branches, he will come to know by looking at the slide, by looking at the patient, इसको क्या हो सकता है, इसका क्या DD है, slide में क्या है, अगर CML नहीं है तो AML क्यों है. So these things are come from the experience, and this is what called as the deep learning, that AI itself will learn itself. Whatever in first machine learning we teach to machine कि भाई ये 3 पैरामीटर है, न्यूक्लियर साइटोप्लाज्मिक रेशो बढ़ गया है, you sell it as, you labeled it as a cancer cell. But next to level in deep learning, it will start himself कि even if N0 ratio is low or in the mid range, then it may be a cancer or not. So that's how it is called as the deep learning. And deep learning, you can see the data is integrated, and it is a billion terms. We called it in AI, it is called as the parameters. So whichever AI chatbots you are using, check it out. If its parameters are greater, then that GPT or that AI chatbot will be performing better. So that's how, but still everybody think that कि sir report तो तैयार हो गया, फिर human की क्या ज़रूरत है. We need to validate the reports. AI can help you to work for you, but he cannot take the decision for you. The decision maker is by human brain only. Critical thinking is not in AI. We have to teach him. So AI is practically divided into 3 steps. First step, we are here right now, that is AI in the labs or AI in our softwares. Second thing is for the clinical integration, and third thing is the super integration. So what super integration, I will tell you later. That this is the very simple. I scan the slide, AI will take the images, and then it will label key. Because I trained AI, this is called as a blast. I trained AI, this is called as the lymphocyte. It's very simple. But there are two ways to teach the AI. One positive, we have to teach him कि इसको blast कहते हैं. But if we are teaching him or we are saying कि this is not the blast, then you have to tell the AI also कि why it is not a blast. So there are the two ways to teach any AI startups or any AI image analysis and any AI technology. So what data say is, currently we are having this machine. Sictipal is Indian startup, Sysmax is a Japanese thing, and these two startup. After that, now in recent, like in last 1 year, we have flooded with the so many machines, because now once the thing is out, we know how to make. So paracetamol can be branded by anyone. So this like that. So there are so many machines. Chinese brand are coming with the lower cost. Next one is the AI plus clinical context. We are trying to integrate your clinical patients features with your lab reports. So Augusta AI is startup in a Bangalore, which is actually invented by IITN. And why it is invented? Because he was misdiagnosed for the vitamin B12. So he did reverse engineering. He is IITN. So he did reverse engineering कि मेरा B12 deficiency कैसे क्या गलत हो गया diagnosis का. So he come to know that either there is fault in a lab report, or either there is a fault from the physician or consultant to integrate that thing. Because he was not angry, because he was anxious. विटामिन B12 का डायग्नोसिस गलत हो गया, इसलिए MRI करना पड़ा. This is very gross. Whatever the problems, he tried to catch the problem, and he come to know that there is no correlation between lab reports and the physician's side. Many a times there is no integration. So that's how he got an idea. He started one startup, that is the Augusta AI. And this Augusta AI is now backed by army officers. There are 2 army physicians, those who completed MD medicine, and they are now his partners also. So they are doing good. They are having more than 2 million people's data, and they are trying to, anybody can open and see this Augusta AI. You can upload your reports, you give your history. They will suggest you algorithms, they will run the algorithm, they will suggest you. If you are diabetic, they will, after 3 months, you will get a message, now it's time to do HbA1c. So this is how AI is working. This is called as the clinical context AI. And now next thing is that fully integration. So forget these names. I will tell you a simple example. I am Dr. Chaitanya. I am 43 years old age. So I don't have hypertension. But if I want to see AI in future, what AI can do is, once I did my all health checkup, I go to my physicians. He will do all clinical checkups. I will give this data to the AI, to the machine. Then machine will go back to the data. He will first segregate 43 years of age males. Then he will segregate, narrow down to the BMI which compares to me. Then he will segregate iska thyroid nahi hai, BP nahi hai. So that's how he narrow down, and exactly matching peoples will be compared with me. And now it comes to the omics. If I have a genomic testings, I have a NSGS, or I have a exosome, my study, then it will try to get, because the data they have collected is already having the history of that person, and then they can predict the risk with my test. So that is called as the full integration. Beyond that, they will try to give that कि इस patient को हमने ये treatment दी थी, तो उसका क्या हुआ. So that is called as the fully integrations. Trials are going on, but clinical validation is not there, and it is very difficult, to be frank, in India, because we have wrong data. So हमारा डेटा एंट्री हमेशा गलत रहता है, आधार से लेके पैन तक सब कुछ गलत रहता है. तो ये आ भी गए इंडिया में, तो it's very risky to use. That's why government is applying, and that is the only thing in AI happening is 2 things. I don't know about the government policies, but one, in February 2025, government had made the AI policies very strict, and DPDA 2023 Act was now activated. So that if someone wants, sir मैं ऐप बनाता हूँ, लोगों का डेटा लेता हूँ, फिर मैं एक algorithm बनाऊंगा, ऐसे नहीं चलेगा. You will get a jail for 10 years, straight away. So that is the only thing I feel that ki first time government had initiated before it come to the market, and it's good move. So next question is, will AI replace me? Straight away answer, I will say no. Why? Because AI can assist me, AI can do my repeated task, AI can do complicated things easy. Okay. But it doesn't mean it will replace me. Definitely, the person who knows AI can replace me, the person who don't know AI. That is the simplest answer, and it is not from me. You can search YouTubes. There are thousands of YouTubers, and there are very good persons, those who are on the AI, those who are working. So you can search it out, and you can get the answer. So what is AI basically? AI is like a Ferrari in our Porsche. एंड व्हाट वी आर डूइंग इज कि हम म्यूजिक टेस्ट करके देखते हैं, लाइट टेक कर देखते हैं, रेस करके देखते हैं, फरारी के साथ फोटो निकालते हैं. यू आर हैविंग फरारी, यू टेक फरारी टू द हाईवे एंड टेस्ट इट. सो दैट्स हाउ AI is, and we all are doing this wrong. One example I will tell you. Last night I was talking with Manoj sir and Mig sir कि if you have a OPD of like 50 patients, 60 patients, and then out of these 2 are AMLA, 2 are CML, 2 are benign, and if you take a strata, one is 12th failed relative, one is the highly educated lawyer, one is the having few doctors in his home, and now you have to finish it in 8 hours or 4 hours, whatever time you are taking. So this is a tedious job you are doing. Tell me frankly, if you are doing this in a clinic, 60% work is repeated. Every day you do 60% same. AML का केस है, उसको same आपको counseling करना है, उसके same question रहेंगे. Hardly one question here and there will be there. So this is the one pain for clinician. Agree? Everybody agree? Okay, if I am wrong, tell me that, sir, no, not possible. Okay, this is pain point for clinicians, yes? So what we can do is, with the AI, you can reduce this pain. You can reduce this pain very simply just with the one prompt, but unfortunately we are not able to reduce it because we will get frustrated. You use chatbot and you ask ki I want to reduce this pain. The problem is you are asking question which is framed wrongly. The thing is, this is the story. If you put patti and you ask ki how's the elephant, everybody will tell different answers. AI is same. If you want to tell AI it is elephant, you have to tell him his weight, ears, nose, everything. That's how your prompt should be. This is the only one prompt you give to the any chat GPT, any your Gemini. You copy this prompt, you just fill it like this, and you will get the answer. So I have included everything. I tried for more than 50 times this prompt for 50 diseases, whether this prompt will work or not. And it is very simple. You just take a copy. Who is your assistant who is working more than 1 year with you? Your maybe your RMO or your assistant or your nursing section or you are the person who is doing screening. You just give this prompt, your chat GPT, because I included everything. The patient's age, FAQs, everything. You just give this chart, fill this prompt, we will get the answer. Now you have to only give this to your assistant. He will answer his all questions. It will reduce your pain. Now your job is only to assess the patient and tell him that what are the basic complications. If he is agree, you can start your treatment. So this is how AI can help you, and this is how we should do. Basically, AI can do your daily task. Basically, AI can train your staff. Basically, AI can help you to study newer things very fast. So this is AI. And yes, the second problem as a pathologist we always get is कि we scan the slide under the microscope and then consultant is saying, sir, leukemia लग रहा है, किसी को लगता है blast like है, किसी को लगता है reactive है. So this is the problem, and this is more at our remote places, because we don't get the, even if I did like 100 cases daily in institute level, if I go back to the Parbani and I'm doing for 6 months, I don't get any leukemia cases. Forget leukemia, leukocytosis का भी case routinely scan के लिए नहीं आता है. They will say 50,000 है, DIC है, D-dimer करो, ICU में, इसको leukemia है ही नहीं, तो वो PS तक आती ही नहीं है. They will run on the Coulter paper only. So yes, these are our pain points, and to solve these pain points, I will share now my cases. There are the 4 cases which will not take more than 10 minutes. So first case is the Kutti story, which is my dearest story. Kutti was a guy who was around 12-year-old and he was having exam. So before exam day, on day one, he got the rash and bone pain, severe bone pain. So what his dad did is, he took to the orthopedician surgeon nearby. Orthopedic gave him some painkillers. Second day, he come back to the orthopedic, and again orthopedic said, now this pain is not relieving after this much dose. It means it's something else. You go to the physician. So how at small places dad and mom work? इसको वैक्सीनेशन कहाँ दिया है उसको लेके जाएंगे. So 12 साल का है 19 साल का है वो नहीं देखते, वो देखते कि वैक्सीनेशन कहाँ दिया है वहाँ लेके जाएंगे. So they took him to the pediatrician. Pediatrician से ओके रिपोर्ट देके सब देखा, अभी 9 बजे एडमिट कर लेते, कल सुबह देखेंगे, इवेल्यूशन करेंगे. नेक्स्ट डे सीआरपी थोड़ा बड़ा था और डेंगू टेस्ट पॉजिटिव आ गई. तो ठीक है डेंगू है, डेंगू टेस्ट पॉजिटिव मीन्स डेंगू है. WBC count was 8,000, hemoglobin was 9 and platelet was 30,000. So now dengue का council हुआ, सब कुछ हुआ. Next day, like this was the second day at pediatric hospital itself, and pediatric suspicious that कि fever जा रहा है आ रहा है, but ये dengue का fever नहीं है. So he called me up. I am sending a one PS, please do it ASAP as usual. So मैंने PS किया. I scan this is my machine, AI 1000. So I scan it, and I usually look in because after scanning you have to see somewhere, so I see in the laptop. And this was his Coulter, platelet 22,000, WBC almost normal, 6,800, RBC was like 3.18. So kuch nahi tha. So this is my dashboard where I usually see how I see this. So I start from the right side, microscopic view, because I am trained on the microscopy. So I usually see first microscopy, then I will see malaria, then I will see platelet, then I will see RBC, and then WBC. This is my sequence which I made myself because I don't want to be biased by checking summary. So this is how microscopy looks, and you can see the zoom. It is 100x digital zoom. So that is one more point again. If there are the 0% chances you can miss malaria. Now this was his WBC photographs and lymphocytes, and this was the atypical or blast cell seen, full of blast. So patient came as a dengue and was diagnosed as a leukemia. I signed the report, it was 54%. Again you can see here machine is labeling it that reactive lymphocytes and lymphocytes in a combined manner. And second is atypical or blast, atypical oblique blast. It is 32.6%. Again, I have to check the slide on the digital microscope. I can check, or I can check manually, and I have to cross verify the all photographs he calculated for the blast is correct or not. So it's not like that I scan the slide, algorithm has been run, and no, it is a leukemia. It's not like that. It will not work like that. I deliver the report ASAP to the physician. Pediatrician called me, are you sure this is a case of dengue positive? I said, sir, yes, it is a leukemia. Next day, patient landed in the Chhatrapati Sambhaji Nagar and bone marrow done, diagnosed with the B cell ALL. So with the clinical impact, we can see 5 days patient was undiagnosed. Once the slide came to me, within a 48 hours, patient started with the treatment. Second thing is number of blast. That was the most difficult thing for us at the remote places, because we don't have a special stain. We have only either Leishman, Giemsa, field. That's it. Beyond that, we don't have anything in hand. So that is the one super good thing with the AI we can do. And over the period, we will gain the confidence also while talking with the clinicians. Sir, whether this is leukemia, yes or no, we can tell very confidently when we have a proofs. Baap dako nasta shraddagal. That is the very good thing happen with these digital scanners. And that's how, this is not my first case, but with this case, I have been featured in the Mint. And once on the 13th of June, I think it was headline for Lok Satta Marathi for all over Maharashtra edition. And that that's why this case is very close to me, because even I don't know that it has been published in the newspapers. So this was actually my first case which I diagnosed. Around 31st March, 6 p.m. I got a call from my neighbor lab. Sir, I am at home. My baby is having fever and I have one case. Because my technician took the pictures, but I am not able to identify the cells, and I think I have to look into the PS. So you have a machine, can you do it for me? I said, yes ma'am, send me the sample. Sample came around evening. We did we run, and ma'am usually send me the photographs of that culture to save that. And it was WBC 3400, hemoglobin 10, and platelets were 8 lakh. No history at all. Patient was totally walking to the clinician. We scanned it, and you can see blast 64%. So this was a walk-in patient, just walk-in patient. No more symptoms, nothing was there. Okay, pain hota hai baba, ghe Naik sir ni CBC CRP PS. So this was done. We did a resampling to confirm, because sample was not taken in my lab. So that is the first step we have to do. Actually, I was emotional because I was traveling basically when I was signing my first leukemia case. Due to urgent things, I was traveling. I was happy that we were able to help, but I was sad also same the time. Walk-in patient came to the clinician, bas angat dukhtay म्हणून has been diagnosed with the leukemia. So this is the sad from his side. Ma'am's name I already told. Sorry for interruption. Actually, my PPT is on the net. So Meenakshi ma'am called me and asked me, sir, like what you feel exactly. I told ma'am it's confirmed that we are having So ma'am asked me, I told ma'am कि ये leukemia है, and I want to show the photograph has been not displayed. It was a WhatsApp chat. We did this diagnosis within a 45 minutes. The leukemia diagnosis with 64% blast. So that was the TAT we did, and this was the first case I posted on the LinkedIn, because when I shared this with my teacher told me that British has ruled us, and at least you take one thing from British, that keep the records of everything. So I am very lazy for that to keep records, so I posted it on LinkedIn, जहाँ पे कोई पढ़ेगा नहीं, but वो record में रहेगा. And I usually keep this post to keep record only purpose. I was posting it on a LinkedIn. I never know that someone will read this and will come to me to take an interview. So that's how I started. So what I get is कि you have to take a bold call sometime, even if you think कि walk-in patient है, history नहीं है, but still you have to see what are the results, you have to deliver it. Now my third case is around 3 a.m. I got a call, and patient came with the weakness, mild fever, chest pain. As my partner's husband is a cardiologist, so most of the chest pain patient will land at a platelet was less than 20,000, and dengue was suspected by the on-duty physician. So they order everything in a straight away because the report was from outside lab before coming to the chest pain. And in my lab, I have one simple protocol: less than 10 hemoglobin, less than 1.2 lakh platelet, and more than 15,000 WBC, PS compulsory. But in morning, like night person will not do PS. Why to do? Because he is not trained, one. And second thing is, even if he will tell, sir, मैंने किया भी तो आप देखने नहीं आने वाले. So करना क्यों है? So this was there, but they will not follow. Plus you have to take one more extra sample to reconfirm that whether we are not wrong. And this was the Coulter, ki WBC 16,000, RBC 5.3, platelet 26,000. Now in morning my senior technician came at 7 o'clock. उसको पता था कि अभी नई machine आई है, तो he need to scan, because now we have an advantage. Even if I am not in a lab, I can see from anywhere. So he scanned the slide, and I saw this. That was EDTA-induced thrombocytopenia. So I immediately called clinician, told that, sir, dengue to nahi hai. You hold the all other tests, and we'll check it with the other, like heparin bulb or plain bulb, and we checked it out. So what happened in this case is, basically you know that time saved already, because around 3 a.m. he came, around 7:30 I told that कि ये dengue नहीं है, we have to wait. And the second thing we got is almost 5,000 के test उसके बच गए. So with the 200 we saved 4,500 rupees. At remote places this amount is very important. अगर हॉस्पिटल में आया, डेंगू सस्पेक्ट किया, 5,000 का टेस्ट करवाया, 10,000 उससे लिया, तो पेशेंट छोड़ो, पूरा गांव का गांव कभी आपके हॉस्पिटल में वापस नहीं आएगा, just because of pathologist. So with this case, then I change one SOP of my lab: scan first, resample later. Next day एंजियोप्लास्टी पेशेंट था, सेकंड डे उसका CBC लिपिड HbA1c करना था, बच्चे ने लाया एंजियोप्लास्टी पेशेंट, डे 2 हीमोग्लोबिन 5, प्लेटलेट लो. सो स्कैन फर्स्ट उसने स्कैन किया, भेजा स्कैन करके, पूरा स्कैन नॉर्मल था. देन आई चेक द रिपोर्ट्स, लिपिड भी लो आया, HbA1c भी नॉर्मल एबनॉर्मल आया. एंजियोप्लास्टी करने के बाद अगर पेशेंट का लिपिड लो आया तो पेशेंट आपको कोर्ट में लेके जाएगा, 2 लाख रुपए लिए. सो एक्चुअली व्हाट हैपन इज, इट वाज अ रॉन्ग सैम्पलिंग. IV लाइन से उसने लेके आया, तो ये हुआ है. देन दिस केस टॉट मी कि if you try to get involved with AI, it will help you more. Your lab errors will get less. And that is also one point, that how you build trust with others, especially with clinicians. See, patient will never come to know pathologist from his side, but clinicians know the importance of this. Day 2 एंजियोप्लास्टी के पेशेंट का हीमोग्लोबिन ड्रॉप हुआ है, मतलब वो सोएगा नहीं, वो नींद से उठ के आएगा ICU में. एंजियोप्लास्टी के पेशेंट का अगर हीमोग्लोबिन लो होता है तो वो नींद से उठ के आएगा कि क्या हुआ, किधर से जा रहा है ब्लड बाहर. This is the last case which taught me a lot, and this is straight away connected with the one recent issue. But this happened with me on the 13th May. I remember the date because 13th May is my anniversary. So, so one patient came at around 10 PM to the pediatric hospital. Sir, काय नाही, थोडा fever आहे, sluggish drowsiness आहे, admit केलंय. And then CBC CRP सांगून टाकलं. CBC showed 40,000 WBC. CRP was normal. Pediatrician called me, how come CRP can be a normal for the 40,000? Patient is having fever. So I called to my technician, told him, कुछ भी कर, scan करना है तुझे आज slide. And he was he was like new joining, like not more than 7 days. I have not trained him. So two problems, new technician, untrained thing. What I did is, he called to my senior technician, and on the phone, on the video call, we scanned the slides. He told like, kaise karna hai scan. And it was the easiest thing because we brought the PS maker in our lab. So now that because of PS maker, we scan the slide, we made the PS, we scanned the slides, and results were like this. There was no atypical of blast cell, almost 6%. All were atypical. Neutrophil was 59%. Except toxic granule, there was nothing suspicious. So I called back to the pediatrician again back around 1 p.m. and I told him कि sir, इसको leukemia नहीं है. You take history once again. There is something wrong or either sample is wrong. Sepsis भी नहीं है. Then pediatrician की नींद उड़ गई because he admitted the patient on the same floor. His house and the ward was on the same floor. He went back. He asked patient something suspiciously, and there was one history because 11, 12, 13 May in Parbani we were having around 40-degree temperature, and patient was not taking a single drop of water. So the moment he got the history and they took to some quack, he brought new Bisleri bottle in front of him. Baby was crying. There is no need to tell what is the diagnosis because patient was hiding a history. So this case taught me the most important lesson that, and I was happy because of AI we can tell them on the time that this is not leukemia. Otherwise he was sleeping, he called me, okay, 40,000 है कल देखेंगे सुबह leukemia ही निकलेगा. He was about to sleep. I was about to sleep. My technician was about to sleep, except the patient. And the havoc was, the patient was on the same floor. The pediatrician is having 2 kids. We need to sanitize whole hospital. We have to take the vaccinations. My lab, 2 persons took vaccinations. Doctor took vaccinations, post exposure vaccinations. So this was a simple case, but it saved a life. Unfortunately, we were not able to save the life of that baby. After 3 days, he died here only in Sambhajinagar. But that day, I got that we invested a money, but we could save so many things. And one more lesson I learned that in an emergency, if it is not leukemia, even if I am able to tell the doctor कि sir ये leukemia नहीं है, then we can save so many things. We can save the wrong treatment. We can refer to the patient to the next level. We can do so many things. So AI is not only for to diagnose the cancers. That's what my biggest lesson I got from this case. And that's why I keep the name HIT. It is not the name of movie. It is like Hematology Investigation Tales. I have almost more than 40 tales with me. I shared only 4. Each and every tale is having some lesson from it. I diagnosed almost more than 26 plus documented cases, 30 cases total in last 6 months at Parbani. Those were leukemia. Out of these 21 I took the follow-up, they are taking a treatment. Few are my out of track and few doesn't show up again back. So this is the last 2 cases. I got 2 cases on the same time. One was a 5-year-old URTI and his culture and results show lymphocytosis, and on scan it shows leukemia. And second was the adult with UTRI, which was a referred case again by some ICU. And this was very, I would like to elaborate that history. Sir called me up by looking my article or somewhere from he come to know, and he called me, sir आपके पास कुछ ये है का मशीन आया है, हमारे पास एक केस है 5 दिन से पड़ा हुआ है, URTI के लिए आया था, सब कुछ ठीक है सर, एंटीबायोटिक दिया, फीवर गया, सब गया, पर उसका अभी भी ना TLC 52,000 है. सर PS किया नहीं किया. So PS मेरे पास भेजा and it shows lymphocytosis. Why I took these bonus cases? Because it was totally wrong. It was a blunder by my technician. Actually, he labeled the cases wrongly. this preclinical error is still here in the AI era. So if AI is there, it doesn't mean that जो आया है उसको टिक करके देंगे. No. Preclinical errors will be there. I immediately terminated that technician. The reason is I trained her for more than 8 days to label the samples only. And this is the blunder, because if you labeled leukemia who don't have leukemia, it will be havoc. And the blame will be on the AI. But it was not AI. It was me and my lab. So with the AI, we have these problems which are already existed there. Before AI machine also, we are having this problem. Preclinical error cannot be removed easily because it is human error. And second thing is, we have other technical issues like staining, bad staining, contaminations. You need to train the people to get exact smears. So we find our own solutions, small solutions we are trying to find out. And with this, there are certain limits of AI which I don't get right now, but article says that there is a poor generalization model, then the morphologies are still not identified by few machines, especially in case of the reactive monocytosis, atypical reactive monocytosis, or atypical blast. So these things yet not been fine mode. Other main issue with the AI is RBC disorders are yet not diagnosed clearly with the AI. Reason is, if you want to see sickle cell, how AI has been trained is with the photometry or cytometry, nucleus, cytoplasm size. We don't have a sickle cell standardization cytometry. And to train the AI, we need more than at least 10,000 data of sickle cell. They tried, most of the Indian startup tried, but they failed. So now they have given it under the fragmented cell. So problem is, whenever you feel it is a hemolytic anemia, you have to go into the fragmented cell section and you have to look for each and every cell. So again, it is tedious job. Better you scan the slide under microscope on the 10x. So that's the one issue. See, no technology will come with 100% advantages. Every technology has its disadvantages. Maybe in future they will have something. So RBC disorder, hemolytic anemia, yes, they are having problem. It's not like that कि आपने slide scan किया और hemolytic anemia बोल दिया. No. That's why I told in my that thing is second step. That is the AI plus clinical integrations. Your scan slides per your clinical integrations report can suspect, can flag this. One super example is in Hyderabad. I saw that there are the patches given to the patient in the ICUs and the chemo wards, and they are running this project that is called as the Z-Dark project. I will in fact tell you the name of hospital is Apollo, and what they are doing is they will monitor everything, pulse, BP, everything. Already your data has been given to the software, and the TV model is on the nursing station. So that nursing station model will get each and everything from the patient, pulse, BP, all running data plus his lab reports. And if he feel there is a mark limit, for example, we say anemia is less than 10, so there is BP iska down ho gaya, isse zyada kam ho gaya, so we have to inform. But we are doing manually. That software already triggered such a way, it is made with such a way that before nurse and before patient, it will be message is being gone directly to the ICU maintenance team or your treating doctor. So almost more than 5 people will get message and calls. And if nobody is responding, they will get IVR call even, that your patient is getting dropped or his breathlessness, whatever it may be. So this is one tedious job, जिसमें आप सो भी गए तो आपको call आ जाएगा. And that's why when it will come, these errors will go. Because this is connected. This is not like that कि first step में सब कुछ हो गया. No. Until unless we will not go for the third step, it will be very difficult. So my reflection with AI, it will cut the delays from days to hours. Second is your junior technician will get empowered, and of course I myself, it will go confidence with you for night reporting also. And the lastly, help us to avoid wrong treatment. It is very important because India is facing two most important issues. One is antimicrobial resistance. 2015, like forget 2015, I saw cases, I saw on Facebook many patients and especially intensivists are posted, urine report दिखाते हैं सारे चीज़ों को resistance है. Reason is रात को आए हुए patient का urine diagnose नहीं होता है UTI बोल के ट्रीटमेंट शुरू कर दी है, and nobody is care about his culture reports, and under the name of empirical therapy we are doing. Same thing is in hematology. If you are treating a patient like this, it's very difficult. फीवर आया है, आज गोली दे दी, कल देखा ही नहीं है PS, बाद में पेशेंट डायरेक्ट रिलैप्स में आ जाएगा. So these are the things I got it from AI, and indirect effects are there. My manual work with the 7 part, obviously I have not covered AI fully. Okay, I just covered the slides. AI can be used in flow cytometry, AI can be used in your graphs, because now Coulter machines are coming with inbuilt AI. So they can read themselves the graphs, they are creating new graphs, IRBC, platelets, like ma'am has covered already the few many parameters, and I think after me also ma'am are going to give the more clues about the Coulter, so I have not taken that at all. But that thing can be done with AI integrations. For me, at remote places, CPT is more important. The more higher side Coulter I am taking, CBC machine, more it will cost. And we charge only 200 rupees. If I charge 400 rupees for Coulter machine, no income. Even for this machine, I know that the break even will never come in my life. 50 lakhs plus 85,000 per year. If I charge 1,000 rupees for PS, no one will come to me. I have to charge 200, maximum 300 rupees. That's it. So that is the indirect effect still. But our technician dependency is going down. And lab visit जो रहती है रात में जाने की वो भी कम हो गई. One more thing I got is those who are taking now the treatment, chemo treatments at Hyderabad, Mumbai, Pune and Sambhajinagar, many are coming to the Parbhani, and they now in morning I have at least, every week I got at least 2 to 3 post chemo patients, because on the third day they have to check their CBC. So somehow many of maybe got reports from my lab. So now few of the doctors from Pune and Mumbai especially mentioning that bus stand पे उतरो, side में एक lab है वहाँ पे कर दो. So I am happy that in indirect way also I am able to help to this patient, because the post chemo patient का CBC PS is more important for me. And more time with the family you can spend. With this you have more time. I don't spend time because at home also I am using the technologies. But more than that, I use this time to write the 2 books. And now I am taking other classes also, some extra hobbies I can do. So these are the indirect effects with AI we can do. You can use your time. So I told already that it will not replace me, but it will amplify me. So that's AI and my clinical implications. Thank you. I think I have taken more time.
Yes, Dr. Chaitanya, surely you have taken far more time, but surely your talk was very engaging and good. We all listened to you patiently and it was all good. Thank you so much. Yes. Yes, sir. So I would like to ask chairperson to please felicitate Dr. Chaitanya. I request Dr. Sudhakar Hase to please come and felicitate chairpersons. Dr. Sharad Biradar, sir. Thank you, Dr. Sharad, for coming. Sudhakar. We have last talk by Dr. Richa. She is professor in AIMS. Her teaching enthusiasm is really high. She is excellent teacher and her last year's talk was very much appreciated. That will be the best talk of the day for sure. Dr. Rahul Chaudhary, sir. Yes, sir. Doctor from Jungle of Masai Mara, Dr. Kaustubh Sodani, sir. are gifts to your kids. They are missing you on Sunday. Thank you for being here. Dr. Pohekar sir. Pohekar sir, thank you for all the support for Hematology Summit every year. You are part of it and we are really glad that you are here. Thank you so much, sir. Dr. Khatavkar sir, thank you for coming. I know Sunday is always busy because of various social commitments, but you took time out and came for Hematology Summit. Thank you so much, sir. We are really glad to have you here. Maybe we can have a group photo together. Thank you, sir. काळजीपूर्वक. So for last talk, I would like to invite Dr. Richa Juneja. She is professor from AIMS and she'll be talking to us on routine clinical CBC we all do, but advanced parameters in CBC can give us the clue for huge problems. She is very good teacher and we are fortunate that she is here today with us. For this session, to chair, I would like to ask Dr. Rohan Gundre to come forward. Dr. Makresh Yadav is here. Dr. Gitesh Dalvi sir, if he is in auditorium, can you please come? Gitesh Dalvi sir. And Dr. Darshan Mantri sir, if he is there. Yes, please. Gitesh sir बाहेर आहेत वाटतं बोलतो.
Very good afternoon. At the outset, I would like to thank Manoj sir and Shweta ma'am for wonderful organization and entire team of Jeevan Amrut. So since morning we have been listening about hematology. We have heard the complex diseases and the crazy benign and malignant spectrum of this beautiful branch. We have also heard the ray of hope, the advanced therapies which are available. What lies in between these two is the correct diagnosis. And that is something we have to hit. But I'm not going to tell you about something big. What we are seeking or the endeavor for next 30 minutes will be to pick up small clues. Small clues from a very humble and modest test, which you all do, which you all interpret every day. But what more can we get? So what are these newer parameters on the cell counter which can add so much value to our reporting and of course to the patient management. So greetings from Orange City. This is the place where I work, AIMS Nagpur. Previous speaker Chaitanya sir already elaborated the importance of not only AI, digital pathology, but also automation in hematology. And hematology is one of the beautiful diagnostic branches which has seen advances coming very rapidly. We embraced them and we brought them to clinical practice. So this is how I intend to cover the topic. Automation brought a lot of clarity and helped patient by giving more precise, more accurate report. They were rapid, you had very robust quality control system in place, and that is why you were sure what you were calling is indeed what you are calling. So what is novel or newer parameter? In routine practice, as sir mentioned, we usually see hemoglobin TLC, platelet and differential leukocyte count and at the max RBC indices, and that is all. But can we get more than this from our machine? Yes. But is it that every new parameter is novel? Answer is no. Many of them are basically derived or calculated from the routine parameter. The beautiful example of this, which all of you have used in COVID, is NLR, neutrophil lymphocyte ratio. We all went crazy, more than 4, poor prognosis and all of that. And actually instruments capitalize on that. They start giving you NLR directly by calculating the ratio, and it makes your life easy and adds value to the reports. This is just for postgraduate students who are interested in the topic can refer to these articles. This is a summary of all the automated newer parameters on CBC which we are going to discuss over next 20 minutes. So first of all, nucleated red blood cell. All of us have had that one case in our residency, either as a resident of medicine, pediatrics, or as a resident of lab, where we got a call, TLC is 2 lakh, this is leukemia. And when you go, you see the peripheral smear, what you see is 500 NRBC. Right? And it was indeed thalassemia and not the acute leukemia. Why it was happening is initially the machines were not able to differentiate between nucleated red blood cell and lymphocyte. But now those days are gone. We use 5-part, 6-part analyzer. They not only differentiate neutrophil, lymphocyte, monocyte, eosinophil, basophil with precision, but also tell you these notorious cells which are nucleated red blood cell. I'm not going to burden you with the technology behind it. Why? Because every machine will use different, or it will tweak the technology a little bit based on that analyzer. But what we are interested in as a pathologist, you should know your diagnostic armamentarium. If you are having Siemens Advia, you should know how it is counting, what are the pitfalls, where I should report it directly from the machine, where my intervention is required. So then what are the takeaways from this newer parameter? First and foremost important thing, if your machine is capable to give you an RBC count and is giving you TLC, that is indeed a corrected TLC. Please don't do manual correction again. I saw many pathologists doing this. They will have TLC from a machine which is already counting an RBC. They are again doing a PS, correcting that corrected TLC. So you are under-reporting WBC of your patient. So don't do that. WBC is a very crucial value for clinician. They take a lot of actions on it. Other important thing for clinician, the NRBC count from machine is very robust. If you can get that in reports, then start acting on it. You can put it in the correct clinical context and choose the diagnosis, whether your patient is hemolyzing. Can this be sepsis causing some NRBC being pushed in the blood, or it is indeed a leukoerythroblastic blood picture. Other very important addition or value adding parameter from newer cell counters is automated reticulocyte count. We all have had that journey of pathology where we started doing retic, where our professor will tell us use Miller's ocular disc, which none of us even saw in our life. But that retic counting is not really precise and accurate. Every JR will have their learning curve. And you know, when we also get called now, Madam retic kal 0.5 diya tha, aaj machine ka 14 aaya hai, I know from where it comes. Either the processing was faulty or the person seeing it is still not trained to report retic. So solution to this problem is automation in reticulocyte counting. And the important point is it is not only giving you retic count, it is telling you much more. What is that much more? So the machine is basically trying to stain the RBC with the dye which binds to the ribonucleic acid, because that is what is increased in reticulocyte count. And then it calculates the reticulocyte percentage, and amongst those reticulocytes, which are the most immature one. That means the RBCs with highest amount of RNA content, and that is called immature reticulocyte fraction. It adds further value. How? So as sir was saying, somebody got initiated into AI because her megaloblastic anemia was misdiagnosed, right? And the MRI was offered. I'm assuming probably somebody thought of hemolytic anemia, because megaloblastic anemia is the biggest masquerader of hemolytic anemia. Clinically, you will get spleen, you will get high LDH, you will get jaundice, and you will start thinking this patient is hemolytic. But the PS report comes, it has hypersegmented neutrophil, and the retic count is less than 0.5%. So that is the power of reticulocyte count in correct typing of anemia. So the diagnostic importance. Other important thing is it also helps you to see the response to hematinics therapy. It rapidly increases, and amongst retic even IRF will increase faster. Other than that, can we monitor our patients of bone marrow transplant, and even after chemotherapy, when can I expect the recovery? Even retic count and IRF both adds a lot of value in these clinical scenario. Now, can I have more? The answer is yes. Ye dil mange more, and the analyzer gives you more. So you have automation in retic, you have immature reticulocyte fraction. Now this machine is also going to tell you hemoglobin content of these reticulocytes, which is a very good and robust parameter of functional iron deficiency. What is this functional iron deficiency? All quiz aspirants must dwell into this, because this is the state where iron is available but not available for hematopoiesis. So typically seen in inflammation or CKD patients. It is very important to identify this condition. The CKD guidelines for anemia management have given it a lot of cognizance, and they depend on this parameter which I was mentioning, the exact hemoglobin content of reticulocyte, which some machines will call RET-HE, some machines will call CHR. If the value is going less than 30 or 28 picogram, you suspect functional iron deficiency. And how a clinician is going to act on those values? If it is a CKD patient being managed with erythropoietin, giving a shot of IV iron will help the patient with functional iron deficiency over a patient who doesn't have that iron deficiency. So these are the critical decisions, and these parameters are no longer not in clinical practice, they are part of guidelines now. Now, one of my favorite new parameter from CBC analyzer, sometimes exploited by us in lab in emergency hours, is fragmented red cell. What is this FRC? So right from your reticulocyte channel, the machine tells you the RBC which are smaller and have minimal RNA content or no RNA content. So these are fragments of those RBCs. Now why you are using it? Because there is one deadly condition for which you will get call at 12, 2 a.m. in the night. Are there schistocytes, ma'am? Most of the time the call is coming from nephrology because the patient has presented with renal shutdown or creat which is very high. So in this stressful situation, a nephrology consultant calling a junior resident pathology, something has to give her a confidence or him a confidence that indeed schistocytes are absent or present. And this parameter comes handy. If FRC is not increased, it practically excludes the possibility of schistocyte in PS. I would like to again say this, use it with a good negative predictive value. Like you use D-dimer for pulmonary embolism. Dimer is negative, no pulmonary embolism, right? That is how we use in practice. Similarly, FRC. It comes with poor specificity because you are measuring fragments. So your hemoglobinopathy patient, your megaloblastic anemia patient will have fragments. They are not schistocyte. So I will again say what Chaitanya sir was saying. Nobody is going to replace you. Don't worry. We are quite, you have invested yourself to learn what you are learning. So just do that properly, but use your machine wisely. Take as much information it is providing you and give more information in a lesser time point. So this is how FRC is measured. If it is coming less, it excludes the possibility of schistocyte in patient's blood. If it is coming high, you have to do microscopy and give them the correct count. More so, remember the machine's count of FRC is not accurately done. You have to do it on PS and report schistocyte percentage following the ICSH guideline. Now another important thing which I learned recently and I am using it for past 1 year is cold agglutinin disease. We all have had those cases in lab where the technician will call you, madam kuch bhi reading theek nahi aa raha hai. You ask them what is happening, they'll tell you MCV is coming 200, MCH is coming 80, MCHC is coming 90, non-realistic values. And we all know RBCs are clumping, they are counted as 1, that's why these values are spuriously high. But now what this new parameter is adding to it? A simple thing, when we do the automated retic count, the sample automatically gets incubated at 47 degree and it gives you the corrected RBC count post incubation, which you and me were doing for years by incubating the sample at 37 degree for 2 hours. So you need not wait for 2 hours, run your ARC, get your optical RBC, which is indeed a corrected RBC and gives you a confidence that it indeed was a result of cold agglutinin. You measure your retic count at the same go and you can label the case as autoimmune hemolytic anemia, likely cold agglutinin disease. Now, does it add value to my WBC part also? Lot of value there. So initially in our PG days, we used to get a call when the neonate sample will come, madam, we are suspecting sepsis, report band form percentage, right? We all have done that, more than 7% suggestive of sepsis. No more needed in today's practice because your machine is going to count promyelocyte, myelocyte, metamyelocyte together and give you the 6th parameter in your DLC, which is immature granulocyte count. But remember, it will include all 3, not only band forms, but it is very good parameters. It is indicative of sepsis also and myelocytic pathologies also. There are certain other newer parameters for sepsis, monocyte distribution width and neutrophil density index. The quiz aspirants can again follow those parameters. Other new parameter which there has been lot of talk about and we have also studied it in our lab and published the data, it is high fluorescent cell or high fluorescent lymphocyte. So as we know, there is a lot of panic when a dengue patient is admitted in your hospital. The platelets crash, it is 10,000, 15,000, patient is not bleeding. The call whether the platelet will be okay tomorrow, should I transfuse, should I not transfuse platelet. This parameter comes handy, coming absolutely free of cost from your machine and telling you the presence of activated lymphocytes in the patient's blood. And what is the importance of this? Is it only to predict dengue? No. First utility is, of course, when the HFCs increase, you can predict dengue infection over other febrile pathologies. But the other important utility is it is competing with immature platelet fraction to predict the platelet recovery. So when your activated lymphocytes fall, within 24 hours your platelet rise. So you can monitor this HFC and predict platelet recovery in your dengue patient. Malaria flagging, there is a lot of work on this by all CBC analyzers. However, I will still say don't rely on them. You just take them as flags. If malaria is flagged, give more time to that slide. If it is not flagged but the history is there, fever is there, you have to give your time and do the thin smear and thick smear to detect malaria and identify species. Other important parameter where AI is coming big time in hematology analyzer data evaluation is cell population data. So the graphs we just saw coming out of machine, how do they come? Because every WBC of the patient being analyzed is going to be measured for its size, granularity, fluorescence, etc. And based on the value for each parameter, that WBC gets a location on the graph, right? And that is how the machine is going to identify that cell as lymphocyte, neutrophil, monocyte, eosinophil, etc. Now imagine the robust data being generated by analyzing millions of cells. And that is these parameters which are coming out. There are multiple studies which are trying to devise the AI-based algorithm using this cell population data to predict MDS and acute leukemia in sample just using the CBC analyzer data. Other very important tool which was very good value addition to hematology diagnostic was PANDA tool. What was that is Siemens Adve as the machine which not only analyzes the cells in CBC but also measures their peroxidase content. And by detecting the cell with high peroxidase value, it could predict a very deadly leukemia, which was acute promyelocytic leukemia. When I say deadly, I would like to correct myself. Once detected on time, it has amazing prognosis. But the problem is, if you delay the diagnosis, you are at risk of losing patient overnight. So the diagnosis and the urgency to diagnose this condition was very high. So that is how they came up with this PANDA tool. Unfortunately, this analyzer is discontinued. So other than that, where are we moving? Can we have flag of blast? We spoke about it. Can you predict infection using CBC analyzer? You spoke about it. Dengue, malaria, everything. But they are going deeper. They are trying to give you hematopoietic progenitor cell count by your simple CBC machine. The Sysmex has published papers that the HPC count coming from this and the CD34 count coming from flow cytometry has a very good correlation. And that can actually give you an idea what is the right time to harvest the patient. Now we have spoken about RBC, we have spoken about WBC. Now coming to the last portion of our CBC, which is platelet. Is there anything new to the platelet? We use MPV, right? Mean platelet volume. It is still very good. The only problem is if you keep your patient for a longer time, your MPV, PDW are not very reliable. So what do we have to identify these large platelet? So we have something called as immature platelet fraction. What is IPF really? What your retic count mean for RBC? Same IPF mean for platelet. So you are just going to detect the platelet with a higher RNA content, and those fraction are nothing but immature platelet fraction. So this is how it looks like. You have platelets. On the right side, you can see the fluorescent content of the platelet is high because it has higher RNA content, and that is immature platelet fraction. How does it help me in my practice? More than this, predicting dengue platelet recovery, how it helps is to make a correct diagnosis. You have a case of thrombocytopenia. Your main concern is the marrow working? Is it a case of peripheral destruction? There you will have high IPF. Versus is the marrow failing? Is it aplastic anemia? Is it marrow infiltrative disorder? In that case, IPF will be low. So in diagnosis, it helps. And more than that, it will also help you to predict platelet recovery in dengue patient. Because of course, once the thrombocytopenia is worsening, you monitor IPF all along. But I've already said HFC is doing this job equally well, and that comes free of cost. This will require additional cost. So we'll quickly go through 3-4 cases to show you the utility and how we can actually utilize these parameters. So the first case is 14-year-old male with creatinine of 5. As I told you, a lot of calls from nephrology overnight for such patients. TLC is normal, 9.2 with neutrophilic differential. Hemoglobin is crashed though, it is just 6.4 gram per deciliter, and the platelets are also going down, 87,000. If you see the automated retic percent, it is not very high, right? Just 2.6%, but on the higher side of normal. And then what we run is FRC. So meanwhile our PS is also showing us schistocyte, but as I told you, it always gives you a good confidence if you have one more parameter in your kitty, and the FRC came 4%. And then yes, we signed it off as microangiopathic hemolytic anemia with thrombocytopenia. Good news, cell counters give you ARC, and they also give you a screening tool for schistocyte, which is FRC. And these diagnoses are very, very crucial. You really have to make them quick for the patient's kidney to be salvaged. 40-year male with weakness, fatigue and splenomegaly. Here there is leukocytosis. You are seeing it is 15,300. Of course, it is neutrophilic differential. I'm not worried about blast. But what we see here, as I was telling you, along with your eosinophil, basophil, you have one more parameter, which is IG. So as you can see, immature granulocytes are 6.8%. That means there is left shift in the myeloid series. Platelets are preserved. There is mild macrocytic anemia for a male. But what I'm seeing is 6 NRBC. So now it is a red flag. A 40-year male with splenomegaly showing me immature grans and NRBC. I need to see the PS to identify teardrop cells and call it leukoerythroblastic blood picture. So much value your CBC data can provide, and you just have to rapidly look for the particular abnormality in your PS and make a rapid diagnosis. So this is 60-year-old male with backache. And this is how the CBC analyzer data look like. So here again you have leukocytosis, predominantly neutrophilic differential, severe anemia, hemoglobin is just 5.1 and platelet are 46,000. So I just showed you how HFC come like. So do you think this is high fluorescent cell? Do you think it is dengue? What do you think on this graph? The green color population going up. Okay, so we also thought maybe they are just activated lymphocyte, but when we made the PS, it showed many plasma cells. So it was a case of plasma cell leukemia. So again, a point of caution. You cannot blindly take up these parameters. You have differential, you make a smear, you see your morphology, you take a good clinical history, put everything together and make a quick diagnosis. Now this was again from nephrology unit, 40-year-old patient who was getting worked up for renal transplant. Their problem was everyday CBC shows different platelet value and it is low, but within 2 hours your JR from pathology changes the report and now the manual platelet becomes 90,000, 1 lakh. So I told them that let me have a look. We had a PS, it showed us lot of giant platelet. The granularity and all is preserved, but huge platelet in the PS of patient. We told them that this is a typical case of pseudo-thrombocytopenia due to giant platelet, and this giant platelet can be constitutional in many parts of our country like northeast and all, so we have to be very cautious about it. They are functionally fine. But unlike that, what can we contribute as a lab is we told them to send fluorescent platelet or IPF every day instead of routine size-based counting of platelet. Why? Because you are measuring platelet by RNA content and not merely measuring the size of platelet, which will be wrong in such cases. So now we give them more reliable platelet value without much manual intervention, just reporting platelet F or fluorescent platelet, which is representative of manual count. Some of them can be corrected, some of them not. However, the NGS was ordered for this patient for fitness, for transplant, etc. And she showed variant in MYH9 gene. And now she is under regular follow-up undergoing renal transplant. This is, I think, last case, 60-year male with epistaxis. CBC, again, the technician gets worried. Whenever we get CBC, the sample gets quickly clotted. We are not able to get any sensible reports out of it. Then I ask JR, did you see PS? They also say, ma'am, the PS is also a little murky. It doesn't show clearly findings. But no information from machine is an information. How? So I just showed you this case in quiz also. So as you can see in peripheral smear, there is a lot of debris. You cannot see anything clearly. The debris is nothing but the cryoglobulin getting precipitated. So we suspected cryoglobulin, did the testing for that. As you can see, you can invert the tube, nothing is falling. Why? Because it is having all the protein which gets precipitated at colder temperatures. The bone marrow was done. It showed Waldenstrom macroglobulinemia with IgM, kappa being monoclonal protein. Her coagulation also got deranged, but it was again falsely deranged because of cryoglobulin protein. So summary, new parameters look very attractive. They are indeed very useful. However, when utilized appropriately, they provide supportive evidence in making better decisions in lab and of course fastening the diagnosis and providing better clinical management. Standardization across the various CBC platform is a challenge. Many are for research purpose only, but the lab can use them judiciously. Additional cost for some parameters is there when we use special reagent. For example, automated retic, IPF, they come at a cost. All flag mandate necessary microscopic examination, so nothing of replacement sort, just adding value. Both IQ controls and external quality assurance program for all the parameters are not available. So that was all on newer parameters. This is our team at AIIMS Nagpur. Sincere thanks for patient listening.
Excellent talk, Dr. Richa. It was fantastic. It is saying that more you know, better you present. She's like, she knows everything about hematopathology, but such a small investigation, CBC, we all do. And to dwell into details of CBC, no one better than her to teach us about the CBC. Thank you so much for being here. Thank you so much for such a lucid presentation. Any questions from the auditorium? I know we all are hungry, but any questions are there? You can ask. Chairperson, any comment, question? Gitesh sir, any question?
Actually, I really don't think after this presentation we will have any sort of question, but I have a suggestion. For reading all the analyzer reports, we really need hematologists like Dr. Richa, who can give us all sort of insights regarding the patient's present clinical condition as well as the patient's prognostications regarding his or her disease. Thank you, ma'am, for enlightening us with the smallest and what I can say very tiny terminologies, which we as a physician will look it, but we'll try to ignore it because we really don't feel these minute details are useful for the patient's clinical betterment. Thank you. Thank you very much.
Thank you.
I request all the chairperson, please be on dais to felicitate Dr. Richa. One question is there from Dr. Pawar.
So Menzer index, yes, we all use it for differentiating iron deficiency anemia from thalassemia trait. I used to rely it more when I was practicing in Delhi at AIIMS and BLK because their thalassemia trait proportion is very high and IDA is relatively less common. The moment I moved to Nagpur, I realized that most of our patients with thalassemia trait also have iron deficiency. And the deficiency of Menzer index is, one, it is not validated for pregnant women. Second, it is not validated for coexisting pathology like iron deficiency with thalassemia trait. Third, we have lot of burden of alpha thalassemia in this Vidarbha region, right? So that is why here you can straightforward not use Menzer and say that it is beta thal trait, but of course we use it, but we don't advise only based on that. We do advise serum iron study and HPLC. But many analyzers are giving that value also, Menzer index. Yeah.
Thank you so much. Chairperson, please be on dais. I request Dr. Nalini Jadhav madam to come to felicitate chairpersons, please. Dr. Rohan, Dr. Makresh Yadav sir. Dr. Makresh Yadav. Thank you, Makresh, on Sunday for being with us. Thank you so much. Dr. Gitesh Dalvi, sir. Dr. Gitesh Dalvi, sir. He is consultant physician from Gajanan Hospital. He is guide to me for everything, like elder brother. Thank you so much, Gitesh sir, for being here. Dr. Rohan Gundre, sir. Thank you, Rohan, for being back to Aurangabad from Pune, and he is good asset to our physician association as an intensivist. Thank you so much. And Dr. Darshan Mantri, sir. Thank you for being here, Darshan, for this today's session. Thank you everyone on the dais for being here. Thank you so much. Thank you everyone in the auditorium for being available for today's Jeevan Amrut Haematology Summit. We will break for lunch. Lunch is there in the hall, which is just in the basement floor of this fund. And within 15 minutes after finishing the lunch, we will be here for the final quiz, which we will be announcing the results of screening round followed by the quiz. Quiz is very, very interesting. I request those who have time after lunch, please be available for the quiz. It will be surely worth taking time out and learning hematology through the question and answer. Thank you so much for being here. Thank you.
Thank you everyone for attending this Jeevan Amrut Haematology Summit. On behalf of IMA Chhatrapati Sambhajinagar, I really want to thank all of you. Our President and Secretary are not present here due to one important program, which is IMA Aao Gaon Chale program. So, on behalf of our President and Secretary, I thank Dr. Manoj sir for conducting such a wonderful academic session. Even though it is Sunday, the full house itself gives us the idea how much people are liking such programs. And thank you once again for inviting us. Thank you.
Thank you. Thank you everyone.